بسم الله الرحمن الرحيم. أهلا ومرحبا بكم في بداية هذا الكورس. Welcome everybody to the beginning of our course. Go ahead, chairs.
Assalamu alaikum. Good morning, everyone. In this session, we will delve into fundamental yet essential respiratory topics with distinguished speakers from across the globe who are leaders in their field. So with no further ado, let's welcome our first speaker, Dr. Brady Scott, an associate professor and program director of respiratory care at Rush University in Chicago. With his extensive background in clinical education and research for approximately 20 years. Am I correct? Dr. Scott will be presenting on the essential topic of respiratory system anatomy and physiology, providing a foundational insight crucial to respiratory care services and care. The mic is yours.
Thank you so much for having me. To say it's an honor to be here is an understatement. Perhaps my favorite part of being here is I recognize some people in the face that were some of my students. So thank you. I get the honor of basically reviewing a lot of things that you probably already know. And here's my little bit of wisdom I'd like to share with you. And somebody taught me this a long time ago, is you cannot learn enough physiology. If you think you know it well now, do me a favor, go learn a little bit more. And as you think you're really good at it, go learn a little bit more, and you'll realize you'll never learn enough. So I teach this course, and I feel like every semester I pick up just a little bit more that helps me with my patients. So let's get started. So these objectives are in your textbook, so I'm not going to go through those because I'm on time, or I have been told by Hassan many, many times I have to be on time and I have to get off stage fast. So I'm not going to go over my objectives with you. So let's talk about the whole purpose of the lungs. So yes, we're going to start a 2-day course over what is the purpose of the lungs. Simply stated, it's to bring atmospheric gases in contact with the blood. And we know that the atmospheric gases that we want to have contact with the blood has oxygen in it. And everybody in this room knows that it's at about 21%. And ventilation, for the purposes of today's definition, will just be this bulk movement of gas flow back and forth. It's the movement of gas in and out of the lungs. In this process or concept of respiration, although the media seems to get it wrong, when you watch at least the U.S. media, they call ventilators respirators and these things. But we know that we have 2 different kinds of respiration. We have between air in the lungs and the blood, that's external respiration, and between the capillaries and the tissues. And so I get to teach folks that have never had respiratory training, right? I get to have those brand new students that know we have lungs, but they're not sure what they do, right? And I have to tell them that in reality, the process of breathing can break down at any portion, right? It can break down between getting air into the lungs and the blood, which we think of, and it can also break down between the capillaries and the tissues. And any part of that breaking down is going to create a situation where the cells don't do well, the cells may die. So when you think about being a respiratory therapist, I'm going to ask you to think beyond just getting oxygen into the bloodstream, but about how we can think about getting oxygen from the bloodstream over to the tissues and how important that is. Okay, back to very basic anatomy. So some of the anatomical concepts that I'm going to cover here are the conducting airways. Remember, the conducting airways are the pipelines. They're just moving the gas. They're moving it from the atmosphere into where gas exchange occurs. And we know although they give us a lot of problems, right? The conducting airways can give us a whole lot of problems, and we're all the time doing things to clear them, open them up. There's no gas exchange there. So they're little more than just pathways of air to move. But I also tell my students, for those of you that are educators, just because there's no gas exchange doesn't mean they're not important. In fact, they give us a lot of trouble, as we know, right? So here's just some of the images that are from the book. Again, I realize, I know this is very basic, but again, getting everybody on the same page. Something I have to emphasize a lot with my students is we think as respiratory clinicians of upper respiratory tract issues. We have lower respiratory tract issues. And I spent many of my years working in an emergency department environment where the upper respiratory tract was a problem in some of our children, and then also I had some lower respiratory tract issues. And we know that we can go from the mouth and nose all the way down into the lungs, and we just keep moving and moving and moving through various pathways all the way down finally to where the magic occurs, which is we have gas exchange. And we're going to jump into that just a little bit more. And tomorrow morning, I'm having some of my students label this because I want to make sure they know it, that literally I'm giving this exam tomorrow. I'm not even joking. Don't tell them it's on the exam if you see them. But we know that we come all the way down into this area here where this respiratory zone here, where we have some smooth muscle that kind of starts to develop into areas of gas exchange and alveolar proliferation and where they grow. And we have the pores of Kohn and canals of Lambert here that create some collateral ventilation. And we know here, down in this area here is, again, where the gas exchange occurs. But again, I want to make sure that we put a tremendous amount of value on those conducting airways and keeping them clear. And then we get all the way down to the level of the type 1, type 2, and even what we call type 3 alveolar cells. And we know that the type 1 cells are just simply the cell basically create the alveolar, the alveoli. And then we have those very important type 2 alveolar cells. Who are my neonatal pediatric respiratory therapists in the room? So, very few. Okay, mostly adults. Nobody wants you to think I'm going to ask you a question is the problem, right? So don't worry, it's too early for me to do that. So we know that the type 2 alveolar cells are particularly important because they're the surfactant-producing cells, right? I am the father of a 9-year-old little girl, and she was born early. She was born 9 weeks early, so right at 33 weeks. And so my concern was for her lung development, surfactant development, and all those things. And I'm happy to tell you now that she is a state champion in Taekwondo, and she's very healthy, and I'm a blessed father. So again, we get down. We also have these alveolar macrophages here that help clean things up, and we know that we have these airway defense systems that keep our lungs clean all the way from nasal hairs down to the alveolar macrophage. And then I know that we get to forget about this a lot, but let's talk about, how important it is to have this mucus blanket in the lungs. We have this mucus blanket in the lungs. We have those very important cilia that are constantly moving back and forth in the gel layer and the soul layer. And we know that this is also part of this process of keeping our lungs clear of things that don't need to be there. And when we do things, even anesthesia or smoking or those things that kind of limit the cilia, mucociliary transport system, this can cause problems for a patient. And our airways change. We have the pseudostratified columnar epithelium and those things that move down. And when we get down here to the alveolar level, we lose some of this stuff. We lose the smooth muscle, get down here to the level of the capillaries and the alveoli. So again, we're thinking we're moving from the nose, the mouth, all the way down to the amount of alveoli. And honestly, I've never counted them myself, unless you have. Tell me otherwise. Textbooks tell me we have about 300 million alveoli, at least. I don't know if that's correct. I've never sat and counted them myself. I don't know, Keith, if you've ever done that, but it seems a bit laborious. But there are a lot of them. So we know that as the airway goes from our big open mouths and nose all the way down to the capillaries, things get very small, and resistance changes, and those things occur over time. Now, this is just, very basic for everybody in the room. But what I like to point out here are a few important things and maybe some descriptions as to why. So, when we look at our chest films, we look at x-rays, and sometimes you can see that the right hemodiaphragm is more elevated than the left. So this is anatomical in nature. And so there's a little bit of debate as to why. I know that I like to teach it's because the liver, and then a pulmonary physician friend of mine likes to teach it's because the heart pushes down the left. And the current textbook that I teach says both, so I like that one. So again, I'm not sure who's right. I leave the anatomist to tell me what it actually is. But I think one of the most important things for those of you that might be new into the profession, new into respiratory care, even as a physician, nurse, or respiratory therapist, which I believe is mostly in the room, is we have to keep in mind that the lungs are sitting inside of a cage, right? The cage is helpful. It provides structure. But we have to think about that when positive pressure is being applied. It just doesn't keep going and going and going, and how the thoracic cage may impact our breathing and things along the way. And of course, everybody likes this type of picture. It's one of the pictures when you're first an RT student, you look at it for 20 minutes and you're like, what is this even telling me here? But really at the end of the day, it's to basically make sure that you remember and thinking about how important that pleural space is and where it is. And it sits in here between, you have the visceral and parietal pleura. And we know that the space in between there is a space. It is a nice space to have. It's good, has a function. But sometimes can cause problems. And also we have to be thinking about the pressures that exist in this area. So again, this is just some text that goes back to some of those photos. The thorax, we think about the rib cage and the intercostal muscles, the vertebrae, the sternum, and the diaphragm. A lot goes on inside the chest, right? A lot goes on. So a competent respiratory therapist has to think about the interplay of the anatomical structures around the lungs in order to try to best understand what might be going on. So I'm going to fast forward us a little bit, but we all know, or a lot of us know, that when you're looking at a ventilator and the peak pressure is high or the plateau pressure is elevated, sometimes we're not exactly sure what it is. Is it the lungs? Is it the chest wall? How do these structures affect us, if at all? And this is an image that I'm not really sure how helpful it is right now since I've already talked about it. But again, with my own students, and I know there's educators in the room, with my own students, I really try to emphasize the reality that our lungs are inside of a cage. And this cage is going to affect us. It's going to change our pressures. It's going to change how we interpret what's happening at the bedside, even through something as simple as mechanical ventilation. So when I started this talk, I mentioned we can't know enough physiology. Well, understanding physiology well helps with understanding patient assessment well, which helps understanding mechanical ventilation well. And sometimes we have to think about the impact of just the chest wall itself on what we're seeing on the ventilator as the path to move forward. And I think there will be some mention over the next couple of days of things like esophageal manometry and stuff to try to understand the difference in what's happening around the chest or the chest wall and the lungs themselves. Got to give some attention here to the diaphragm, as we know that the diaphragm is an extremely important, it's our major muscle of breathing. But I also want to give some attention here to things like the external and internal intercostals and their importance of playing when somebody's having, maybe a high increase in airway resistance or a decrease in compliance. And I also want to focus on, sometimes I think, at least in my opinion or observations, we ought to make sure that we give some attention to the accessory muscles that exist on expiration as well. So we think about accessory muscle use. Even myself, I catch myself in the classroom trying to show my students what that might look like when they're in their first few semesters of school, and I'm trying to show them accessory muscle use, and I'm not great at it, to be honest with you. I'm not a good actor. I try my best. My students that are in the room can tell you, I try, but it's not a great, so acting is not my thing. But we also need to focus on the reality. They have expiratory muscles as well that are involved in expiration. So somebody who's having a hard time out will recruit, if you will, the expiratory muscles, the abdominal muscles that will help them on that side. So again, inspiratory accessory muscles, sure, it's what I try to pretend a lot in class, but I got to make sure I understand the students know that we have expiratory muscles, accessory muscles as well. And we know that our accessory muscles are generally quiet, during a normal lung mechanics and normal resistance and normal compliance. And we know that they're normally inactive during quiet expiration. The accessory muscles of expiration are. And when we think about the resistance, if you will, I don't love that language. I thought about that before. But you think about, when we think about lung inflation, right? We think about the airway resistance. I think that's a bit more common language that respiratory therapists use, is airway resistance itself. But we also think about elastance. Sorry, I'll spit that out in a second. And so those two things are what creates the amount of work that we're having to overcome over time. Luckily, everybody in this room has the ability to overcome the amount of work that's being imposed on you. Everybody. We're all lucky right now that there are, yeah, of course we have some resistance. Of course we have some degree of lung compliance, or we have some elastance that we're dealing with, but we're all able to overcome them with the strength and the muscles that we have. It's not until these things exceed what we can do that we start having problems. We start having problems, okay? And just a quick reminder here, I will tell you that I'll rewind myself probably 25 years. I think you pointed out I've been doing this for a couple decades now. This type of concept was really confusing to me. Didn't really understand it, right? But to simplify it, you have things, you look at airway pressures versus alveolar pressures with the P big A, and the gradients there are just simply what creates the gas motion, right? Flow occurs because pressure gradients are different. When the pressure gradient's there, you get movement. So I think sometimes I wish I had ChatGPT back in 25 years ago where I could ask ChatGPT, please take this slide and make it simple for me, right? If you didn't know it, we'll do that for you. But we know that another thing that's very important here is the transpulmonary pressure, and this is what we call the distending pressure, and it's getting more and more attention these days and more conversation because we're trying to understand the importance of the transpulmonary pressure. And I'm going to speed up just a little bit so I'm not late. But very important here just to make sure we understand how the pressures change in our chest over time. Again, thinking about our chest wall, thinking about the lungs themselves and the interplay of our pleural space. Here you have a patient who's spontaneously breathing, and so they take the breath, and the pleural space will go a bit, the pleural space will go a bit negative, and they will still, and you see the airway pressure 0, and they'll draw in this breath, they'll get a tidal volume of 500. But that's not who we're seeing a lot. A lot of us work in adult acute care. We'll see where we reverse this. So the pleural pressures are going to change. The pressure that's inside the parietal and visceral pleural, in between there, the pleural space, you still get a tidal volume, but this changes completely. So the direction of gas flow will change. It's, I would say, for lack of better words, it's not the natural way for us to breathe. It's different. So the pressures are going to switch. And that's an important thing to understand. Also, just as a reminder, in this example here, this is just simply part of anatomy physiology to get everybody on the same page, nothing you haven't seen before. But we know that we can use spirometry and other ways to measure our lung volumes. You know, we have the body box where we can measure all of the lung volumes. And remember that you have the volumes themselves, and when you combine volumes, you have capacities. And the one we can't measure using like spirometry is our residual volume, right? This one down here. It takes a little extra work inside of a pulmonary function lab. But here we are on average. You know, sometimes this says tidal volumes of 500, but we know that everybody in this room has their own tidal volume, right? Tidal volume's around 500 or so. You take the big deep breath, that's part of your inspiratory reserve volume, add those together, it's your inspiratory capacity. Add your inspiratory capacity with your tidal volume and your functional residual capacity, you have your vital capacity. And add it all together, subtract the residual volume. Again, will be vital capacity, but when you include the residual volume, that becomes your TLC. And again, these are all guesstimations of numbers of 5,800 milliliters. So real quick, just so I can make sure that we're on time again, real quick concepts of reviewing. And I'm going to ask you something here, is I would like for you to think about the idea of minute ventilation, which you know frequency times volume, versus alveolar ventilation. Very important. What's the difference? Dead space, right? So we got to take that with us to the bedside. Always keeping in mind the amount of dead space we're dealing with, right? So it's the volume of air entering the alveoli. So we have minute ventilation, again, easy, frequency times tidal volume. And then you have alveolar ventilation. That's really important in terms of gas exchange, all right? Also, keep in mind that in reality, in respiratory physiology, that hypoventilation and hyperventilation has specific definitions. Hyperventilation does not equal tachypnea. It does not equal fast respiratory rate. It has its own specific definition. So, you know, before we became respiratory practitioners, when we saw somebody breathing fast, we would say, oh, I'm hyperventilating. To the RT, you're like, I don't know that's for sure. I have to have a blood gas to know that, right? Because we know that hyperventilation is when you outpace the CO2's body production. And you have a decrease in PaCO2. And some people even define it specifically as a CO2 of less than 35 millimeters of mercury. Hypoventilation is the reverse. It's when ventilation is inadequate. All right, real quick on this. I thought, what am I going to show a bunch of respiratory clinicians about this busy slide deck? Real simple. Just keep in mind that we leave the left ventricle out to the aorta at 120/80, higher pressure system. We come back relatively low, right? Relatively low pressures, which is why we have some issues when we're mechanically ventilating people and we start changing some of those chest pressures, and we'll talk more about this today. It's why it may have some impact on your blood pressure. I'm going to speed up just a bit. Everybody in my workshop tomorrow, we're having a quiz on all of these. I'm kidding. There's no quiz. I'm just joking. But I believe it's important to understand some of these concepts, if nothing else, that some of your coronary arteries come right off of the aortic valve when it closes. All right? One of my favorite topics in the world is the electrical system of the heart. I love it. I love to talk about it. I love to watch EKGs move and all this happen. Keep in mind, we're going from our sinoatrial node, which is your major pacemaker, moving all the way down into your AV node, AV bundle, going all the way out, and that's how we're creating it. Again, I'm going to speed up just a little bit because I want to hit some major points. Cardiac output, love hemodynamics, one of my favorite topics. Stroke volume times heart rate. What's stroke volume? Preload, afterload, contractility. Take away either one of those, can't have output, right? Your heart can pump perfectly fine. You can have perfect afterload of resistance. You have no blood, no preload, no blood pressure, no output, right? The opposite. You can have perfect preload, fluid's fine, volume's fine. Afterload, for what it's worth, normal. No contractility in the heart, output goes. And that's how we treat it at the bedside. When we see somebody with low blood pressure, when we see somebody with low cardiac output, we got to think pharmacologically, how do we treat this issue? Could it just be fluid? Is it just fluid from dehydration or something like that, or so on and so forth? All right, probably another one of my favorite things. If you can't tell, I really like physiology. So again, we have this oxyhemoglobin dissociation or equilibrium curve. When we think about ideas, or right around 90% on an SaO2, we have a PO2 of right around 60. That rule applies pretty well until it shifts one way or the other based on acidosis or changes in temperature. And we know that this changes how much the hemoglobin and oxygen care for each other, right? So sometimes it drops oxygen off to the tissues a bit more. Sometimes it holds it back depending on the shift. And I got about 3.5 minutes, and this is something that, so I'm going to admit to you, I probably shouldn't. I don't like math. I get good grades in it, but I don't care for it that much. So I don't walk around all the time doing algebraic equations in my head, just when I have to. But this is one of the few things that I can remember off the top of my head because I really understand its importance. And that's O2 content. Because O2 content equation is hemoglobin times 1.34 times SaO2 plus PaO2 times 0.003. If I can walk around with that, it means it has a purpose. Because after you think about the content of oxygen that's in your blood, you have to have the hemoglobin. We know what hemoglobin does. And this is the constant. This is how much oxygen it can hold. And this is your saturation. Look how much that side of the equation matters. Look how much that side of the equation of O2 content matters. The saturation matters a lot. The amount of hemoglobin that we have matters a lot. Look at this side. PaO2 times 0.003, right? The difference between SaO2, saturation of hemoglobin, PaO2, what's dissolved in the plasma, right? All are important, of course, but this is one thing I'd really like for you to start to get to better understand, because honestly, looking at that hemoglobin is important. Because in factors to have O2 delivery, what do we have to have? To deliver oxygen to the body, you have to have a saturation that's good. Your PaO2 has to be good, which determines your O2 content. And then it doesn't matter how good we put oxygen into the bloodstream, it has to move, right? It has to move to the systems. And we have to have cardiac output, right? If we had cardiac output but low oxygen, it doesn't matter. We have to have all of it. And that's what I try so hard to have my students understand. We have to care deeply about all of this in order to get oxygen to the cells the way that it needs to be. All right? I think I'm down to 1 minute here, so I'm going to go a little bit past a little bit of the chemistry here. But you can see that the CO2 hydration reaction is there where you have carbonic acid that will this whole reaction actually moves back and forth. And basically what we see is when we hypoventilate, you have an increase in CO2, you have an increase in PaCO2, the little a here being arterial, and this hydration reaction shifts right. And when we have this hydration reaction that shifts right, it simply means that we're going to end up with higher blood acid levels. And then biochemically again, when we hyperventilate CO2, this hydration reaction shifts the other direction. And this is when CO2 elimination momentarily exceeds CO2 production, which ultimately ends blood acid levels. All right? So I usually take an entire semester to teach everything we just did in 25 minutes. So thank you very much for your time. And it's been my pleasure to start this with you, and I look forward to seeing you again later today. I have 25 seconds left.
Well, thank you very much.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning all. Welcome to this session. I'm pleased to introduce the next speaker, Dr. Keith Lamb. He is an RRT from Trauma Surgery and Neurological Service, Respiratory Therapy Services, University of Virginia Medical Center, Virginia, USA. Keith's primary interest in critically ill patients, and to be specific, he is interested in current practice and strategies regarding ARDS. The stage is yours. Thank you so much.
There's literally one button you have to push, and I couldn't find it. I always love to follow my good friend Brady Scott, because invariably he goes over stuff that I'm supposed to go over, and so that leaves me a little extra time to get through my presentation. So Dr. Scott covered a lot of the anatomy and physiology, which is, I don't want to use the term straightforward, but you read your textbook, you look at the numbers, and that's what it is. It hasn't changed in a very long time. We're going to talk about physical assessment, which involves a lot of subjective approach. Okay. This is in your textbook, so I'm not going to take a lot of time going over those things. We'll jump right into your preparation for the encounter of evaluating your patient, which the clinician's job is to have effective communication, to be able to listen, to be able to empathize with the patient, understand their pain, understand their discomfort, and to have good confidentiality, understand and use nonverbal communication if needed, and verbal communication. Also, it's never been more important to have good hygiene, infection control, hand hygiene, personal protective equipment, etc. So these are really the key topics that you should focus on and approach when you're doing a patient assessment. You need to know what their chief complaint is, and you see all of this stuff is in your textbook. But I think it's important to remember that the chief complaint, why is the patient in the hospital? Why have you been asked to evaluate that patient? What are their issues? It's important to know demographics. It's important to understand if I had to pick one or two of those things that I think are the most important. BMI is difficult to manage a critically ill patient that has a really high BMI. Occupational history may give you some clues as to whether or not they've been exposed to certain substances or other things that could irritate their lungs and cause them to have a chronic or an acute on chronic condition. You have to know what their past medical history is so that you simply understand whether or not this is an acute issue or is this something that has been sort of managed for a long time, or a chronic problem that has not been managed for a very long time, and maybe we're just now trying to figure out what that is. So smoking history, medications, allergies, et cetera, are very important. Family history, some things are hereditary that we take care of. Some of the diseases that we help support and try to treat are hereditary. And so family history, sometimes economic history may play a big part. Where do they live now? Do they live at home by themselves? Do they live with other folks? Do they have certain everyday living sort of assistance with hearing aids, glasses, walkers, et cetera? CPAP. Cough. So everything that we talk about with a patient assessment, or at least most of the things, the great majority of things that we talk about with patient assessment fall under the category of either being a sign or a symptom. It's important to understand that a sign is something that you can objectively evaluate. It's something you can count. It's something that you can put a number to, quantitative information. And a symptom would be something that's more subjective that the patient has. So heart rate is a sign, pain, et cetera, are symptoms. Cough can be either one, really, right? You can, the patient can tell you I have a cough, or you can see them cough. So it can be subjective or objective. Either way, it's a sign of something that's not right in the airways, right? It can either be due to reactive airway disease, which is a common kind of patient that we take care of, whether or not they're a chronic obstructive pulmonary disease patient or asthmatic. It could be a GI symptom, that they have chronic reflux at night, and so they sort of microaspirate, acid, stomach acid, and that causes them cough. Or it could be a sign of infection, either acute or chronic. A chronic COPD patient normally wakes up. If you talk to a COPD patient at the bedside, sir, do you usually cough and cough stuff up first thing in the morning when you wake up? Yes, that's very common, right? But it also could be an acute infectious process, and that's something that we all try to help and assist in sort of sorting that stuff out. Chronic diseases like CF, cystic fibrosis, or bronchiectasis, where patients have hyperproduction of mucus. The viscosity and the color sometimes can be helpful in terms of trying to sort things out, whether or not they may be infectious or they're not. The modified Borg score is sort of a way of sort of measuring dyspnea. It's probably not used that often by the bedside clinician. You don't spend a lot of time trying to calculate scores of dyspnea, but it could be useful. Different kinds of chest pain. Chest pain can be cardiac etiology. It can be pulmonary chest pain like pleurisy, or it could be musculoskeletal chest pain. Cardiopulmonary signs and symptoms. So a sign or a symptom, a headache. What is a headache? We're going to have a test about this tomorrow also. Just kidding. Also, I wanted to tell Brady that I did actually one time try to count alveoli because I really didn't believe the couple 100 million theory, but I got interrupted. When you get interrupted when you're counting something, it's hard to get started again. So headaches could be a sign or symptom of what? It could be hypercarbia, acute or chronic hypercarbia. It could be a patient that doesn't sleep well, doesn't get through all of the sleep cycles appropriately. Fevers, chills, and night sweats could be signs of infection. Most often, dizziness and syncopal episodes are sort of like fainting episodes. How often do they occur? And these can be caused by decreased cerebral perfusion, obstructive physiology, pulmonary or cerebral embolism, et cetera. So vital signs, these are things that you measure. A respiratory rate, there are shortcuts. You can count for 30 seconds, multiply by 2, but if you're trying to evaluate for an irregularity, it's more efficacious to count for, to evaluate for a longer period of time. Pulse, we all do this. We all evaluate the radial pulse. We all should be experts at evaluating for a radial pulse. And there are abnormal pulses. You're evaluating for either a regular rhythm and rate or irregular rhythm and rate, and then trying to figure out why somebody might have that. Blood pressure is a very important vital sign to evaluate for many different sorts of abnormalities, either cardiac in nature or shock, et cetera. And we should all be familiar with how to. I will have to admit, I haven't taken a manual blood pressure in quite a long time. But you should still try to remember how to do it, because guess what? The automatic ones don't always work. The arterial lines aren't always as reliable as we would like for them to be. So it's important to understand how to do that. So respiratory patterns, we should be experts in this. Bradypnea is my favorite word, and when I'm in rounds and I say the patient's bradypnic, and everybody looks at me like I've got 3 heads, and they don't quite understand it, but it's a slow respiratory rate, right? Normal in every other way, except it's just slow. Tachypnea, and apnea, of course, maybe the most important one, because you really need to figure out what the causative nature is of that. And those things can be, in my world, in the trauma world, it can be cause of a brain injury. It can be caused by too many opioids, et cetera. Brady talked a little bit about adjunct accessory muscle use, and we know that the same COPD patient that we talked about earlier about sort of having hyperactive mucosal glands and mucus production, they also may breathe like this person with the pursed lips, where they're trying to cause back pressure to keep airways open and reduce the obstruction. And we see patients with sternocleidomastoid usage in scalene muscles, intercostal muscles, et cetera, and these are all signs that a patient's unable to keep up with the work, or they're having to work harder to keep up with the respiratory cycle. Tripoding also, for somebody who's acutely dyspneic, is also a sign. I'm sure that we've all seen that. Your evaluation of thorax, many things can impinge on the patient's ability to breathe, and some of them are chronic, like abnormal thorax anatomy, like kyphosis or scoliosis. And I mentioned earlier BMI, that's something that also can impinge on your respiratory cycle. Being able to lay hands on patients and evaluate for dysynchronous or asynchronous chest wall movement. Lots of words on here, and it's all in your book, so I'm not going to go over this. This is a very busy slide, but being able to the most important part is to be able to understand the etiology of the abnormal breath sounds, right? If you have fine crackles, many of us are old enough that we used to call these rails, but you know what they sound like, and you should know that the etiology of that most oftentimes is either atelectasis or alveolar edema, right? Something in the alveolus that's causing that sound. All the way through, wheezing or upper airway. Again, upper airway stridor is something that I see a lot of in my surgical trauma ICU. Wheezes, reactive airway disease. The most important thing is to understand what the potential etiologies, the differential is. Also don't do this much at the bedside anymore, but understanding when you evaluate for with percussion approach, that if there's increased resonance or hyperresonance, there's probably extra gas in that space, extra air, and dull percussion probably means that there's less, that there's some sort of consolidation there. We talked about how abdominal, something's going on with the abdomen. In this case, this person's expecting, and that can take up space and reduce lung excursion, diaphragm excursion. Understanding with the peripheral evaluation of extremities, what that might mean for chronic pulmonary disease. So Brady talked a lot about cardiac physiology, or at least touched on most things that we need to focus on in this course. So understanding that there are ways of evaluating perfusion, peripheral perfusion, and that primary easiest way is to evaluate for capillary refill. And if you have reduced capillary refill, then that's a sign of systemic shock or hypotension. So Brady's chapter goes into a great bit of depth on the cardiac physiology, but I think that it's important for us to understand as the bedside clinician the effect that different dysrhythmias have on the pulmonary system and the cardiopulmonary system in general. And these things, sinus tach is just a normal rhythm that's fast. Sinus bradycardia is a normal rhythm that's slow. But the really important ones that reduce cardiac output are important for us to know, because if you reduce cardiac output, like Brady so eloquently stated and showed you, that has a profound effect on the system in general. All the dysrhythmias here, fast, slow, etc. Of course, as you go down, you get to the ones that probably affect cardiac output the most, and those would be the ventricular dysrhythmias. And this is really getting granular with the cardiac physiology that you'll hear other people talk about. Neurologic assessment is important because so many neurologic abnormalities also affect the cardiopulmonary system, and it's easy to sort of evaluate with the GCS. The GCS was initially developed to evaluate trauma patients that had brain injuries. We've sort of extrapolated that to anybody that has abnormal neurologic function to some extent now, but it's important to understand that if a person has passed away, their GCS is still 3. Like, that's the lowest and the worst that you can get, and a 15 is what most of us are now. I'm about a 13 until I get to my second cup of coffee. The RAS score has really become important over the last several years, because we now understand how important it is to not over-sedate patients. We now understand that particularly benzodiazepines that cause ICU delirium and extend ICU days, extend hospital days, worsen outcomes. So it's important, and in general, I can't speak for everybody, but we like people to be a -1 or so. Other neurologic assessment and examination categories: mental status. Are they oriented to person, place, and time? Do they have really low GCS? Do they have low GCS and not a low enough GCS that they cannot protect their airway, and so do they need to be intubated and to be placed on a ventilator? Pupillary response. Again, we have issues sometimes with over narcotizing patients, and a sign of that is pinpoint hemorrhage, or we have drug abusers that come in, and that's a sort of way to evaluate for that. And do they have intact airway reflexes? BMP, basic metabolic panel. It's important because so many of these electrolytes are important for cardiac function and basic muscle function, glucose, fats. Important to understand that somebody's neurostatus may be contingent on what their glucose level is. I've been to many rapid response team activations where person's unconscious and their glucose is 30. So Very important because that's an easy fix. You know, some of these things are not so easily fixed, but that is. Important to understand how to look at labs and sort of evaluate whether or not somebody may have an acute infection or chronic problem. Look at the different gram stain, et cetera, to understand what the appropriate antibiotic is to use. Your antibiotic stewards where you work will be on you about not using an antibiotic that's inappropriate. Important to understand troponin and other cardiac and muscle damage. You know, troponin is good for MI. CK is good for somebody who might be in rhabdomyolysis and may have been unresponsive and in their on the floor of their restroom at home for a couple of days. CBCs, we're all familiar with the basic normal and abnormal lab values here. Again, it's all in your textbook, but it's important to know that you can get a lot out of some of these quantitative evaluations. Blood gases, this has gone over very well in your textbook. Alkalosis, acidosis, et cetera. We know that we quantify and evaluate gas exchange by looking at PO2, SO2, and PCO2. Brady went over this very well too. This is what I mean by thank you, Dr. Scott. I don't have to talk about this because this isn't something that's in my wheelhouse that much anyway, so I won't. Flow volume loops, also not my wheelhouse, but it's important to understand, at least understand the relationship between flow and volume so that you can fairly easily evaluate whether or not somebody has a restrictive disorder or obstructive disorder. Understanding images, AP chest x-ray is the standard, the approach from the anterior posterior. So this is the kind that we most often get in the ICU. Understanding CTA or CTPAs to rule out pulmonary embolism, and obviously you should be acutely aware that POCUS or point of care ultrasound has become very popular around the world today, and is very useful for evaluating for some of these abnormalities. A bronchoscopy, looking for obstructions, looking for compressions, extraluminal compression of the airways, evaluating for mucus plugs and treating mucus plugging. Transbronchial evaluation of lymph nodes for cancer using EBUS. This is sort of complex, but many centers are doing this now. Evaluating whether or not somebody has sleep disorders is an important part of our profession, and so looking at even if they're in the critical care unit, understanding whether or not they need to be treated with nocturnal positive pressure. Before they go home, evaluating what kind of situation they are at home, whether or not what kind of extra equipment or extra people coming out to see them, equipment upkeep. Looking at all these, we should be experts in understanding obstructive, restrictive, infectious, vascular, and maybe not cancer, but certainly understanding what the presentation for some of these things would be. So, also your key concepts are in your book, so I won't go over all of these either. Thank you very much.
Thanks, Dr. Keith, for presenting this essential topic.
Thank you, Keith, and welcome to those who just joined us. Our next speaker is Dr. Noel Tiburcio. Dr. Noel is the head of the Respiratory Therapy Department at Trinity University of Asia in Philippines. Dr. Noel will cover the oxygen therapy and discussing the vital role of oxygen in respiratory care, and how to optimize it to delivery in the clinical practice. The floor is yours.
Hi, good morning everyone, and welcome to Fundamental Respiratory Care Support course, which is the first ever to be held, and it is in Riyadh. And I'm honored to be part of the faculty and the international speaker. To be with them is such a great honor. Okay, so I think this is my second time in Riyadh. That was 30 years ago. Actually, I visited this place December 1994. So I'm glad that I got the opportunity to visit this place again. Okay, so yeah, I'm registered respiratory therapist and RT respiratory therapy educator from the Philippines, and I'm glad that there are some Filipino respiratory therapists that are in the audience. Okay. So my topic for today will be about oxygen therapy, the fundamentals, which I think everyone who are here will be able to relate to. Oxygen therapy is a very basic and fundamental respiratory care procedure that we as a respiratory therapist should be knowledgeable and expert with. Remember, oxygen is very vital to life, and they always said that man can live without food for 3 to 4 weeks, without water for 1 week, but only for 2 to 3 minutes without oxygen. And you see how vital oxygen is. I won't be going through these objectives because they are written in your books. Okay, and also the next 4 slides will be about terms and abbreviations that I'm sure that you are all familiar with. Okay, so let me proceed with the lecture proper. Okay, so yeah, oxygen delivery. So our cells and tissues in the body need continuous supplies of oxygen to sustain its metabolic function, which is aerobic metabolism. Interruption of it will lead into switch to anaerobic metabolism, which is quite detrimental to our cells and tissues, producing lactic acid, which is what we don't want to happen. Our body requires 200 mils of oxygen per minute. Okay, so but then it should be continuous. Unfortunately, our body cannot store oxygen. It should be a continuous process. Okay, so a majority of oxygen is transported as in chemical combinations with hemoglobin, which is about 98%, and 2% dissolved in plasma. That's how oxygen is being transported. And then the normal or the oxyhemoglobin saturation is 97% when breathing room air, or 21%. Though it will depend on the ventilation perfusion matching. If it is normal, like 0.8, there's no problem. But then if there is a big mismatching, then our oxygen delivery will be affected. Okay. So how do we determine how adequate our oxygen in the body? Okay, so normally, how do we increase our oxygen level? It is through oxygen delivery. And there are 2 ways on how we can determine its adequacy. We can either do it invasively, which is through arterial blood gas, or non-invasively through the pulse oximetry. Okay, so when you're doing the ABG, one of the big advantages, it is a very accurate way. And one thing that I will always emphasize is that it allows the calculations of the PF ratio, or the PaO2 FiO2 ratio, or what we call the Horowitz index. During the pandemic, it plays a big role in management of our critical care patients in the ICU. Okay, so we know na the normal PF ratio is about more than 500, but then if we get a lower PF ratio of less than 300, will guide us on how the level of our ARDS will be. If it's less than 300, it's mild ARDS. If it's less than 200, it is moderate. And if it's less than 100, it is severe ARDS. It's a big help. My daughter, who is a pulmonologist, really said that it was a big help for her identifying who to attend to immediately. So, and then pulse oximetry, okay, which will be considered the PEEP vital signs. Together with that, we measured heart rate. So it's very vital. It's very common measurement that we do in the hospital, though it is affected by some factors like motion, perfusion, or even skin pigmentation. So, and these are the three ways on how we can use our pulse oximeter. We can do a one-time check. Okay, sorry. Yeah, we can do a one-time spot check using the finger probe, or a continuous monitoring using finger probe, or what you usually do in the hospital is attached to a monitor, in which the most important thing is because of the alarm system, so we can monitor it properly. Okay, so, and then the purpose of oxygen therapy is to treat hypoxemia, or the low level of oxygen in the blood, okay, which we can either categorize into acute versus chronic. So what is the difference? Acute is the sudden onset. Tissue oxygenation immediately is disrupted. Okay, normally as a result of a serious trauma or exacerbation of chronic lung disease, which is our COPD, or the chronic obstructive pulmonary disease. It provides oxygen therapy while treating underlying causes, and that is the most vital thing. Okay? So we should be able to provide oxygen therapy while we are trying to figure out what is wrong. And then we have the chronic hypoxemia. Prolonged onset over time, physiological adaptation occurs. Okay? So usually it's a body's compensation or compensatory mechanism. It results in irreparable damage to gas exchange areas, just like the COPD, particularly emphysema, in which the alveolar is affected. Long-term home oxygen therapy is the answer to that, or usually the therapy that we usually prescribe our long-term patients. Okay, so, and then acute hypoxemia. How do we determine that? It can either be through the signs and symptoms. And actually, acute hypoxemia is further categorized into a mild to moderate or to chronic. So what do you mean by mild to moderate? So figure out a PO2 of about 40 to 50 millimeter mercury. Okay, so a patient usually is restless, anxious, agitated, and disoriented. Okay, so and the patient appears to be tachypnic, a little dyspneic, an increase in heart rate or tachycardia, and some degree of hypertension. And for severe, which is usually has a value of PO2 of less than 40 millimeter mercury, going to show some signs and symptoms, which is more onerous, okay, or a little worse than that. It's a major life-threatening emergency and has to be attended immediately. Patient looks lethargic, possibly comatose, and looks pale and bluish. So slowing rate, agonal breathing is a sure sign of this severe acute hypoxemia and with some cardiac arrhythmias. While for the causes, what usually causes acute hypoxemia? One of that is the low level of PO2 in the blood, okay, or the low FiO2 level, as evident by those who live in high altitude area or affected by the altitude. And then also the way our hemoglobin looks like, or is there any exact amount of hemoglobin in the blood, or is it an abnormal hemoglobin, like our carboxy hemoglobin or sickle cell anemia? Okay, and then alveolar hypoventilation. Okay, so we're not breathing good enough to achieve a good ventilation. And of course, BQ mismatch. Okay, if our ventilation cannot match the perfusion, or more than the 0.8, then, which happened during COPD exacerbation, or right to left intrapulmonary shunt, as evident by acute lung injury or lung atelectasis. Okay, so how do we treat acute hypoxemia? First and foremost is the administration of supplemental oxygen to increase the PaO2. We can always deliver 100% medical grade oxygen delivered through a low flow oxygen system or high flow oxygen system, whatever fits the scenario. Or we have to titrate oxygen delivery to target blood. Okay, so normally for a normal individual, it's about 95% SpO2 or a PaO2 of 90 millimeter mercury. And we should always avoid prolonged administration of FiO2 to more than 60. Okay, so a new term that is introduced lately which is a replacement for oxygen therapy, is HALI, or hyperoxic acute lung injury, something that we are using right now. And also possible hypoxic drive in COPD patient, which is usually caused by hypoventilation due to excessive amount of oxygen in the blood, as shown for our COPD patients. And for our preterm newborn baby, the effect of high PO2, usually more than 100, on the eyes of our premature baby, which results into retinopathy of prematurity, or what we call retrolental fibroplasia. Okay, so treating acute hypoxemia, we can always use low flow oxygen or high flow oxygen, depending on the needs that we have. FiO2 delivered to alveolar functions of the type of device, whether it's a low flow oxygen devices or high flow. And of course, how many liters do we have to use? And then the respiratory rate. Okay, oxygen delivery is affected on how our patient's breathing. If the patient is tachypnic or having an increase in breathing effort, then the FiO2 is affected. Also, and then the ambient air entrainment. Usually, when you use a low-flow oxygen device, there's always the air entrainment. Okay. Important to periodically monitor blood oxygen level. That is always important. That's why we can either use an invasive ABG or the non-invasive pulse oximeter. For chronic hypoxemia, then what are the signs and symptoms? For long-term physiologic effects, patient looks dyspneic with more pronounced upon exertion. Okay. Elevated hemoglobin count as evident by our patients with emphysema, in which the hemoglobin increases as a compensatory mechanism for the chronic hypoxemia. When the hemoglobin goes up above 17, then that is like polycythemia. That's what they said. Okay. And then pulmonary vasoconstrictions or pulmonary hypertension also. And then for cor pulmonale or the right heart failure caused by chronic obstructive pulmonary disease. And of course, exacerbations become life-threatening. This is something that we usually want to avoid. Okay? So the frequent exacerbations. Greater risk from lung injury, trauma, and pulmonary infection. That is for our chronic hypoxemic patient. Okay? How do we manage chronic hypoxemia? Provide long-term home oxygen therapy, which will be my last topic, is the LTOT. Okay, so target blood levels, usually because these patients are breathing using their peripheral chemoreceptors or the hypoxic drive. So the PO2 that we target is usually a little lower. PO2 of 60 millimeter mercury and an SpO2 of 90%. Okay? So also avoid over-oxygenation because of the effect of the hypoventilation due to excessive PO2. And what are the goals? Reduce further systematic damage from untreated hypoxemia by providing the right amount of oxygen. Reduce dyspnea, enhance ambulation. As you can see, some of our patients, some COPD patients, who are oxygen dependent. So they usually use a low flow nasal cannula to do that and to be able to ambulate around. Okay, you can see some people on portable oxygen or on e-cylinder. Facilitate pulmonary rehabilitation, in which our main purpose is to improve the quality of life. Okay? So with the right treatment, they will be able to increase the activity of daily living. Reduce likelihood of further exacerbation, which is usually the aim when we are managing our COPD patients. Okay? So how do we get those supplies? Okay, so the most common is the wall panel. Okay, so we happen to see those white tank bulk supply of oxygen. So through the engineering, they were able to go through a piping system and able to deliver it to the different rooms in the hospital, where you can just insert or a flow meter. And then we have the M250 cylinder. Okay, so before we term our cylinders using the letters, but then this time it is through the number. So what does M250 means? M250 means the capacity that it's that tank. Usually before it's an HRK contains 250 cubic feet or 7,075 liters to be exact. And at 2,200 PSI can be used for almost 24 hours. For e-cylinder, we call it M24. Okay? So that is for emergency and transport. It contains about 24 cubic feet of oxygen or 679 liters. The duration can be used for about 3 hours or 3 minutes. Okay, so, and then I have to emphasize that whenever you are using the cylinders or tanks, then there's a lot of safety features or safety measures that we need to adopt. One of that is the storage system, that is the tank should never be stored in places where it generates heat. Okay, and then the way we transport it should be properly, like those gadgets. Okay, and then also remember, oxygen does not burn but supports combustion. So smoking sign should be always there whenever an oxygen is being used in a patient's room. Okay, then. So and how do we dispense them? Okay, so because of the high pressure of each cylinder, then we should be able to bring the pressure down to a working level, which is about 50 PSI. And how do we do that? We can always use regulators for M250 using the burden gauge, and also for M24 using the spin index burden gauge system. Okay? And also we can always use the Torp tube flow meters as well, okay, to be able to use it and give it to our patients. And there's some oxygen gadgets that could be very, very necessary. It could be very helpful. One of that is the oxygen analyzers. So if you're in doubt and you really want to see the exact FiO2 of the oxygen that you're delivering to the patient, you can always have, or you can always use an oxygen, which is a battery-operated small gadget to find out the right FiO2. Okay, and also then, of course, if you want an exact FiO2, be able to titrate between 21 to 100%, we can always use their oxygen blenders using the high pressure compressed air and oxygen. And this one is very vital during the pandemics because it is the one that's used for high flow nasal cannula. And actually, the air oxygen blender is very, very necessary in neonatal ICU, where we want to have an FiO2 of between 21 to 100% to be used. Okay. So for oxygen devices, we can either have a low flow oxygen or high flow oxygen devices. Okay, so here, I'm sure everyone can relate. Most common or standard that we use is standard nasal cannula. If we want to use a flow between 1 to 5 liters, that can deliver from 22 to 45%. Okay, and of course, we don't want the flow to be higher than 5 liters because of the effect on us. Okay, so, and also we have a simple face mask, which can give or provide a 35% to 40%. And then the minimum flow required is about 5 liters because we don't want to have a CO2 buildup inside the mask. And of course, we have the non-rebreathing and also the partial rebreathing. Okay? If we need a higher percentage from 70%, then we can always use that. Okay? So these are the low flow oxygen devices as compared to our high-flow oxygen devices. Okay, so for low-flow oxygen devices, they don't provide a fixed FiO2 because of the entrainment of room air. But for high flow, if you really want something that meets the inspiratory flow demand of the patient, then this is the best option. Aside from that, it can provide a fixed FiO2 from 24, 28, 31, and 40% FiO2. Okay, so this is the best system that we can provide our patients. And lastly, last topic will be about long-term oxygen therapy, which I've mentioned to you previously. Our goals, whenever we use that, is to reduce further systemic damage from untreated hypoxemia, particularly our chronic obstructive pulmonary disease patients. To enhance ambulations, reduce shortness of breath, just like using those portable systems. Our oxygen-dependent patient can move around a lot easier than before. Okay, and then to improve the quality or to facilitate pulmonary rehabilitation. So it's just ordinary. Now you can see in the pulmonary rehab, oxygen, our patients with COPD patients on nasal cannula, moving around, doing the walking, doing ambulations, and then improve quality of life. And with that, and then some can travel. Some can spend more time with their family. And to reduce the likelihood of severe exacerbation. And that is one of the targets, is to reduce exacerbations of our COPD patient. Okay, so, and here we need to titrate the oxygen that we're giving into providing a PO2 of more than 60 millimeter mercury or an SpO2 of 90%. Though, as I have mentioned earlier, avoid over-oxygenation as it can cause hypoventilation because these patients uses their peripheral chemoreceptor or the hypoxia. Okay, so what are the clinical criteria to be included for long-term oxygen therapy? Okay, so we can always consider the signs, symptoms, risk factors, and confirmed diagnosis of COPD. Okay, so the patient should be diagnosed COPD based on the spirometry. Okay, and also through signs like those cigarette smoker, having chronic cough, patients who are quite dyspneic, retain secretions, and then, or those that has a resting room air of less than 55 and or an SpO2 of less than 80. So remember, the target PO2 for them is more than 60, and then target SpO2 is 95%. Okay? Evidence of secondary pulmonary hypertension or core pulmonale. Okay, so marked desaturation during exercise or sleep could be one of the reason or criteria. Okay, or those people or those patients that need at least 15 hours minimum day for optimum clinical effect. Okay? Ideally, 24/7, including while away from stationary system. Okay, and how do we do that? There are two ways on how to provide long-term oxygen therapy. We have the stationary system or the portable system. For the stationary, they're quite heavy, so they're not transportable, provide continuous flow 24/7, and there are two main types. We have the liquid oxygen that can deliver up to 100% oxygen concentrators that use the nitrogen molecular sieve to extract nitrogen and be able to provide oxygen. Okay. Portable system, small lightweight device that are easily transferable. Okay. So this is how our oxygen system looks like. We have the liquid oxygen system, we have oxygen concentrator, and then we have the transfill concentrator. Okay. For portable oxygen concentrators, we have standard POC, and we have the smaller POC, okay, which is quite accessible. And with that, I end my presentation. Thank you very much for listening.
honor to present the next speaker, Dana Evans. Ms. Evans is the president-elect of the ARC, and she will present a very important topic. The next topic, humidity therapy. Thank you so much, Ms. Evans.
Thank you. Thank you for having me. Good morning, everyone. So as they said, I'm going to talk about humidity therapy today. There are quite a lot of objectives. I'm not going to read them to you. They are in your book. I do find that even as practicing respiratory therapists, sometimes we forget the basics of humidity therapy. So we're going to go through that a little bit this morning, specifically focusing on those basic concepts and talking about humidity deficit and the impact it can have on the body. And a lot more objectives as well. I promise I won't read all of this to you. There is a lot there. So just as a reminder, water makes up the bulk of our bodies, right? It can exist in both liquid, solid, and gaseous form. So for the purposes of this talk, we'll really be talking about the gaseous form exclusively, most commonly referred to as water vapor. So just as a reminder, temperature and absolute the ability to hold water is proportionately related. So as temperature goes up, carrying capacity can go up as well. So higher temperatures can have more water in them and higher levels of absolute humidity. This is significant when we think about medical gases, which have absolutely zero humidity in them, right? Very, very dry, very cold, and this can be significant for our patients. So a gas that has a high temperature and high levels of humidity, as the temperature drops, its carrying capacity will drop as well. And that's when you can start to see condensate developing in the circuit once it drops below its dew point. So if you're familiar with mechanical ventilation circuits, you probably commonly see little droplets of water in the circuit, and that's condensation happening as the temperature drops below the carrying capacity of what it was previously at before. And when we think about normal body temperature, and normal body carrying capacity, at normal body temperature of about 37 degrees Celsius, fully saturated water vapor exerts about 44 milligrams of mercury. Also kind of more commonly talked about, at least in the States, is 44 milligrams per liter of absolute humidity content. The way this happens, because room air, the room that we're in now, is not at 44 milligrams per liter, is our upper airway, and to some extent the trachea and the bronchi work to heat and humidify gas. And it does that as you inhale, room temperature typically around 22 degrees Celsius. As you inhale that, and it moves through the upper airways down into the lower airways, the mucosa starts to heat that gas, and it pulls water out of the tissue to humidify it as well until it reaches the temperature of about 37 degrees Celsius body temperature and 100% saturation, about 44 milligrams per liter. Anytime you're inhaling a gas that's less than 100% saturated at 37 degrees, it creates a humidity deficit. It just simply means the body has to work to heat and humidify that gas. The more substantial the difference between BTPS and what you're actually inhaling, the more significant the deficit and the more significant the potential consequence to your patient may be. So breathing room air, you're at a humidity deficit anyway, but the upper airway is really proficient at heating and humidifying gases. This changes substantially when you add an artificial airway, right? So an endotracheal tube or a tracheostomy, you start to bypass that upper airway, and our body becomes less efficient at heating and humidifying. In a normal, spontaneously breathing patient, like all of us, the isothermic saturation boundary is about 5 centimeters below the carina. There's a typo on this slide. Points if you caught it. It's correct in the chapter. 5 centimeters below the carina. So that's about how far the gas has to travel before it heats and humidifies up to 37 degrees and 44 milligrams per liter of water. When there is a large humidity deficit or you've bypassed the upper airway, the isothermic saturation boundary drops and becomes lower and lower in the airway, exposing more mucosa to potential damage from the humidity deficit. There are a lot of bad things that can happen to your patient airway when there is a humidity deficit, the most significant perhaps being ciliary destruction. But probably the first thing you'll see is the secretions start getting thick and tenacious and more difficult to move. You also start to see the ciliary being able to beat less efficiently, so it results in thick retained secretions that are stuck in the airway can also lead to decreased compliance, increased airway resistance, and in some cases atelectasis. So we want to avoid this as much as we can. Obviously, when we introduce medical gases, as Dr. Tyberko just talked about, medical gases have 0% humidity. They're cold and dry. And now that might be fine for a patient if they're on low flows of oxygen on a nasal cannula. 2 liters, 3 liters, that might be okay. Although for some patients, they'll start to complain right away about dry nose. Some of them have nosebleed. Others start to have more, particularly upper airway thickness of their secretions. So sometimes you'll see us add a little humidification to a nasal cannula, but this becomes more significant and more important when we do high flows of gas, as is the case with high flow nasal cannula or mechanical ventilation. So as I mentioned, when you introduce an artificial airway, you are eliminating the upper airway's ability to heat and humidify the gas. So it drops that isothermic saturation boundary. It makes it more difficult to achieve 44 milligrams per liter of water vapor, and really starts to amp up the impact of that humidity deficit. So it's incumbent upon us to add heat and humidity in those cases. As I mentioned before, temperature and water vapor content are proportionate related. So this is just a visual display of temperature going up and water vapor content going up. Okay, so we're going to talk about 4 different types of humidity devices that are typically available in hospitals today: bubble, passover jet, and then in use with high flow nasal cannula. So first, a bubble humidifier, probably the most common and perhaps the most ineffective means of introducing humidification into a patient's airway, is the bubble humidifier. It's quite literally just a container that holds water with a capillary tube, and it forces the medical gas down into the water to bubble up back through the water. The smaller the particles, the more surface area is exposed to the water, the longer it spends time underwater, the more water it can pick up before it bubbles its way back up and moves to the patient. A lot of evidence suggests that in a typical nasal cannula situation, that time is too fast and the surface area too small to really pick up substantial amounts of humidity, but for some patients it can increase compliance and comfort. Passover humidifiers are a little different. This is quite literally the air, the water in a chamber and the gas passing over the top of it. It picks up water vapor through the process of evaporation. So as the water evaporates out of out of the pool, it moves up into the gas flow as it moves across. This is significantly impacted and increased when you increase the temperature of those Passover humidifiers. Probably the most common one you can think of are the humidity chambers we use on mechanical ventilation. Those are heated Passover chambers. Another means of Passover, although much less common, is a wick humidifier. This is literally also a Passover humidifier, but instead of just having it pass over the water, there's a saturated wick, if you will, full of more water, which just increases the access to water as it passes by. You can see in this slide, the right-hand side, left-hand side for you, being a heated Passover. You can see it just passing over the water. But on the right-hand side here, right-hand side? Oh boy, right-hand side for you. It goes down and it has more exposure time as it moves past that wick. So this is a more efficient means of providing humidification, although a less commonly used one. Jet nebulizers. We most commonly think of jet nebulizers when we think about inhaled medication delivery like albuterol, although it can be used to provide additional and supplemental humidification into the airway as well if you put isotonic or 0.9% sodium chloride into the nebulizer as well. It's been a long, long time since I've done this, but there have been occasions where it's been done. It's an aerosol, so you can do that through a large volume jet nebulizer, an ultrasonic nebulizer. Again, not as common in mechanical ventilation, but you can see that out there as a means of providing additional humidity to our patients. Okay, so when you talk about devices, so as I mentioned, medical gas, cold and dry. With a nasal cannula or other devices that are sort of considered low flow, this is impactful, but not as impactful as when you really crank up the flow. So a normal nasal cannula may, provide somewhere between 4 to 6 typically liters per minute. As I said, you may be able to get away without humidification on that. There are some large bore nasal cannulas that can go up to 15. That starts to become more uncomfortable for your patient. But when you turn the flow up to 60, right, that can be like a freight train of air coming at you. It's cold and dry and fast, and very quickly you'll start to see the impact of humidity deficit. So it really is required to have heated humidity for patients on high-flow nasal cannula therapy, as well as non-invasive and invasive ventilation. Important to use high-flow nasal cannula, and I won't talk about this too terribly much, but there's lots of evidence that suggests it reduces work of breathing, can really improve oxygenation and reduce dyspnea as well. So you want to make sure that you're providing this therapy to your patients, but in a way that doesn't cause other challenges or damage to the airway. So during mechanical ventilation, again, that's even faster in some cases and pressurized. You want to make sure that you are, of course, humidifying these to body temperature pressure standard. Sort of the standard expectation for humidification on a mechanical ventilator is to achieve an absolute humidity somewhere between 33 to 44 milligrams per liter at a temperature between 30 and 40 degrees Celsius. You can use passive or active humidification for patients with mechanical ventilation. So passive humidification is a heat and moisture exchanger, or an HME. This works kind of like the upper airway, so sometimes you'll hear this referred to as an artificial nose. And so the way this works is the patient inhales gases and exhales back through it. That's where the heat and humidity comes from. So when they exhale warm, moist gas through the HME. The material in the HME collects the heat and moisture. So on the next inspiration, that gas passes through there, it warms it up, it humidifies it a little bit, and then it moves into the airway. This can be pretty efficient for patients that are on mechanical ventilation for a short period of time, but not all patients are candidates for this type of humidity therapy. Visual display of what I just told you. So this is a relatively inexpensive means of providing humidity to patients. So a lot of hospitals do utilize this, particularly in their post-operative surgical units when patients are going to come off the mechanical ventilator pretty quickly. Cheaper than a heated wire circuit and a humidifier chamber. So a lot of them will opt to do this if possible. But as I said, not every patient is a candidate for an HME. So if they already have thick, tenacious, or bloody secretions, they probably don't have enough humidification in their airway to be providing humidification to themselves, right? So that's a poor candidate for this. If they have a cold body temperature, they can't heat themselves if they're already cold. If they have a large leak around the endotracheal tube, when the heat and humidified gas is moving out into the room and not through the HME, obviously the HME can't capture that heat and humidity, so that doesn't work. Or patients that have very large minute volumes, greater than 10 liters a minute, it's just moving too doggone fast to pick up the heat and humidity inside the HME itself. So these are patients that should not get HME therapy and should be using Passover humidification instead. So active humidification, as I mentioned, this is typically a form of Passover humidification. This is added to the ventilator circuit, probably the most common means of doing this. Lots of companies provide Passover humidifiers. And again, the way this works is the gas passes over the chamber. The circuit itself is really innovative, in that there's a temperature probe at the chamber and a temperature probe at the patient. So it's monitoring that to try to keep it as close to 37 degrees Celsius as much as it can, so that it gets to the patient at full saturation and the temperature that it needs to be at. You will know it's working correctly if you see condensation in the circuit or in the endotracheal tube itself. If you don't see any condensation, no droplets at all, then you're absolutely not providing 100% relative humidity. You want to see some condensing there. I can think of a few patients in my career where the heater malfunctioned, and if it didn't get caught, and so they end up with thick, tenacious secretions and sometimes airway plugging. I've seen patients code associated with this as well. So you want to make sure there's good fogging and condensation in the circuit. If not, you need to troubleshoot your device. The AARC does have clinical practice guidelines associated with humidity therapy. They're getting a little dated from 2012 now, but they have some recommendations that Absolute humidity for all of these devices must be between 33 and 44, and the temperature between 30 and 37. It does also highlight that high ambient temperatures in the room can trick the heater, right? So if the room temperature is high, the little temp probe in the circuit will think the circuit is warm, and it will stop heating because it doesn't feel that it needs to provide any additional heat or humidity. It's already done its job. The problem with that, of course, is that the gas starts to become less humidified, right? So it starts to impact the patient. There are probably two more common reasons that'll cause that. The most common, I think, is a neonatal unit. If you've ever seen a baby in those giraffe beds and the little boxes that are heated for them, it can trick the circuit. So a lot of times you'll see neonatal respiratory therapists move the temperature probe outside the porthole doors so that it's exposed to ambient temperature and not the temperature in the room, or in the box, it will. The other place that I have seen this, although it's been many years ago, is in burn units. So some patients with full thickness burns, you'll see them with radiant warmers above the bed. Same thing, tricks the temperature probe. This is the one instance in my career where I've actually used a jet nebulizer in line with a mechanical ventilator to provide additional humidification. Humidifier technology has gotten smarter since then, but we had to be crafty. Just another image of that. So when you're trying to decide for the patient in front of you which type of humidification you should use, this is a pretty good tool for that. This is in your textbook. You sort of start by looking at your patient and asking yourself, can I use an HME or do I need to use active humidification? So passive versus active. The first thing you would ask yourself is, do they have any of those HME contraindications I mentioned? Thick, bloody secretions, low body temperature, large expiratory leak, or a large minute volume. If the answer is yes, you have to move to active humidification, those heated passover chambers. If the answer is no, then you can use an HME. If you're using active humidification, this slide would suggest that if their secretions remain thick, you can increase the temperature. I don't see that a lot in practice, but it is a reasonable thing to have here. Humidification during aerosol therapy. So not uncommon to give inhaled medications to patients while they're on non-invasive or invasive mechanical ventilation, but the heat and humidity absolutely impacts the particle size of the medication you're giving. Larger particle sizes impact higher in the airway, so it reduces particle deposition to where you want it. So it's something you have to think about. There was a brief period of time where people would turn off the heater to give the medication. This does not help. Don't do that. This does not help. The circuit still stays warm and moist for a long time, so that's been abandoned. Folks still give it while that's on. What you need to be thoughtful about, though, is relative humidities above 40 to 50% will impact your particle deposition. So your patients may need higher doses or a higher frequency of the medication in order to get the impact that you really want. The other thing to think about is the type of device that you use and the particle size it generates from the outset, as well as where you place it in the circuit. So some data, a lot of data actually suggests in a mechanical ventilator, you might want to put that on the dry side of the chamber, but that does vary based on device. High frequency is a little bit different, things like that. So you always want to make sure you understand the device you're using and the best placement in the circuit so that you can lessen the impact and get the proper amount of particle deposition that you want for your patients. This is amplified in pediatric patients, those patients who have smaller airways, so pediatrics and neonatal patients, this is more significant to them. Non-invasive ventilation, you do still need to provide humidity to these patients, even though they are using their upper airway. The speed of the gas moving through the upper airway, it's so rapid that the upper airway simply cannot keep up. So we do still need to provide additional supplemental humidity for them. Typically, if you don't humidify this, you might see an absolute humidity as low as 5 milligrams per liter in these patients coming into their nose and mouth, and that's just not something they can maintain keeping up with. We know that this adding humidification makes it just frankly more comfortable for our patients. They're more likely to be compliant. This is significant for our home patients, where we're expecting them to put this on when we're not looking. And certainly significant to add active humidification for patients in the ICU who are having acute respiratory illness. You want to make sure that the temperature for this is between 20 and 22 degrees Celsius and the relative humidity is above 10 milligrams per liter. Okay. I moved really fast. So key concepts here, there are a lot of them. These are printed exactly like this in your book. I won't read them to you here either. But I will mention, I didn't mention this on the previous slide. Passive humidification, HMEs, are not recommended for non-invasive ventilation. They're not recommended for non-invasive ventilation because there tends to be a large leak in the circuit before where you would put an HME, so it cannot collect enough heat and humidity to work. So you really do have to use a passover humidifier, and a heated humidifier is certainly more recommended for that because, again, it increases the relative humidity, although some patients can do it without heat. All right, so key concepts here. Medical gases are cold and dry and have an absolute humidity of nothing, right? I wouldn't like that, you wouldn't like that, our patients don't like that either. So you want to make sure you're supplementing that to reduce their humidity deficit and the detrimental effects associated with that, particularly thickening secretions that become retained and cause challenges to your patient's airway resistance and compliance. Humidifiers are affected by ambient temperature, so you want to be thoughtful about that. A good clinician during patient ventilator assessments are always looking for condensate in the circuit, and if not there, taking action. Active humidification for non-invasive ventilation, and we shouldn't use HMEs for non-invasive ventilation. And I've got you ahead of schedule, so thank you very much for your time.
Thanks, Ms. Ethans, for this informative presentation, and thanks again for the perfect timing. With this important topic, we end session 1. Thanks to all the speakers, and thanks to you all for attending. Now we'll switch to the FRCS organizer, Mr. Hassan Al-Uraini, Abu Saleh, for the next event. Thank you so much.
Do.
السعودية عمار والله ما قبلك بلد والله ما بعدك ديار عمار يا دار السعد لا يا السعودية عمار والله ما قبلك بلد والله ما بعدك ديار بسم الله الرحمن نبدأ يا لطيف حليم بسم الله الرحمن نبدأ يا لطيف حليم يا عالم بالغيب يا منان يا ذا الجلال
بسم الله الرحمن الرحيم. اللهم آمين. اللهم احمي بلادنا واحمي وأوطاننا وأدم علينا الأمن والأمان وأدم لنا خادم الحرمين الشريفين وولي عهدها الأمين. أهلا وسهلا بكم. Good morning everyone. So it's time now to just give you a little of a break for an opening remarks. Who is best to start this opening remarks except my colleague and friend, Professor Jerome Sullivan? Please.
Thank you, Hassan. I want to add my welcome to everybody here. And I have some important words because this is an important day. Over 10 years ago, Hassan al-Araini, better known as Abu Salah, and I began working on elements of the fundamental support course. And really now, finally, we've come down to Riyadh, and we're actually having the first session that's being offered. And this is a great victory, I should say. Our goal was to develop and offer a course for the safe and effective provision of respiratory care and to meet and exceed international standards. Before I say anything else, I want to recognize my part and acknowledge my partner, Hassan al-Araini, without whose tireless efforts this meeting would not be in function right now. The Saudi Arabian respiratory community, and indeed the international respiratory care community, owes him a great deal of thanks. Thank you, Hassan. From the beginning, Hassan and I realized that in order to make this course effective, we had to have diversity of thought and opinion, and was to invite leading clinicians, educators, and researchers from many different countries to contribute as authors. Many of those authors are speaking on the dais today or are in the audience. And we believe we have succeeded from drawing these authors from many different countries and have this diversity of opinion. And it comes down to the fact that we have 11 different countries that produced chapters in the fundamentals course. That number 11 doesn't really speak for what impactful is going on. But if you think about how we cross the world map to draw on this expert knowledge, it's really impressive. So I'll give you a little trip, a verbal trip. Norway. From Norway we went to Turkey, Saudi Arabia, Japan, China, the Philippines, Colombia, Canada, the United States, Taiwan, and Lebanon. So we're very thankful that you're all here. I think we've got to the point where we need to introduce the current sitting president of the American Association for Respiratory Care, Carl Hingston, and I will turn the mic over to Carl. Thank you.
Go back. Oh, sorry, shocking. Good morning, everyone. As Jerome said, I am Carl Hinkson, and it has been my honor to serve as the president for the American Association for Respiratory Care for these last 2 years. I know that this course has been in the works for a very long time. Jerome and Hassan have worked exceedingly hard, and the association, the AARC, is very proud to be the organizer for this inaugural event here in Riyadh. This is my first time traveling abroad. As I kind of realized last night, I did my first international flight this week here, and so it is my pleasure. I had the pleasure to see some of Riyadh yesterday, and I am very pleased to have been welcomed here and to be a part of such an esteemed group of a faculty from across the world. So I thank you. I welcome everybody. I hope there is an opportunity for me to be able to meet and speak with the respiratory therapists and the respiratory therapist students that are here today. And we look forward to serving and presenting during this conference. Thank you.
Um, as we have many international representatives and guests, and also we have many people in this auditorium who are not totally familiar with the respiratory care schooling and education and practice in Saudi Arabia. And there's nobody who can do it best than Professor Hajid Al-Otaibi, a seasoned respiratory therapist, and who can give us a quick presentation. Can you launch his?
Abu Saleh, thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh. Sabbahakum Allah bil khair jami'an. Actually, this presentation usually takes 30 minutes. Abu Saleh asked me for 2 minutes, so I'm going to do my best.
هذا يقدم. هذا push this.
Yep.
Okay, here. Here. قلنا لك.
We all know that Ministry of Health has established 1950. But respiratory therapy was not one of, the professions that was recognized by that time. Actually, the respiratory therapy profession started in King Faisal Specialist Hospital and Research Center in 1975. The service was there, but they were just doing the service. But the real start of the respiratory care profession was 1976, when Lumulinda University Heart Team had operated the first cardiac operation in Khamis Mshaid. And at that time, there was 2 respiratory technicians. So the respiratory team was consulting the American team about the procedure or the protocol of the operation. They told them that you need to have respiratory technician so they can take care of the patient after the surgery. So the idea started 1976. The authority in Khamis Mshaid is a city in the south of Saudi Arabia. The authority of Khamis Mshaid Hospital, they started to train some of the healthcare provider to work as respiratory care technician. Then the first department was established at that time. Lumulinda Heart Team was moved to Riyadh 1979. The military hospital was established by that time, and Dr. Al-Faqih, a famous cardiac surgeon, has started the services of cardiac open heart surgery, cardiac operation. So the real start of the respiratory care profession in Saudi Arabia was parallel with the open heart surgery. So then Dr. Al-Faqih recruited somebody from the state to do some kind of structured training. Then later on, Lumulinda University started the first 3-year diploma program in Riyadh. 1 year later, Prince Sultan Military College for Health Sciences in Dhahran started the first local 3-year diploma program. Then, probably 10 years later, King Faisal University, which is now called Imam Abdul Rahman bin Faisal University, started the first bachelor degree program. Then things started to improve. The Saudi Society for Respiratory Care was established in 2004. Later on, in 2005, the Saudi Commission for Health Specialties has recognized respiratory care profession as one of the healthcare providers that are licensed and registered within the country. I think probably in 2011 there was a signed agreement between the Saudi Society for Respiratory Care and the American Association for Respiratory Care. In 2012, there is a major recognition in Saudi Arabia. Was the profession was formally recognized by the government and started to hire people in the healthcare bodies. I'll go fast on this. This paper was published in 2015. It gives some statistics about the workforce of the respiratory therapy in Saudi Arabia. In 2015, by the way, the data was collected in 2011 or 2012. There was 1,477 RTs. 25% of them are Saudi. They are 67 of them Filipino. I mean, Filipino, يعني they are constituting major part of this. They were distributed through the country, central, east region, northern region. I'll go to the new data. This is unpublished data under review. Currently today, there is 5,462 RTs. So from 2015 to today, there is a huge increase in the RT. Majority of the respiratory therapists are in the major cities. Almost 50 of them are females. So the RT right now, we have 23 programs in Saudi Arabia. I guess all of them are a bachelor degree program. They are well distributed through the country. We have a 2-year postgraduate diploma in critical care, and this one established. And now we have about 14 training centers in the country. We have also, this is a newly established, a postgraduate diploma in sleep studies, and this is probably going to start next year. It is developed. We are just waiting the training center to be accredited. And we have a postgraduate diploma in cardiovascular perfusion. Cardiovascular perfusion was treated as a subspecialty of the respiratory care profession. The major, Sibahi, this is accreditation bodies in Saudi Arabia. And I believe that the major expansion in the respiratory therapy profession was attributed to Sibahi, because Sibahi recognized our respiratory therapy as one of the standards. We have subspecialties. It is not really recognized, and I think that we need to go and revise this subspecialty and start the process of their recognition. Thank you very much.
Thank you, Dr. Hajid, for a quick. I'm sure there is more data that he has, but due to the limitation of time. Now, please allow me to very quickly go over some housekeeping items for everyone. Then we have a reward ceremony following this. Now, as you can see, the final program is already on your bag. It has elite of speakers and topics. And as you can see, we have only 17 lectures. 17 lectures, meaning 17 chapter of the book. And many of you received the book, which is 360. If it's the whole book, it's about 850, just to let you know. And this is our program for today. I'm going to flip very quickly. As you can see, we were delighted to be able to attract an elite faculty from around the world. Of course, almost every major department in the kingdom, whether it's education or clinical, are collaborator. I must pay tribute to my good friend, Allah yarhamu rahmatan wasi'ah. I talked to him just a few weeks before he passed away. But I chose to keep him in the program as a tribute to him. He was a fine person. Allah yarhamu rahmatan wasi'ah. More of our collaborators and departments and faculty, local. Now, just to let you know that the program now, as we speak, it's live everywhere in all those applications. So you may just scan the QR code and then send it. And it's free. Even the Zoom is available. You can register also. Now, tomorrow is the day of the workshop. And we have 4 workshops in the morning and 4 workshops in the afternoon. Of course, all of you are grouped into group A, B, and C. Please don't change, or don't attempt to change your group, because it's very carefully calculated and demographically designed that way, based on schooling, background, knowledge, gender, institution. Pre-test results also played a role on this, and different regions. So we have many from one area. We did not put them all together, and so on. Now, some statistics very important to everyone. Now, we have, again, 4 groups, 31, 31, 30, and 30. Total participant registered in this course is 122. Now, so stay on your group, okay? Now, by city, this is by city, how many registration from each city. Dammam, 38, Jeddah, 35, Riyadh, 35, equal. See, Dammam, though it's too far, and people have to travel, they are on the top. Jeddah, though they have to fly, they are equal number. And then goes down, Jazan, 600, Yambo, 1 from Yambo and 1 from, we also have 2 from Qatar, 2 UAE, 1 Egypt, and 1 Yemen. Now, by institution, College of Muhammad Al-Mana scored the highest registration. For that, we thank you. National Guard Jeddah, 13. Imam University in Dammam, 10. National Guard Riyadh, 7. King Faisal Jeddah, 7. Sulaiman Al-Habib, 6. And the rest are all below 5, 5, 5. And some of them are 1. Now, by specialty, we have 82 respiratory therapists, respiratory intern 27, pulmonologist, intensivist 4, emergency physician, intensivist, internist, the first one, this is intensivist 3, and we have 1 nurse. Where is this nurse? Oh, she is standing in the back there. Thank you. Now, we did a pre-test, and the pre-test, thank to very good 3 colleagues, 2 colleagues, 1 in Jeddah and 1 in Dammam. They administered the test in a very professional way. There are two exams, same question, but they are just shuffled. And they did a good job in Jeddah. Thank you, Dr. Hajid. Dr. Ashok from Dammam, she did in Dammam, she and Dr. Mansour Al-Asmari in his center. So for that, we thank him. And here is the pre-test results. We have 111, they did actually the pre-test. We have about 40, we did it online. And can you believe it? In Zoom, we just put the question and someone is, okay, A, Alpha. The girl was sitting next to me. Her name is Farah there. I can hear her, Alpha. B as in beta, and so on. So she did a good job, about 40. As you can see, the average is 58 of all those participants. 60%, 60 of them above 58, the average, 51 below. Dammam, King Fahd Specialist Hospital in Dammam got 85, one person. This is the highest score. Below, King Saud University in Riyadh, 82 from Riyadh. And then Princess Noura is the third person, 79. Imam University in Dammam, 79. And Jazan, and then goes down like this, down to this. Now, the post-test, this is very important. At the last day, tomorrow, you need to come back to the same place. There will be a post-test. This is very important. And then people who pass the test will get this certificate of successful completion, who passes the test. People who do not pass the test, they will need to wait for 1 month, then we'll give them another chance to retest, okay? And this will go, the results will be scored within this week, and next week we'll get back to you. Now, people who don't pass, and everybody in this room who attended this course will get certificate of attendance. Now, this course is 16 hours Saudi Commission and 15 hours CRCEs from the ARC. Now, immediately tomorrow night, you need to go to the website to do evaluation. This evaluation is very important for our direction and for the future. So you need to log in, and only people who registered can log in to this. So it's not open. And when you are done with the evaluation, you will get certificate of attendance. As you can see, now you have your text. There are many in this room who are either faculty, certified faculty or authors. It may be a good idea to get them autograph if they have the time. Thank you. Now, there is a few thanks. I want to thank first of our committee who worked very hard to establishing this course and get it going. I would like to thank our faculty members, and I would like to thank the local committee and faculty members. I would like to thank the ARCF for their support throughout the years. And I would like to thank also Saudi Society for Respiratory Care for their participation in this course. Most important, our companies, thank you very much. All, without any exclusion, thank you very much. Without your support, we won't be here. I would like also to thank Al-Faisal. Al-Faisal is very important. Without them, we cannot have this nice facility. And most important, I would like to thank you for coming and attending this course and registering. Now, this whole work is not easy. It took so much time and effort. As you can see, this is the designer, and we have 33,000 files between him and I, 33,000 from inception until today. Images, document, name it. And between Noura and I, we have 1,000, almost 2,000 files, documents, letters, invitation, and so on. So lunch break will be downstairs, okay? And the best we can do is just lunch boxes, okay? And coffee break is just in here. Now, I haven't heard any phone ringing, so thank you for that. Now, I would like to call Dr. Sullivan and President to maybe stand here. We have a few awards that we need to present. It's important to us. The first award, Nasser, the first award goes to Alfaisal University. Yeah. Without them, we will not be here. So for that, we profusely thank them. When we thought about this course, there are three things we must have. One of them is a location, a place to hold this event. And then we got Al-Faisal University immediately agreeing to hold a course. For that, we thank them. We have a small momentum and we have Ms. Fatin Al-Khatib. She is the head of medical education at Al-Faisal, receiving on behalf of Professor Al-Qattan. Please. Yeah, you can hand it to her and take a picture. Photographer. You go the other side. Okay? Thank you. Thank you very much. Next is, okay, well, now we have a place. We are delighted to have the place. Now the second thing, and we should have money to hold, to conduct this course and to cover all the expenses. So then we sent invitation to all possible respiratory care suppliers in the kingdom. The first, within 24 hours, was Al-Khatib Medical. Amazing. That ignited really the urge to continue. And we have engineer Tariq Al-Khatib, yes, he is here. For that we thank him. Within 24 hours, we got the approval to do this. For that we thank you very much. Mohandes, thank you. Picture time. Face it. Thank you. Thank you very much. Now, we have a place, we have the funds, then we have to have the workforce. There is one person who, when I immediately asked, can we start this? She said, yes, we will do it. And that's my friend and best colleague, Noor Shah. I'm sure many of you got messages from her and things. So for that, I thank her for her patience and for her. I wouldn't be able to do any of that without her. Just 1 second. Thank you. And of course, as I said before, now we have registrations and we have to have attendance, which is one most important pillar of any event. So to get the registration, we get the highest registration from Al-Mana University. And I have Sukaina Al-Mashhad. Sukaina Al-Mashhad, thank you very much. We have 14 registered. They have the highest registration. Thank you. Perfect. Sukaina is from Rush University. She's a graduate of Rush. So for that, we thank you very much. And our greeting to Al-Mana. Thank you. Thank you. Not only they have the highest registration, 14, but 7 out of the 14 scored above the average. So now I would like my friend Professor Sullivan to introduce our next Dean Hess. You come here, the mic. Yes, you don't go.
Our next honoree, many of you know him or of his academic work and his publications. Dr. Dean Hess, would you please come up? Okay. Dean. Yeah, Dean was our editor through this long journey, and we have a special award for him.
You are talking?
I would like to see the plaque.
Okay.
Okay. It's 36 chapters in the total program, so not just the 17 that we have now in this meeting, but Dean worked tirelessly and many hours, and he and I had a joke that as he progressed, he'll probably average out about minimum wage.
Right.
He actually did most of this work for nothing, and he really did steer us correctly. We had contributions, and they did require revisions and additions and editing,
Right.
and he did a fine job, so let's hear it for Dr. Dean Hess.
I want to add to my colleague Sullivan that without Dean, we will not be able to actually accomplish 36 chapters. And you can imagine chapters, authors from China, from different places in the US. Each one of those authors, they have their own style of writing and errors and just name it. And he was able to fix everything and keep it consistent. Even if the chapter is authored in China or different or Taiwan, he made them all look the same. For that, we thank you. Come, picture time. Yeah. Thank you. A few words for you. I will carry this for you. You can go to the mic. Yeah. Yes, wait.
So they told me I need to say a few words. I have no words prepared, so I'll make this up as I go. Certainly it is my honor to be here with you today and to have been invited to do two presentations that you will hear this afternoon. Let me say that it was from the start my privilege to work with Jerome and Hassan. We together spent many hours working on many chapters. I think you can already see from the presentations this morning what a great product this has turned out to be. And I was very honored to be part of it from almost the very start. So welcome to the meeting, and it is my privilege to have worked with these fine gentlemen, and it's my privilege to be with you today. Thank you.
I mean, many companies have been asking, even audience have been asking, when is the next one? So this is an anticipated date for next year. Mark your calendar. And now we can go for our break. Thank you. Coffee break now.
So we go to companies.
بسم الله الرحمن الرحيم. Dear all, in the second session now, please join me to welcome Dr. Ahmed Bahammam, Professor of Medicine, Editor-in-Chief of Nature Science, and he is the President of Asian Society of Sleep Medicine, Consultant Pulmonary and Sleep Medicine Director, King Saud University, and he is also the Director of Prince Naif Health Research Center. Dr. Bahammam, Professor Bahammam published more than 350 articles in peer-reviewed journals, 60 chapters in medical books, and presented more than 200 scientific abstracts in local and international scientific meetings. Please join me to welcome Professor Bahammam.
Thank you, Dr. Saad. Assalamu alaikum wa rahmatullahi wa barakatuh. As'ad Allah sabahakum. Good morning, all. And thank you, Mr. Hassan, my brother, Mr. Hassan, for the chance, and Professor Dean Hiss and all the team for inviting me to write the chapter and to be here in the first course. It's a great honor for me. Our chapter or our lecture will be about breathing-related sleep disorders. We'll cover some of the topics discussed in the chapter because of the time. So the objectives that we will try to cover today is describe obstructive sleep apnea, its polysomnographic patterns and the major treatment options, including positive airway pressure, describe the major types of central sleep apnea, distinguish between obstructive and central sleep apnea, list treatment options for common types of central sleep apnea, describe obesity hypoventilation syndrome, its diagnosis and major treatment options, describe the techniques for positive airway pressure titration recommended by the American Academy of Sleep Medicine, and how to track and improve positive airway pressure therapy adherence. We'll have more details on that in the workshop tomorrow, and discuss the differences between different interfaces for positive airway pressure therapy, and also we'll have more discussions on that tomorrow in the workshop. Sleep apnea, obstructive sleep apnea, pathophysiology, as you probably all know, it's related mainly to narrowing of the upper airway and closure during sleep. And this results in recurrent, what we call intermittent hypoxemia, which is something characteristics for obstructive sleep apnea, different from other sleep disorders different from other respiratory disorders that usually result in sustained hypoxemia. This in turn increases the risk of cardiovascular complications, metabolic complications, and arrhythmias. Obstructive sleep apnea is very prevalent. Believe it or not, probably it's more common than bronchial asthma that we know a lot about. And this is a conservative estimate of the prevalence of approximately 3 to 7% in adult men and 2 to 5% in adult women. In Saudi Arabia, it's probably 4% in middle-aged women and 11% in middle-aged men. The estimated global prevalence in adults in 2019, those who are middle-aged, slightly more than middle-aged, it's about 1 billion. They have mild to severe OSA, and around 500 million have severe OSA. You are also probably familiar with the main symptoms of obstructive sleep apnea. Snoring is the cardinal features, but not all snorers have obstructive sleep apnea. Do I have to put this one? Oh, it's okay. Okay. Choking during sleep, which is one of the bad symptoms. Anyone who has choking or has experienced choking, it's a bad feeling. So they will come running looking for care. But some patients with severe sleep apnea, they don't feel it. That's why sleep apnea is not one size fits all. We have different phenotypes and endotypes. We'll cover some of them as we go on. Witnessed apnea is also present. Sometimes like the wife who notes that her husband has apneas and she will push him to go to medical care. Nocturia, when we think about nocturia, we think about many disorders, but one of the common causes of waking up at night to go to the toilet is obstructive sleep apnea. And once you treat it, the effect is almost immediate. Mouth breathing, which results in dry mouth and throat in the morning, also bitter taste in the mouth and sore throat, excessive daytime sleepiness, but remember that not all obstructive sleep apnea patients, they have excessive daytime sleepiness. Maybe 30 to 40% only of them will have excessive daytime sleepiness. As patients open their mouth and start breathing, and the mouth is not for breathing, they will have dryness of the mucosa. So salivary gland will understand there is some dryness, we have to increase saliva, so they have excessive salivation during sleep. Also, morning headache is one of the symptoms, and it is more with obesity, hypoventilation, excessive sweating during sleep. Obstructive sleep apnea is one of the causes of this common problem. Nocturnal heartburn, because it increases the risk of reflux, and reflux also increases the risk of sleep apnea. Nocturnal palpitation, nocturnal chest pain, and sleep that's not refreshing in the morning. To diagnose sleep apnea, there are some questionnaires that we discuss in the chapter. They are used for screening only. They are not diagnostic. The commonest known one is the Berlin questionnaire and the Stop Bank questionnaire. And we have validated Arabic versions of these questionnaire. The American Academy of Sleep Medicine and the ASM, you see that's the American Academy of Sleep Medicine, still considers polysomnography. We'll show you some example, and this is like what we monitor in what we call type 1 or level 1 sleep study. It's neuro, cardio, pulmonary, and neurological monitoring. So we monitor muscles and EEG, respiratory pattern, ECG, and pulse oximeter. So this is still the gold standard, but because this is time consuming, require precious beds in the hospital or in the centers to be admitted, doesn't mimic the normal sleep of people at home, there have been a shift to what we call home sleep testing. And home sleep testing is mainly approved now for obstructive sleep apnea, not for other sleep disorders. And it is recommended by the American Academy of Sleep Medicine for patients with high likelihood, clinical likelihood, of moderate to severe OSA. So patients who are likely to have severe OSA with no other comorbid conditions like muscular diseases, like COPD, like hypercapnia, this is not good for them. It's only pure OSA. Home sleep testing has good results. And when we talk about home sleep testing, there are certain levels of what we call portable or sleep studies. Level 1 is the one I showed you, the BSG, full neurocardiorespiratory and muscular monitoring. Level 2 is called unattended comprehensive. It's done only for research. Level 3 is the main home sleep apnea testing. And that one, we have cardiorespiratory monitoring. In that one, we don't have EEG. It has limitations because when we don't have EEG, we don't know if the patient is asleep or not. Also, we cannot diagnose what's called REM-related or REM-predominant OSA. I'll show you an example of that. Because hypopnea, I'll come to the scoring of hypopnea, one of the criteria depends on respiratory events of hypopnea followed by arousal. If there is no EEG, you cannot score arousal. So home sleep test tends to underestimate the severity of sleep apnea. That's why the American Academy of Sleep Medicine, in their recommendation, they put, if one study fails, then you go to BSG, you don't repeat it. And if a study shows no sleep apnea, but the clinical suspicion of sleep apnea is high, this is not enough to rule out sleep apnea. You have to go for level 1 in-lab sleep study. And because it is unattended, there is a risk always of signal failure. So if you look here, this is apnea. Apnea is easy to define because we have apneas and hypopneas. Apneas are complete or near complete cessation of breathing, 90% or more reduction in nasal flow. I'll show you examples when we go to the sleep studies now. In adults, it's 10 seconds or more. This is what has been accepted. In children, 10 seconds is too much for them because they breathe at a faster respiratory rate. So if they miss 1 or 2 breaths, that's serious that you have to treat. If you look here, you see the patient is breathing, then there is no flow. So this is apnea. You see here, obstructive, no flow, but the patient is trying to breathe. So there is effort, but no flow. Central, there is no flow and no effort. So the problem is central. Patient stopped breathing altogether. Mixed, you don't have to worry about it. I don't want to confuse you with that. What are the scoring criteria for apnea and hypopnea by the American Academy of Sleep Medicine? Apnea have been always fixed. Hypopnea, every 2-3 years, they changed the criteria because still until now, they are not sure what's hypopnea. So for the recommendations for hypopnea, they have recommended definition and accepted definition. And this is confusing, but this is what they had. And this is related to somewhere to Medicare and Medicaid. Anyways, recommended definition, at least 30% drop in nasal airflow. I'll show you examples of that for 10 seconds or more in adult, followed by 3% or more oxygen desaturation from the pre-event baseline or arousal. So if you don't have EEG, we cannot score arousal. So we tend to underestimate hypopnea. Then they have the accepted definition. In February 2023, they changed the term acceptable into optional criteria. So they used to call it recommended and acceptable. Now they call it recommended and optional criteria or definition. At least 30% drop in nasal airflow for 10 seconds or more, followed by 4% or more desaturation. So if you see here, we'll try just to go through this one. This is a 2 minutes almost window of BSG. Between the two lines is 30 seconds, what we call epoch. And here what we monitor, this is the eye movement, this is the EEG. And if you see here, this is the chin EMG. This is the flow by nasal cannula and flow by thermistor. Probably in the workshop we can discuss that if we have time. This is the thoracic and abdominal movement, and this is the saturation. If you see here, the patient was breathing, and here normal breathing, here normal breathing. In between, there is paradoxical breathing, what we call, and there is no flow. So this is obstructive apnea, and it is followed by arousal and desaturation. Remember that for apnea, we don't need arousal or desaturation. Arousal and desaturation only for the hypopneas. This is an example of hypopnea here. You see, there is reduction in flow compared to the baseline, but there is still flow, so there is no complete or near complete cessation of flow. So there is a reduction in flow followed by arousal or desaturation, then you score hypopnea. Remember always in adults, it's 10 seconds or more. Less than 10 seconds, we don't score. This is a phenoendotype of sleep apnea called REM predominant OSA. This is what we call a histogram. And this is the top called hypnogram, where we put the sleep stages. Up is awake, then as we go down, we go into the deeper stages of sleep until stage 3. And the red color is the rapid eye movement or the dreaming stage, where we have atonia or absence tone of the gravity muscles, including the respiratory muscles except diaphragm. You see, this patient, when he or when she goes into REM sleep, she starts to desaturate and have obstructive apnea. Each line of these lines is obstructive apnea. The length is the duration of the apnea. These are hypopneas, and this is arousal. And in between, in non-REM sleep, normal, there is nothing. So this is what we call REM predominant OSA. We see it mainly in premenopausal women, young adults, and sometimes in thin people. These patients are less symptomatic. We used to think that this patient is not risky if they are asymptomatic, you don't have to treat them. But recent observational data are showing that probably they have higher risk of cardiometabolic complications than non-REM or non-stage specific OSA. How do we score severity of OSA? They have accepted the number of apneas and hypopneas. So what we call the apnea-hypopnea index, which is the number of apneas and hypopneas during sleep, total sleep time. If a patient slept for 10 hours and they have 60 apneas and hypopnea, then we'll have the apnea-hypopnea index 60 by 10, it will be 6. However, if he slept for 5 hours and have 60 apneas and hypopneas, then the apnea-hypopnea index will be 12. Okay, so this is how we calculate the apnea-hypopnea index. So less than 5 in adult is considered normal. 5 to 14 mild, 20-30 per hour moderate, and more than 30 severe. But remember that this criteria has been just put like that, we use it in research. But recent data are showing that probably desaturation index and what we call hypoxic burden, or how much time they spend during sleep with saturation less than 90, is more predictive of severity and complication than the AHI. But this is what is accepted until now. We are following that. How do we treat obstructive sleep apnea? Patient education and behavioral strategies, we discussed that. Usually it is helpful, it's not effective in its own, like weight reduction, exercise. Early this month, we published a systematic review about aerobic exercise and sleep apnea, showing good result, but these all are supportive and positional therapy. You can read it in that chapter. What's the mainstay or the gold standard treatment is the positive airway pressure for sleep apnea. And then we have the non-positive airway pressure therapy, like some techniques for surgery and oral appliances, again, that have been discussed in your chapter. You can look at it. How do we titrate positive airway pressure? We do it usually while we do in-lab sleep studies. But even for home sleep testing, if you diagnose them, you can use auto-titrating CPAP. Probably we'll talk about that more in the workshop. But what about in-lab titration? If you look at this, what's our target? Our target is to have HI 5 or less, saturation more than 88, respiratory arousal less than 5. Patients should go into REM sleep and supine because they have more apnea while we do the titration to make sure that we have eliminated that. And we eliminate snoring. This table will show you when to increase CPAP during titration for children, and more than 12 is considered adults here. I'll focus on this one for the sake of time. So if the patient has 2 or more obstructive apneas, 3 or more hypopneas, this is what we call respiratory effort-related arousal. The definition is in your book. This will not meet the criteria of apnea or hypopnea, but the patient will be snoring, some reduction in flow, followed by arousal. So this also is not benign. You have to treat it. Or they have 3 minutes or more of loud, unambiguous snoring. If you have that, then you increase CPAP during titration by 1 centimeter of water. And then you have to wait at least 5 minutes between increasing the pressure. You don't have to do it quickly. Why? Because if you do it quickly, patient will not tolerate it, but you also create another problem called treatment emergent central sleep apnea, which is well discussed in your chapter. Several theories have been recommended for that. One of them is probably opening the airway will wash out CO2, so patient will have hypocapnia, but that you can read in your chapter. So this is an example of rapid titration. Pay attention here, please. If you see this one, again, this is the histogram, and this is the heart rate, saturation, sleep stages, the hypnogram. Respiratory events are hypopneas and some central apneas. The technologist was building pressure quickly, not following the American Academy of Sleep Medicine, and this what it causes a lot of central apnea, what we call treatment emergent central sleep apnea. So instead of having obstructive apnea, they will have on top of it central sleep apnea. It's called treatment emergent central sleep apnea. So one of the causes of that is rapid titration. Another cause is leak. If there is significant leak, wash out CO2, they may have hypocapnia, central sleep apnea. These are the 2 main causes. Then if we do home sleep apnea test, then we can do the unattended CPAP titration. And the results for unattended sleep titration in systematic review is as good, if not better, than attended titration. Auto-titrating CPAP, they use different algorithms by different companies, like changes in the flow, vibration because of the snoring, changes in the pressure. Different algorithms are there. And if you are going to buy auto-titrating machine or something, you have to make sure that the company provides you with validation, peer-reviewed, published papers for their algorithm, because not all brands, they have the same efficacy. Then you have to choose the interface. This probably will be discussed more in the workshops and in other lectures as well. We have nasal mask, which we like for sleep apnea. This is the first choice. And we have also nasal pillows. Some people like that. They have less claustrophobia. And full face mask and then total face mask here. And what we like usually is the nasal mask, because you require less pressure, less claustrophobia. When you put oronasal mask, you may require higher pressure for the patient. But the problem with the nasal mask that you may have leak through the mouth. So this is something probably we'll discuss more in the workshop. This is probably, you remember from your physics, what we call the Starling resistor. This is important when we talk about nasal versus oronasal mask, because for any flow to happen, we have 3 points. We have upstream, which is usually here the nose, and we have the pharynx in between, which there is possible collapse. So when the pressure outside is more than pressure inside, it will close. This is what we call the critical pressure that will cause the closure. And then we have the downstream, which is the trachea. So pressure at point A has to be higher than B and higher than C for the air to flow. This concept, well, we'll discuss more in the workshop when we talk about nasal or oronasal mask. Also, when the patient opens their mouth during snoring, especially in stage 3 sleep, the mandible will come closer to the hyoid bone. So this will put the genoglossus muscle, which is the airway dilator muscle, at a disadvantageous position for the tone. So this will narrow the airway as well and will put us closer to the critical airway closure point. This one, sorry, because the animation had been frozen, just to make it easier for the presentation.
5 minutes.
5 minutes? Okay. You have, like, when you, from the CPAP data, you can get a lot of information when you download data from the CPAP. You can have the efficacy. You can have also the number of hours used, efficacy by looking to the apnea-hypopnea index. You can check for for mask leak if it is significant. And you can look to the flow signal. Sometimes this is helpful, especially for ASP or when the patient has central apneas. Central apnea, just will cover briefly because we see it more in children than adults. It's not as common as obstructive sleep apnea. What we have to remember here is the Chine-Stork breathing. This is very important. We'll talk about it. And treatment emergent central sleep apnea. Chine-Stork breathing, we see it mainly in patients with heart failure and low ejection fraction, have been associated with higher morbidity and mortality in heart failure. So it looks like this, what we call crescendo-decrescendo pattern of breathing followed by apnea. Then the patient will start breathing again. This is an example of crescendo-decrescendo pattern. So this is an example of central sleep apnea. You can see it clearly as well. Here, I think this is clear, and desaturation. In this pattern, usually the arousal will happen at the peak of the breathing, not like obstructive apnea. By the end of apnea, they will have arousal. And just for your knowledge, if you look here, this we have the pressure, this ASP, and when the patient has apnea, the ASP will talk about it in more details, probably in the workshop. Adaptive servo-ventilation, it kicks in, and patients start breathing. This again, crescendo-decrescendo pattern, classical one. This is 5 minutes. Epoch. How do we manage? CPAP and oxygen. And of course, you have to manage left ventricular ejection fraction with medications. CPAP has been shown to improve ejection fraction, but in the CAMBAB study, the transplant survival was not better. But in post-hoc analysis, when they did, they found that if you reduce the HI to less than 15, probably you will have some survival benefit. What we call adaptive servo-ventilation that I showed you, this one here, we were excited about it, but studies, randomized control studies showing at least one study that there is probably higher mortality if you use it. Then when they did clustering of the patient, they found that those with ejection fraction less than 45%, they have higher mortality. So what we use it now, the recommendation, if you use it for Chine-Stork, make sure that the ejection fraction is 45 or more. Treatment emergent central sleep apnea, we talked about it, very important to remember. 2 things you remember here. Avoid rapid titration and avoid air leaks, because these are the commonest 2 causes of treatment emergent central sleep apnea. The last part is the obesity hypoventilation. This is a clinical diagnosis, but we do sleep study because 90% of them, they have obstructive sleep apnea as well. So these patients, they have awake hypercapnia, they have obesity by definition, and hypoventilation is not related to pulmonary, neurological, muscular, or congenital disorder. Almost 90% of patients with OHS, they will have obstructive sleep apnea. And if you look to the data in any of you in your lab or center, probably 10% of OSA patients you have, they will have also obesity hypoventilation. And many of these patients are misdiagnosed as COPD. They never smoke. They are usually obese and restrictive pattern on PFT. we were the first to report that there is probably gender difference in this group of patients. It's probably more common in women than men, not like OSA, which is more common in men than women. So this is probably a disease of postmenopausal obese women than it is a disease of men. This is a zoomed window, just to see here, almost done. This is here, you don't see any obstructive events. You see the EEG, and then you see the patient is breathing. There is no clear obstructive apnea or hypopnea or central. But if you look to the transcutaneous CO2 and end-tidal CO2, you see it's high, and the patient has sustained hypoxemia. So OHS causes sustained hypoxemia because of hypoventilation. That's why they are more prone to pulmonary hypertension. Remember that OHS patients, they have a lot of comorbid medical conditions that the medical doctors have to treat it as well. So how do we treat them? The American Thoracic Society, they have published guidelines for that. Briefly, they said if it is mild to moderate OSA with OHS, sorry, if it is severe OSA plus OHS, you can use CPAP as the first line. However, if the patient have OHS with apnea-hypopnea index less than 30, then they recommend bi-level positive airway pressure. So bi-level positive airway pressure should be considered in OHS without OSA, OHS and coexisting OSA with persistent hypercapnia, failure to tolerate CPAP, acute and chronic respiratory failure. So when do we use bi-level, not CPAP and OHS? If they have mild to moderate OSA with OHS, if they continue to have hypercapnia despite using CPAP, they may come sometimes with acute respiratory failure, hypercapnic respiratory failure. We use for them bi-level, not CPAP. They are admitted to the ICU or in the emergency room, and if they cannot tolerate CPAP. What are the key concepts that we want to send from this chapter and this lecture? And sorry for taking some extra time. The key concepts: apnea can be obstructive, central, or mixed. BSG is the gold standard diagnostic test for sleep-related breathing disorders, but unattended type 3 sleep studies can be used to diagnose OSA. The main therapy for OSA and OHS is non-invasive positive airway pressure therapy, which is applied via a mask in the form of CPAP or bi-level positive airway pressure. The correct choice of interface is essential for good positive airway pressure adherence, very important. Positive airway pressure tracking systems are able to track BAP adherence reliably. The American Academy of Sleep Medicine recommends that ASV should not be used to treat central sleep apnea related to congestive heart failure in adults with an ejection fraction less than 45. Thank you.
Thank you very much, Professor Bahammam, for this informative presentation. Our next speaker is Professor Arzu Ari. Professor Arzu is Associate Dean of Respiratory of Research at the College of Health Sciences, Department of Respiratory Care, Texas State University. Professor Arzu is not only a respiratory therapist, but also a physical therapist with more than 25 years experience as a manager, clinician, educator, and a researcher. Please join me to welcome Professor Arzu. Thank you.
Thank you. Thank you very much for the kind introduction, and I see so many familiar faces, and I enjoy seeing my former students here in the audience. If we haven't met before, please come see me after my presentation. Introduce yourself, because I would love to learn more about you, and answer your questions about aerosol therapy after my presentation. Before I start my presentation, I also would like to thank Mr. Hassan El-Arani and Dr. Jerome Sullivan for inviting me to this wonderful event. I also would like to thank Dr. Al-Katan for hosting us at this beautiful facility. So you see I wear green and white. You know the reason for that, I assume. I noticed that you... Thank you. I noticed that you celebrated your National Day this week, and I decided to wear green and white in honor of your National Day. So today I'm going to talk about... okay, how do I do this? I am doing this, but it doesn't work. Can someone help me? Okay, all right. How do I go back? Okay. I see, thank you. So today I have a lot to cover. So pay attention when I talk to all these subjects. We are going to start with the characteristics of aerosol therapy, and then I'm going to explain device selection, interface selection, delivery technique, cleaning and maintenance of aerosol delivery devices used for the treatment of spontaneously breathing patients and ventilator-dependent patients. We will also talk about how to optimize patient education and adherence to prescribed aerosolized medication. So what is the optimum aerosol particle size? You didn't expect to ask me a question, very obviously, but I love asking questions. So what is the optimum particle size? 2 to 5? I would say 1 to 5. That's good. If you were asked this question on the exam, that doesn't mean this will be on the exam, by the way, but if you were asked, please remember the ideal particle size is from 1 to 5 micron. If it is between 5 and 10 micron, it deposits in the conducting airway, and if it is larger than 10 micron, it will stay either in the nose or upper airways. So there are 4 types of aerosol delivery devices that are available on the market, including nebulizers, PMDIs, pressurized metered dose inhalers, dry powder inhalers, and soft mist inhalers. So nebulizers can be divided into 4 categories, including jet, mesh, ultrasonic, and smart nebulizers. So, I'm sorry. As for the delivery technique, your textbook has all these informations and you will have step-by-step instructions. So I'm not going to go over every step here in this presentation because of time constraints. But the thing that you will need to know, when you use the jet nebulizer, you should set the flow rate at 6 to 8 liters per minute to generate optimum particle size. If it is less than 6, you generate larger particle size. If it is more than 8, particle size gets smaller and may not be optimum in this particular situation. Also, it is operated by either oxygen or air, right? But sometimes we need to use it with a compressor. But jet nebulizers are designed to operate at 50 psi. And compressors, some compressors works at 13 psi, which will not be ideal for jet nebulizers. Therefore, it is very important to use the jet nebulizer and the compressor that are manufactured by the same company. That way, you wouldn't have any issue with the functionality of the jet nebulizer. Another thing that you need to pay attention is the residual volume and the fill volume of the jet nebulizer. When I say residual volume, I'm talking about the amount of drug that stays in the nebulizer cup at the end of the treatment. The more residual volume stays in the nebulizer cup, the less medication you give to the patient. And that's why it is called dead volume, because we never deliver this medication to the patient at the end of the treatment. It stays in the nebulizer cup and it is never aerosolized. So our goal is to have a nebulizer that has low residual volume, and that's something you can ask to the manufacturing company and see what their residual volume is, what the fill volume is, and what the particle size that the nebulizer generates. As for the fill volume, of course, we would like to make sure that we have enough fill volume to use with the jet nebulizer. If it is not enough, you can always increase the fill volume by adding normal saline to the nebulizer cup. However, remember, when you do that, you also increase the treatment time. Another option would be to use another type of nebulizer for your patient's treatment. As for ultrasonic and MASH and smart nebulizers, I recommend following the manufacturer's guidelines for their delivery technique, but nebulizers usually do not require a specific breathing technique, unlike inhalers. However, I must say that some smart nebulizer will tell you step by step what to do, and that's the beauty of using smart nebulizers. Cleaning and maintenance is extremely important for nebulizers, right? Because we would like to make sure that we do not contaminate the nebulizer and we do not cause any type of infection during nebulizer treatment. So how we are going to do that? Should we do it at the end of each treatment? Please say yes. Yes, you need to do it at the end of each nebulizer treatment. And all you need to do is to disassemble the nebulizer and rinse it with either distilled water or sterile water. Easy peasy, right? You can do it easily at your clinical practice, and you shouldn't dry it with a towel. You should let it air dry, and you can keep it in a clean surface so that it can air dry until the next treatment. As for the cleaning and maintenance of mesh nebulizers and smart nebulizers, once again, you need to follow the manufacturer's guidelines. Pressurized metered dose inhalers are most commonly used inhalers or aerosol devices available on the market. They are mostly prescribed because they are portable and they are compact, and the treatment time is very short, therefore it is considered easy to use. However, they are very technique dependent, so they require some specific breathing pattern to be used efficiently. There are two types of PMDIs. One of them is conventional PMDIs, that is regular PMDI that you see here in this slide. And in this particular PMDI, you basically actuate the PMDI manually, as opposed to breath-actuated PMDI that will be triggered at the beginning of inspiration and deliver the dose. So, as I said earlier, PMDIs are highly technique dependent. So there are certain things that you need to do. First thing is shaking the PMDI before the treatment, because propellant and medication will separate from one another if you do not shake it, if it keeps in a still position. And then you need to prime the PMDI if it is a brand new PMDI and if it hasn't been used more than 24 hours. If you do not prime or shake, how much aerosol reduction you may cause in the treatment, do you know? Almost 30%. So it's very simple procedure, but it may cause lots of reduction in the treatment. That's why it is important to shake the PMDI and prime the PMDI before the treatment. So after that, we need to make sure that the PMDI is used correctly, right? We need to make sure the patient takes the mouthpiece in the mouth, but do not block the mouthpiece with the tongue. The tongue should stay below the mouthpiece, and how the breathing pattern should be in the PMDI. Slow or fast? Who said fast? I don't want to hear it, no. If you use the PMDI, your patient should have deep and slow breath, okay? Should take a deep and slow breath, slow, definitely slow, not fast. And what she needs to do after that? Hold the breath, right? How long? 10 seconds, or as long as they can, right? And after that, you will let them exhale. You can remove the mouthpiece and exhale. How long you should wait in between actuations? Yes, at least 15 seconds or more, and then you can deliver another dose. Do you know why you should wait? There's a metering chamber in the PMDI which needs to be filled with the medication. So when you wait, you basically fill the metering chamber with the drug, and then the next dose will be available for aerosol drug delivery. So PMDI, this is the regular use of the PMDI without the spacer. When you use the spacer, we have basically two options, two reasons why we combine it with the spacer. Do you know why we are using the PMDI with the spacer? Poor hand-breath coordination is one of the reasons. The second reason, oropharyngeal deposition. He is my student. He knows it. Good, good. I'm glad to hear that. So there are two types of accessory devices available for the PMDIs. One of them is called spacer, and the other one is the wire holding chamber. It is important to understand the difference between them. The spacer is basically a simple tube, while the wire holding chamber has a one-way valve in it. And spacer is cheaper than wire holding chamber, but it requires a type of, hand-breath coordination. But wire holding chamber actually is a little better than the spacer and reduce aerosol losses with poor hand-breath coordination. When we would like to choose a spacer or a wire holding chamber for our patient, there are a couple of things that we need to pay attention. One of them is to choose a non-electrostatic wire holding chamber for aerosol drug delivery, because they deliver up to 4-fold more drugs during the treatment. That's a big difference, and that's why we prefer using non-electrostatic wire holding chambers. We also would like to make sure that the inhalation valve of the wire holding chamber functions properly, and use the wire holding chamber with smaller volume if you are using it for the treatment of infants and children. And that makes sense, right? Because children and infants have small tidal volume. It will take a lot of time and effort to empty the medication and the volume inside the spacer. That's why we prefer using smaller volumes, especially with infants and small children. Cleaning and maintenance of PMDIs are very easy. If you use the PMDI alone without the spacer, all you need to do is to look at the nozzle of the and see if there are any particles around it. If there is, you need to clean it. So that needs to be done once a week, and you can remove the canister. Never ever submerge the canister in the water. That's not ideal situation. But you can remove the canister from the container, and you can actually rinse the container and let it air dry. And you should do this cleaning in the evening so that it can air dry overnight. As for the PMDI accessory devices, such as spacer or the wire folding chamber, you should remove the parts, you should disassemble the parts, and then wash it with, immerse it with the detergent or with the water, with warm water with liquid detergent, and then rinse it, and then again air dry overnight. Dry powder inhalers are breath-actuated inhalers, and they have medication in powder form. There are 3 types of DPIs, unit dose DPIs, which includes capsules, and you place the capsule in the device and puncture the capsule based on the type of device that you use. You follow the manufacturer's guidelines. And multiple unit dose DPIs has a case of 4 or 8 individual blister packets, and every time when you use the DPI for the medication delivery, the blister turns and deliver the next dose for you. And the multiple dose DPIs can have either a reservoir powder system preloaded with 120 drug doses, or a tape system including up to 60 sealed single doses. So there are different types, and each one has a different delivery technique, so it is ideal to follow the manufacturer's guidelines to use the DPIs correctly. So here is a question for you. When the patient when your patient uses the DPI, should she breathe fast or slow? Thank you. You're the best. You're the best. Yes, fast is the right answer. And once again, if the patient is using a PMDI, you need to instruct the patient to take slow and deep breath, and they shouldn't hear the whistling sound if you use the PMDI with the spacer. The delivery technique is device dependent, so every device has a different delivery technique, so you need to follow the manufacturer's guidelines. As for the cleaning, it's very simple. All you need to do is to clean the mouthpiece with a damp towel. And never ever submerge it in water. And also, it is very important to keep it in a dry environment. We don't want to keep the DPI in the bathroom, for instance, because it will impact its functionality. Soft mist inhaler is propellant-free, single patient use, and multi-dose inhalers. They use the energy produced by spring compression and squeeze liquid formulation from the collapsible drug container through a proprietary valve. And you can read the delivery technique of the soft mist inhaler in your textbook. And it's very easy to use, and we will also cover this at the workshop tomorrow. Clinical efficiency of aerosol devices is important to mention, and according to previous research, nebulizers, PMDIs, and DPIs are equally efficient if they are age-appropriate and used correctly. So using the inhalers specifically correctly and doing the right breathing technique is extremely important. So when we are ready to select the right type of aerosol device for our patients, there are several things that we need to consider. One of them is your patient's age, physical and cognitive abilities, your patient's tolerance, preference, and acceptance of the device and interface. Also, drug-device related factors should be considered during your selection process. So let's say your patient needs aerosol treatment. So you need to determine the goal of therapy. And this is usually determined by the physician, but that's the concept. First, you need to determine the goal of aerosol treatment, and then select the medication that will help you achieve that goal. Let's say the medication is available only as a PMDI. In this case, the decision is made, right? You have to use the PMDI as for your treatment. If the medication is available as the PMDI and the DPI and the nebulizer, then you are going to think about the efficiency of the device, the cost of the device, precision and consistency of dosing, as well as the risks to other patients and providers. One of the things that I highly recommend you is to consider patient's preference. If your patient tells you that they don't like the PMDI, do not use the PMDI. If they come to you and say they love using the DPI, please use the DPI. That means they are able to use the DPI correctly and benefit from the medication. Otherwise, they wouldn't like the device, right? If they see that it benefits them and they improve, the symptoms get improved after the treatment, they like that particular device, and that's what you should choose. And we do not want to combine the devices. For instance, we don't want to give one medication as a PMDI, another medication as a DPI, because they have different breathing patterns. And we usually deal with elderly patients, right? And they have cognitive and physical impairments we should be aware of. That's why it is very important to be consistent with aerosol device selection. If the medications are available as DPIs, in this case, use the DPIs for all treatments. And if your patient likes the DPI, that will be the ideal treatment modality anyway. And same thing for the nebulizers.
5 minutes.
Oh my goodness. Okay. So patient education and spontaneously breathing patients are very important. We don't want to give a written instruction to our patient. We need to make sure that they understand basic facts about the patient's disease, the role of medications, the skills needed to use aerosol devices, daily self-assessment to monitor disease symptoms and conditions, as well as an action plan that will be needed when they have a disease exacerbation. There are several devices available that will help you educate your patient on the correct inhalation device, and those devices are explained in your chapter. If you haven't had a chance to read the chapter, please do so. But one thing that I would like to suggest is to train yourself about aerosol delivery devices. And the workshop tomorrow will help you with that. But take a proactive approach in this and learn about those devices. And evaluate your patient's inhaler technique, not only at initial treatment, but also at each follow-up. Provide written treatment plan, including actions and times, and simplify your treatment plan, because if your patient use the treatment once a day, they will be more adherent to treatment as opposed to 3 times a day treatment. Also, educate your patients about the medication, diseases, and risk. If they understand the benefit of the medication for the disease, they will be more adherent to therapy and they will benefit from the medication. Aerosol delivery to children is extremely important. We need to select the device and interface based on their age, physical and cognitive abilities, tolerance, preference, acceptance of the device, and delivery efficiency of those devices are equivalent as long as they are age appropriate. So how are we going to select those? I have a chart, figure 8, will tell you how you can make those selections based on the age, and there are different options for each device and interface that you can use for the treatment of children. When you select, let me go to this. When you select the device for ventilator-dependent patients, please know that you can use either a PMDI or a nebulizer to deliver aerosolized medications to ventilator-dependent patients. And the thing is, you need to use it correctly. And we are going to teach you how to use those devices correctly during mechanical ventilation. My colleagues will be helping me tomorrow at the workshop, and we are so excited to have you there. And once again, in the book chapter, you will have the delivery technique with the jet nebulizer and mesh nebulizer during mechanical ventilation. We will talk about this tomorrow, but you can read it at your textbook. Yes, please tell me you will read it before you come to the workshop. I don't hear you guys. Yes, I think you will read it. I trust you will read it. So I'm going to think that you will know everything before you come, and we will just have a good time. As for the PMDIs, once again, we will go over this tomorrow at the workshop. But do you see this red sign on the bottom of the slide? Do not turn off the heated humidifier for aerosol drug delivery. That is not needed. In the past, we always thought that we should turn off the humidifier, but that's not the case anymore. We learned from our evidence or recent publications that you don't need to turn off the humidifier to increase aerosol drug delivery to ventilator-dependent patients. So, key concepts. Aerosol is a suspension of solid and liquid particles in gas. The purpose of aerosol therapy is to deliver a therapeutic dose of drug to the lungs, and aerosol devices are either nebulizers, PMDIs, DPIs, or SMIs. You can use PMDIs, but remember it requires hand-breath coordination. It may be better to use it with spacers or wire-holding chambers. You can also use the DPIs, but DPIs require high inspiratory flow rate to remove the medication from the device and break it down to the inhalable particles. Nebulizers are less technique dependent and easy to use compared to inhalers. Also, when you select the device, please consider your patient's age, physical and cognitive abilities, as well as drug and device-related factors. And remember, we can use the mouthpiece if our patient is able to use the mouthpiece. When we use the face mask, we will need to make sure that there is a good seal between face and the mask. And otherwise, even a small leak will cause large reduction in aerosol drug delivery. Therefore, it is extremely important to have a good seal between face and the mask. And remember, the high-flow nasal cannula can be a good option for your patient. So I look forward to seeing you tomorrow at the workshop. And remember, you need to review the textbook before you come. Okay, thank you very much for your attention, and I would love to...
The questions will be at the end.
Do we have time for questions?
No.
Okay.
Thank you so much.
I would be more than happy to answer your questions after my presentation or during breaks.
Thank you, Teresa. Our next session will be discussing the airway clearance and lung expansion therapy. Please join me to welcome Carl Hinkson, the President of American Association for Respiratory Care and the Chair of American Respiratory Care Foundation. Carl has extensive experience in the field, and he is known for his commitment to advancing the profession. The floor is yours, Carl. Thank you.
Right. Thank you very much. Happy to be here. I think amongst the faculty of the staff, I have traveled the furthest. I came from Seattle, Washington, which took me about 27 hours to get here. Just for a quick show of hands, who are practicing respiratory therapists? Great. Who are respiratory interns or students? So we have a lot of students here. Okay, great, awesome. So I'm here talking about airway clearance therapy, suctioning, and lung volume recruitment. I assume that you have the textbook and are going to, fulfill Arzu's commitment to reading it tonight, and those are the objectives there and the key points. So we're going to talk about those things. And just to let you know, clinically, I worked for 20 years at a trauma center where I worked with a lot of head injury and spinal cord injury patients. And so this was one of the activities of a respiratory therapist that was always, didn't require reliance on the physician's orders, or this really was the relationship between my skill set and the patient to help them breathe easier, sleep better, and recover. So what is mucus, phlegm, and sputum? Mucus is basically a heterogeneous adhesive viscoelastic gel produced by the goblet cells. It is the lung's mechanism for cleaning itself and keeping itself working. Your goblet cells lining your airways, they produce mucin. There's two proteins there that make it somewhat sticky, and it sort of grabs stuff and it moves up towards the neck, and then you cough it out. The term phlegm comes from Greek for inflammation that is found in disease. It denotes the airway product resulting from inflammation, or dust, the refuge that the lung wants to expectorate out. So sputum is expirated phlegm, so now we have those three definitions. Mucus is what your lungs secrete to clean itself. Phlegm is sort of the disease process, and sputum is what the patients cough out. Now, when I was a respiratory therapy student, we worked alongside with a lot of nurses, and there was a running joke was, how could you tell the nurse from the respiratory therapist? The joke was you would put them up to their necks in excrement, and then you would flow sputum at them, and the nurses would duck. So mucus is critical to the airway's defense. It prevents the dehydration of the airways, right? So back when I was a younger respiratory therapist, if we did not adequately hydrate our patients when we were doing invasive mechanical ventilation, or if they were sick, those secretions would start to thicken, get really stuck with mucus, and they would start to plug the airways. The patient's sats would drop, and essentially bad things would ensue. So we developed a lot of our therapies and our techniques, our medications to try to move those along so that the patients could expirate and clear the inhaled particles and keep the airways clear. So how does the mucus normally get cleared? Well, it gets cleared because your lungs are lined with cilia. These are these hair-like protractions that are lined, hair-like protractions that help with coordinated mitochondrial beating of the cilia, which means they basically beat in one direction that moves all the sputum up towards the neck, right? Up to your trachea, and then you feel it in the back of your throat, you cough, and it comes out. Most mucociliary dysfunction is due to a primary abnormalities of the cilia, and we call that a primary cilia dyskinesia, or secondary, or it can be secondary to chronic inflammation. So as you heard from Dana's lectures and some of the other lectures, when we reach disease state, that impacts the cilia's movement of mucus up towards the throat. I keep hitting the wrong button here, I apologize. It can also be, there's also a few genetic diseases that can cause this you might want to be aware of that create ciliary dyskinesia, but it's often as a result of airway disease. Any changes to surface fluid loss or the epithelium due to inflation can impact cilia control. And mucociliary coupling, so this is a microscopic vision of this. Now what's important to kind of note out is that when we look at how the goblet cells make the mucus or the phlegm, they secrete the thin liquid stuff, and then the mucin kind of lines the top, and it creates what we call the gel layer and then the sole layer, right? The sole layer is the more liquidy part that is the cilia beat along, and it is easy to beat that along. And the gel layer is the stuff that the particles and the DNA and the refuge from inflammation stick to. And as it beats along, it moves everything towards the head of the neck. When mucociliary clearance is overwhelmed in disease states, high velocity airflow or cough clearance is a secondary clearance mechanism. Cough clearance depends upon the improved mucus cohesion and lack of adhesion, meaning it sticks together but not to the surface of the airway. Things that can impact that include low sputum tenacity and higher airway or higher airflow. So when we think about some of our, the way I'm a simple person, right? I'd like to think about it in simple terms, right? Can the patient take a deep breath and cough, right? If we look back at the mechanisms of a cough, we take a deep breath, we fill our lungs up almost to total TLC capacity, our glottic closes, we bear down, we create a high peak cough flow, and the sputum expirates up towards the back of our throat, and then we either cough it out or we swallow it. When we think about what impacts those dysfunctions, there is an impact somewhere along that mechanism that causes that cough to be impaired, right? Is there a change to the quality of the sputum? Is the patient dehydrated, so now that sputum is thicker, so their ability to cough is now impaired, right? I'm looking at an elderly lady. She's now got thick secretions. When she takes that deep breath, she doesn't have enough FRC to generate an ability to cough. Or is this a spinal cord injury patient who, because of their injury, somewhere along their nervous system, they don't have the ability to bear down high enough to get that sputum out, right? Somewhere along the line, we have changes in the mechanism of cough that impair the patient's ability to cough. So in this particular graph, we see that tenacity, which is the quality of the sputum along this line, since measured in dynes, changes, and the cough clearability. There is a definite correlation between the tenacity of the sputum relating to low tenacity is better, higher tenacity is not awesome, and it impacts their clearability. So there are a couple ways that we look at this and we approach trying to assist patients with cough. One approach is trying to use mucoactive medications to try and assist us. There's a lot of the over-counter stuff. A lot of our cystic fibrosis patients will consume some of these products. They are indicated when to improve the properties of oops, that's the wrong button. I will get this by the time I'm done today, I swear. They're made to enhance the clearance, to decrease excessive secretions or in a hypersecretive state, or improve ciliary or cough function. So there are several types of mucoactive agents that are on the market. There is one is called expectorants. Expectorants is hypertonic saline or mannitol. Mannitol is not used in the United States. Now, how many have ever given hypertonic saline to help someone cough? Just because they are overwhelmed. How many have used hypertonic saline to what we do call a sputum induction? Okay. In my career, I have a lot more experience using hypertonic saline to induce a sputum induction. That was usually somebody who could not produce any phlegm, and so the pulmonologist did not want to bronch the patient, and so they would have us come in and use 9% hypertonic saline. And what the hypertonic saline would do is it would draw the fluid, the epithelial cells into the mucus and really loosen the mucus up, right? When we think about what changes can we make to improve the patient's ability to cough? If the secretions are too thick, can we make them thinner? And this was one mechanism that was done. Mannitol achieves it pretty much the same way. The research for using this approach demonstrates it's not really an effective technique for patients with chronic lung disease. Another class is classical mucolytics, and this would be acetylcysteine, or in my country we call this mucomist. And it delivers sulfide bonds which break up the bonding around the mucin molecules. It smells really bad. How many of you ever delivered mucin? Yeah, it smells really awful. And in the COCF population, it was used quite a bit, but clinical practice guidelines are demonstrating that this is not really an effective method for using it. And then there's peptide mucolytics. This is Dornase. These hydrolyze the DNA bonds that are in the DNA that's in the mucus, and it kind of breaks it down. There is evidence to support Dornase in CF patients. And then we're looking at our mucoregulatory agents. These are our anticholinergic agents, our glucocorticoid steroids, and macrolide antibiotics. And what your anticholinergics do is they decrease the inflammation and decrease the secretions. And so when we think about what techniques can we do, what medications do, we want to somehow address the quality of the sputum. If it's thick, are we going to give an agent that thins it? If it's thin, if they're like bronchoreek and they have a lot of thin coughing, can we thicken it up so they're not coughing it so much? And then there's other agents that are cough clearance promoters, bronchodilators. So if you have a patient that has poor airflow obstruction and you're giving a bronchodilator, that opens the airways up and it allows them to get more air in. And when we think about, again, we go back to that cough mechanism, right? They need to be able to take a big breath in, get a good total lung capacity bear down. And when we think about asthmatics, the problem is, I've always learned, it's not that they can't get the good air in, it's that they have a problem getting the bad air out. So if we can open up those lungs a little bit more, then they can expirate out some of the bad air and some of the phlegm out as well. Surfactants have been given. In some instances, it decreases the sputum's adhesiveness to the airways. And what I will say is, outside of CF, most of these agents have not been proven to be really effective in the long run. Mucolytics are divided into two classes, as we discussed on the previous slide. Acetylcysteine and AC was the prototype. And other classic mucolytics have not been shown to be effective in the treatment of airway disease. However, the peptide mucolytics, which is pulmazine, and Dornase are effective in the treatment of congestive heart failure, but not in any other forms of lung disease, pneumonia, COPD, non-CF bronchiectasis. They're probably considered unsafe. One of the jokes that we used to do when we had to go deliver amongst the staff, when we used to do a sputum induction with hypertonic saline, it's like, be careful, you won't be doing a sputum induction, you'll be doing a vomit induction because it's so nauseating to the patients. So this is a discussion from the alpha Dornase trial for diseases other than congestive heart failure. It was published by the original author of the chapter, that they stopped the trial for futility. They were looking at alpha Dornase in patients with chronic bronchitis, chronic bronchitis, and after it was intended to recruit 5,600 patients, and they stopped it after 244 patients for futility because they realized that even at that level they weren't going to get to clinical significance. So the point I want to bring up is there's a lot of medications that are out there, but outside of chronic cystic fibrosis, for chronic lung disease, they don't tend to be very effective. Other mucoactive agent medications, including expectorants and saccharides. I mean, this is a long list of really long words. Mucolytics, mucospecifics, and mucoregulatory medications, with the exception of anti-inflammatory medications like corticosteroids or immunomodulators, mucus modulators such as macrolides. There's very few supportive use of this data supporting any of the medications, right? So sometimes it might be better to make sure your patient's well hydrated to facilitate a cough and work with them on coughing than administering some of the medications. This is from a study looking at a very common over-the-counter medication in the United States. Oops, I did it again. What we call Mucinex. In the United States, pharmaceutical companies are allowed to advertise on our TV, and you probably can't watch a football game or an American football game without seeing at least 2 to 3 Mucinex commercials. But this was a study done by the author of the chapter, and this is a Wisconsin respiratory score looking at symptoms of cold-like symptoms. And they did a Mucinex control and a placebo. And what they found is from day 0 to day 8, there was really no difference in those scores between those two patient populations, demonstrating that the Mucinex really didn't help improve it for the patients with chronic lung disease, which means that it probably entertains the patient more than it treats the patient. So airway clearance therapy, which is meant to augment mucociliary cough clearance using breathing techniques or other devices to promote clearance of retained secretions. This is a lot of the bread and butter that I did for many years. There's a lot of devices that are out there on the market, including high-frequency chest wall compression devices, positive expiratory or PEP devices, oscillatory PEP devices, and intrapulmonary percussive ventilations. We use the acronym ACT for this, but even with these techniques, the evidence for doing these is really limited. Postural drainage or turning the patient to tip their head down to use gravity-assisted mucus clearance has not been shown to be more effective than chest physical therapy performed without postural drainage. So when I was a younger respiratory therapist, first introduced into the world, we would often get orders for doing chest PT. It was a running joke that the physicians, whenever the patient would leave the ICU, they would hit the acute care floor and the physicians would order bilateral CPT, right? And then we would ask, why do you want to do this? There's nothing there. And they said, well, it's transfer atelectasis. It would be very time consuming for us. Now there's a couple ways that you can do chest PT. You can do it by hand. In the United States, we often use a percussor. And it's you put the patient into position, you put the percussor over the affected area or the ordered area, and you percuss. I think the book says 30 seconds or 3 minutes, I forget. I never did it for less than 8 minutes. That was what I was told. But putting the head down in the Trendelenburg position, which is not recommended in the book, and I would kind of ask you to remember that because they cite that the postural drainage increases the risk of gastroesophageal reflux and increased cranial pressure. Now, I did work with a lot of head injury patients who had a lot of ICP monitoring, so we would watch that, and we would often do those patients in the flat position. But again, we no longer do postural drainage. And then what I'd always heard from some of the older people, to do postural drainage, you would actually have to leave them there in a really long time. And they didn't, and the patients did not enjoy that. The cough assist, the mechanical insufflator, it is a very effective tool for patients with neuromuscular dysfunction who cannot generate an effective cough. So when we go back and we look at what's an effective cough mechanism, we take a deep breath, we get to total lung capacity, we bear down, our accessory muscles create a lot of negative pressure, and we expirate our sputum, right? That is our peak cough maneuver. And when we think about spinal cord injury patients, we always say C3, 4, 5, keep the diaphragm alive. Those patients have limited peak cough flow. And the book mentions a peak cough flow of 160 liters per minute. If the patient can't achieve that minimum peak cough flow, they are not able to generate enough force to shear the secretions, the phlegm off the airways to cough it up. And I probably did a lot of what we called MIE therapies because we were a regional referral center for trauma patients. So we had a whole, I will be the one demonstrating this at the skill station, and we'll go through that and how we did that. Aside from this, you can also do a manual cough as an abdominal thrust, timed with exhalation after breath stacking. So this is something that I would do with the patients. We called it quad coughing. We had to change the name after a while to be more politically correct. But this was something that you would time with the patient, you would push on their belly to help them cough. And for those patients who had spinal cord injuries, this was a very effective way to keep them clear. Now, for the spinal cord injury, a pneumonia is a very debilitating event.
5 minutes.
Awesome. Suctioning of the airway. Suctioning of the airway is to facilitate the removal in patients who are unable to do so because of weakness or because of the other presence of an artificial airway, such as an endotracheal tube. Now, I've often heard this referred to as one of the most invasive procedures that we've done. I would say, one of the primary ways, it's risk, one of the high risks because it can cause bradycardia, laryngospasm, hypotension if done incorrectly. The best way to prevent all those contraindications or challenges is with adequate pre-oxygenation. We'll demonstrate this tomorrow, but you want to use whenever possible, especially with a artificial airway, closed line suctioning unit. We even developed our own inline closed suction catheters from where we worked with trach collar patients because it was just much easier to bag and suction the patient there. You can also do open suctioning, but that requires a secondary level of skill. Now, this is an important point that's made in your book. When you suction the airway, you want to know where the tip of your artificial airway ends. You should not be extending the suction catheter beyond the tip of that. Now, the reason for that is the first thing that the tip of the suction catheter is going to encounter is called the carina. That's where the lungs split into. That is the highest cough reflex in the human body, and once you touch that, you're going to cause a lot of spasm, and you also can have the challenge of you cause injury. When we would bronch patients in the days of when I worked in the ICU, we would often, when we do bronchs, they would note that there was a lot of trauma suction injury around the carina. So you want to prevent that by limiting how far you advance the endotracheal tube. Also, we want to limit the amount of saline that we use when I came into the field, you would use a lot of saline to break the sputum up to try and ease it out. Research has shown we want to use as minimal possible. You're also in danger of breaking up the biofilm that lines the endotracheal tube. So when we intubate somebody and they're ventilated 2 to 3 days, a biofilm forms on the inside of the endotracheal tube. And if you break it up, you can break it up like a brittle candy, and flakes of it will start to fall lower into the patient's lung, which is not advantageous. So lung volume recruitment or lung expansion therapy is used to increase therapy. Again, we go back to that cough mechanism. We want patients to be able to get up that total lung capacity. So this is basically asking the patient to either take a series of deep breaths without exhaling fully, so that by the time they get to cough, they're almost total lung capacity. When I would work with spinal cord injury patients, we'd actually take a bag with a mouthpiece and we would help them bag up over a series of coughs. And then that total lung capacity, we would have them cough. Incentive spirometry is the most common used device for this, given most patients postoperative. This helps them take full deep breaths to total lung capacity to prevent atelectasis from sitting in bed. The data on incentive spirometry is fairly limited. I will say the AARC published a clinical practice guideline that said getting the patient up to walk was superior to incentive spirometry, which is why PT and OT is consulted on everyone. Except for sickle cell anemia. That was a joke for those who work in America, because PT-OT gets consulted on everyone. And as like I said, stacking breaths in patients with nuclear muscular illnesses is often very useful. All right. I think I made it on time. Here are key concepts. I got 3 slides of them. They're in your textbook, and as Urzu said, you guys are going to go home and read the textbook tonight. And be ready for the test tomorrow. So thank you for your time.
Thank you, Carl, for your informative lectures. Please join me to welcome Dr. Ibrahim Mahmoud, who is infectious disease consultant and the program director for the infectious disease fellowship program in King Abdulaziz Medical City, King Faisal Specialist Hospital. Welcome, Dr. Ibrahim.
Thank you very much. Bismillah ar-Rahman ar-Rahim. I'm really delighted to be here today with all of those respiratory therapists, pulmonologists, and intensivists, but let's switch gears into infection, namely RSV infection, respiratory syncytial virus infection. And how does it pose a problem in older adults? Okay, so in this sponsored talk by GSK, is it working? The green one? Okay, but it's not working. No. Oh, it's not moving. Okay. Oh, can I switch it from here? Sorry for this technical issue, but I hope that you are still interested. Is it fine now? Okay. So I should light into the first licensed vaccine for respiratory syncytial virus for older adults more than age of 60. Through this presentation, I will take you through how RSV poses a significant problem for older population and how can we prevent that through vaccination. I'll start with this real scenario that I hope that you find it interesting. So 41 years old male, status post stem cell transplant presented to emergency in December, winter month, with throat pain and shortness of breath. Initially, he was requiring 2 liters of oxygen, but started to deteriorate very rapidly, started to require non-invasive ventilation, and shifted to ICU. His chest X-ray showed bilateral infiltrate, and as you can see, his CT chest showed some of the bilateral ground glass opacity. In my hospital, when we do testing for flu or COVID, all of the 3 tests of flu, COVID, and RSV come in one. So he was tested, and RSV turned to be positive. I will not talk about what is the best way of ventilation and the aerosol and all of those, because he will take care of that. But for our side, he was started on ribavirin and IVIG. He started to improve, stayed a few days in ICU, and after that, he was not requiring any more oxygen. So that was an example of RSV in adults who are immunocompromised or having comorbidities. But actually, RSV can infect all age population. Probably we do not need to emphasize the importance of RSV in children and infants, because that is very well recognized and known. But we often forget our older population who are at risk of having severe disease. RSV is highly contagious, is transmitted through inhalation, and through the mathematical modeling, it is expected that a patient with RSV will infect around 3 persons around them. From virology point of view, RSV is an RNA virus. It has 2 surface protein, which has an important role in the pathogenesis of the RSV. And the virus is classified into type A and B. That is based on the antigen which is present on the surface protein. RSV is usually very active in the winter season, similar to the other viral illnesses, viral respiratory illness, and it can cause upper respiratory tract infection or lower respiratory tract infection. All of that will start with the attachment to the nasopharyngeal or conjunctival mucosal membrane, and after that it will descend into the whole respiratory tract system. In the cellular level, it can cause epithelial cell necrosis, which lead to airway obstruction, decreasing lung compliance, but not only that, it may have further complications like cardiovascular complication. It's very difficult to differentiate between RSV and the other viral infection because it shares similar presentation, particularly the clinical presentation, whether on an upper respiratory tract or lower respiratory tract as a pneumonia. Definitely, it is essential to know how significant or how important is the disease by knowing the burden of the disease. So this is a study that was done in older adults more than 60 years of age in industrialized countries, and estimating that the RSV accounted for around 5.2 million acute respiratory infection yearly, around 470,000 hospitalization yearly, and around 33,000 deaths per year. Why older adults? Because when we are growing old, our immunity will actually become much less effective. And if you want to add for that having comorbidities, because a lot of comorbidities cause a much higher risk for RSV and its complication, as we will see. So if you combine both age and the comorbidities, that will result in much severe RSV infection and poor outcome. RSV, for those who get COPD, actually get a 13.4 times more likely to be hospitalized compared to those who does not have COPD. A similar rate actually has been also documented for asthma, where asthmatic patient has 3.6 times more likely to be hospitalized if they have RSV infection. That was respiratory comorbidities, but what about cardiovascular comorbidities and metabolic or endocrine? That risk actually can go up to 11.4 times higher likely to be hospitalized for those who are diabetic compared to non-diabetic. All of that showed how significant or how the comorbidities can contribute into the outcome of the RSV. However, the actual burden for RSV is definitely underestimated in older adults. Why is that? Because we are not considering that among the differential diagnosis when an elderly presents as pneumonia. Not only that, but not a lot of centers has the molecular testing to identify RSV. So let's see from Saudi Arabia what is our data regarding that. This is a beautiful review which has involved many studies in the area or in the region. You can see here those who get red star are the studies reporting RSV, while the green one does not report RSV. And you can see here through the different years, there are different sample size. Some of them actually get large sample size. But the prevalence also is very variable in the RSV positivity. Also, there are variability in the method using to detect RSV, starting from previously culture, which is not used anymore, going to the PCR, which is now probably the standard of care. But there is a consensus among all the studies about how predominant is RSV in the children and how is the very low number of patients among the older adult. Here is an example of the study, around 1,200 samples, and among those, only 8 samples were in elderly more than age of 60, which is less than 1%. In the literature, there has been a lot comparing RSV and influenza because they share a lot of similarities. They have the same season, they are active, and you cannot differentiate between the two. However, in this study, if we compare influenza to RSV actually get a higher severe outcome. So RSV, the odd ratio of having pneumonia, if you have RSV, was around 2.7 times compared to influenza. And that explains why there is a difference in those different metrics comparing RSV to influenza, where RSV resulted in higher hospital utilization in terms of length of stay, more respiratory outcome, and survival and ICU admission. So what is the solution? Definitely we know that the prevention is better than the treatment. And a RSV vaccine, which has been licensed by or approved by FDA in May 2023, is the first RSV vaccine that has been licensed for older adults more than age of 60. As every other vaccine, you need to induce immunity. And this immunity is important, particularly for older adults where there is a decline in their immunity, particularly for RSV. And that is the vaccine which is active against RSV A and B. It contains the antigen, which is RSV F3 antigen, and adjuvant system, which help to boost the immune response to the vaccine. The evidence which licensed or granted the approval for the vaccine is this landmark trial, where older adults more than age of 60 were enrolled into 2 arms, whether to receive the vaccine, 12,000 patients, and the other arm to receive the placebo. That was in 17 countries. Following that, the vaccine was given in the pre-season, which is August and September, and they were followed for 1 year to see what is the efficacy of the vaccine and what is the number of RSV confirmed cases at the end of the first year. So that was the primary endpoint, but they want to include other secondary important endpoints, including the safety, the immunogenicity, and subgroup population related to different outcomes. The two groups were very well balanced in terms of age, gender, race, type of residency, but more importantly, related to comorbidities, the coexisting condition, the comorbidity index, and the frailty status. What was the outcome? So here is the endpoint. So among 12,466 recipients of the vaccine, only 7 cases of RSV was reported, compared to 40 cases in the placebo, where for severe RSV infection, it was only 1 among those who were vaccinated compared to 17. And that is translated into an efficacy of 82.6% in those who are aged more than 60. And among the protection regarding severe disease, it was more than 90%, 94.6%. If you want to see that among age of more than 60 or more than 70, the protection is around 81% among the age of 60 or to 69. And between 70 and 79, the efficacy is 93%. Not only older adults are important, but those who get also comorbidities. So this is subgroup analysis of those who get comorbidities. If you get 1 or more pre-existing comorbidity, the efficacy is 94%, where those who get cardiorespiratory comorbidities like congestive heart failure, COPD, asthmatic, the efficacy is 92% and may reach up to 100% in those who get endocrine metabolic comorbidities. It's important to know that the efficacy is more or less the same across the subtypes of RSV, A or B, and there was no difference between that, whether in upper respiratory tract infection or lower respiratory tract infection. Since we know that it's effective, we need to demonstrate that it's safe, and that was shown. So among the safety profile, any solicited reaction is common, and that is somehow expected, where around 72% of those who get the vaccine get side effect. But also, quarter of those patients who receive only placebo actually reported side effect. But we care most about grade 3 or severe side effect, and that was only detected in 4% of those who get the vaccine. And the most common was pain and erythema, most likely pain, which was around 60%. What about systemic side effect? Fatigue, myalgia, and headache were the most common side effect after taking the vaccine. The good news is that since the winter is coming, you can get the 2 vaccines of influenza and RSV both in the same time, and there is no contraindication of giving the 2 vaccines together and the co-administration of the 2 vaccines. The dose is 0.5 ml, and it does come in the 2 vials, and you need to mix them. So I think through this presentation, I showed you how effective is the vaccine and how safe is the vaccine. But getting back to the first scenario, how good is the vaccine in those who are immunocompromised, since the vaccine was not tested yet? This is the unmet need, which is the question that has not been answered yet. By that, I'm concluding my presentation. I hope that you enjoyed this talk. Thank you.
Thank you very much. Thank you, Dr. Ibrahim. Thank you all for attending our morning sessions, and by these lectures we conclude our sessions, and it's time now to start the lunch and prayer break. Thank you very much.
So we are going for a break until 1 sharp. Please be back here. We will start in the same time. Lunch is downstairs, okay? Thank you very much, everyone.
feel so free. Unlocking secrets of the universe. Enlightenment. Merge up as light as a feather. I wonder if I'll ever grace the sky with you forever. When it feels like we are clouds caught in heavy, stormy weather, I want you to transcend realities. I feel so free. Unlocking secrets of the universe. Enlightenment. Merge up as light as a feather. I wonder if I'll ever grace the sky with you forever. When it feels like we are clouds caught in heavy, stormy weather, I want you to transcend realities. feels like we are clouds caught in heavy, stormy weather. I want you to transcend realities.
function testing. Me and my colleague, Dr. Abdessalam Zahrani, will be the moderator for this session. I think this is the most difficult session because it's after in the afternoon, after you had the lunch. So we will start this session with Dr. Douglas Gardner Heyer. He is a clinical professor and the chair of the Department of Respiratory Therapy and Governor's Research Fellow at Lewis College Nursing and Health Sciences Profession at Georgia State University. What take my attention from his biography that he got $1 billion as a fund for his research. So we need another lecture for this on how to get this amount of funding. He wrote a lot of book chapters and obtained a lot of awards. So welcome, Dr. Douglas, to present fundamentals of respiratory care pharmacology.
Thank you. Thank you all. So thank you. Thank you for the warm welcome. What a pleasure to be here, to be in front of you. Hopefully you'll stay awake after all of the lunch that you had, but we'll go ahead and get started. So these are the objectives that we have. I will not do any disservice to you. I know that you could read those, so I'll just give you a second to kind of glance over them. But again, they gear everything towards what we're looking for in this presentation and hope that you'll be able to take home and be able to learn from. So with those, we're going to cover a couple of different sections, really. We're going to look at some of the pieces of how we get to where we're looking at for the drug, and then we'll cover some of the drugs, which I think sometimes is the most important that we think about because of how we're going to be using them every day. So the first thing in what we're looking for through the use of these drugs is that we are looking through the administration process of how that drug is made available. So we're looking at the dosage form, how that it is going to be utilized, the route in which it's going to take through the body, and ultimately how that formulation is created. So we know as a respiratory therapist and what we're using, we're mostly looking at all of our aerosol devices, and those are going to be formulated differently, and there's going to be additives in that medication, whether it's going to be given through a DPI, an MDI, or through a regular jet nebulizer. Ultimately, looking at the course and the disposition of the drug as it moves through the body, we understand that the drug is going to be absorbed, we're going to be able to distribute it to where it needs to be, we're going to metabolize it and eliminate it. And we'll talk a little bit more about those. So when we look at metabolism, this is again key, and I think a lot of times where individuals forget the behind-the-scenes process of what's really going on with the metabolism of the drug, which can be just as important as we are looking at in terms of the delivery. So the usual site is going to be the liver. That's where all the metabolism is going to occur. But what's important is to understand that the body will also make enzymes. So this is an enzyme induction that, again, is created. And what that happens is we forget. This a very easy example is looking at taking pain medication. So we have individuals who, again, take pain medication, and sometimes they abuse that pain medication. So normally we would think if you had pain, you would take the medication and you would get the response that the pain would be relieved. However, because of the repeated use of that drug over and over again, and sometimes the abuse and overuse of that drug, the body creates this enzyme in terms of the induction of that, and then it's going to metabolize that drug much easier, quicker, so that the response is going to be a lot less. So what that does is it just makes that cycle go again and again, where we're trying to get more and more drug. And so to do that, we have to take higher and higher doses more and more often. And so it's a perpetual cycle. The other second part that's most important is the first pass effect. Understanding that drugs and how they are formulated and created, if we're looking at that in terms of chemically, we're going to have some drugs that are going to have a high or, again, a lower first pass effect. So that first pass effect is very important in how we're looking at talking about the LT ratio, which we'll go over a little bit later, but understanding for us the first pass effect because of the drug going in the body as an aerosol, but it's also going into the body through the gut. So we have that where it's going to go into the back of the oral pharynx, we're going to swallow, and some of that drug is making its way to the gut, and then we have a first pass effect, which then we're going to reduce because of that metabolism with that agent. And that's going to be a positive thing for us to help control some of the pieces that we're looking at, depending upon how we are performing that therapy and what you as a respiratory therapist need to be understanding and why that education is so important for the device. So this is what we just mentioned just a minute ago for the first pass effect, and understanding as when the drug comes into the stomach, depending upon what that percent is, then through this portal vein, it's going to be shifted directly into the liver and metabolized, meaning that that drug is not going to be available for use. For example, which we'll see that here in a minute, albuterol, very common, has a 50% first pass effect, meaning half of what makes its way here becomes neutralized in the liver because of metabolism, because of the first pass effect. That's helpful for us because it's going to reduce and help a little bit with our LT ratio. But there are other drugs that have a little bit higher level, and we see a lot of those with corticosteroids that are in a much higher level, closer to 80, 90%, that again come through there. Then of course, elimination is primarily within the kidneys. However, there's other organs that are working through in terms of the intestines in helping with the elimination of the drug. So as I mentioned before, how is that form available and what is it that we're doing and why is that so important to us? So ultimately we're looking at a local effect. So that local effect, which is again, we're looking for this systemic versus non-systemic piece. A local effect is that we're using aerosolized agents as respiratory therapists to have that local effect. We're making local application of the drug onto the airways. That's what we're looking for in terms of the terminology of the local effect. Versus a systemic is if we were to take that albuterol totally by a pill and we're looking at that systemically. More often we think of a systemic effect as having something such as IV or intramuscular injection that we see maybe with morphine or insulin. So there's different effects, and that again is going to change the systemic side effects. And that's crucial in what it is that we're doing. So remember, the number one thing that we look for in aerosol medicine is to give that local effect so that we can reduce those systemic side effects. That's the big take home and why we are giving aerosolized medication. We get to give it in a much smaller amount directly to the lungs versus a larger amount and making its way all the way through the body to get to where we're trying to make that occur, which is in the lungs itself. Mentioned earlier just about the LT ratio. This is important to understand because we're looking at you as the respiratory therapist because there's so many different changes that occur with the use of aerosol devices. As Dr. Ari pointed out, we talked about, she asked, is it high or low in how you're breathing with certain devices? And education is number one in helping with this LT ratio. Now, the first pass effect will also be helpful in determining that because all we're looking at doing in this LT ratio is doing a little bit of math where we have a numerator and a denominator and understanding how that works. So this is the example that I mentioned. Albuterol, 50%. That's the first pass effect that it's going to have. So it's got middle of the road, a first pass effect. So if we are saying that we have the ability to get about 30% of the drug into the airway, that's going to leave us with about 70% that may make its way to the stomach. So we're saying that we have all this oral impaction and we're swallowing and it's making its way down into the gut. Because of that 50%, now we can see that 35% first pass effect is eliminated, where now we have the GI absorption of 35% that's making its way systemically. Through that, we can create the LT ratio. So here's the L and the T. Remember, the L is just the lung dose, and then we have the total, which is the lung and the gut, and now we have 46. 0.46 is that ratio, or we could say 46%. Normal is going to be where we're looking for, we're going to have a range between 0 and 1. The higher that we can get to 1, the better that device is going to be. So that's where you come into play. So we need to make sure that we understand the device, understand how it's used, and making sure that we educate the patient so that they understand explicitly how important that they do that use of that device over and over and over again the correct way. That's the most important. Because if we can continue to increase that and do better, that means that we can help with this part. Now we understand that we can help that with some of the newer formulations that are there. That might help. But if we're doing it poorly and we're instructing poorly, then this is where we have the biggest effect. This is always going to remain the same, but if we can get more to the airway, less to the stomach, then we're going to have a better LT ratio, because that now we're going to have that numerator hopefully being closer and the denominator being closer together, which we're going to get approaching closer to 1. Hopefully that makes sense, because I believe that it's very important in the understanding as we make our way through. So if we look at our pharmacodynamic phase, before we were looking at kinetics, the movement of the drug. This is the dynamic part. This is what we're looking for, the intended response. And so that is where the drug makes its way to the receptor, and we actually get the effect that we're looking for. Whether that's the direct effect or indirect effect, we're looking to have that drug go into the receptor site. So as we transition from how we're utilizing the background of the chemicals and how it makes its way through the body, we'll look at what's very important to us, all of our different bronchodilators and other medications that we use in aerosol medicine and in respiratory therapy. So if we look at beta-2 bronchodilators, we have several different categories. So this is what I consider the front door, as short-acting agents. These are, again, very common. Some of those you see there, albuterol, levalbuterol, being very common around the world. And what's also important to note is that we use these for very, if you will, acute emergent situations, and you may see that termed rescue agents or rescue inhaler. You'll see that used quite a bit throughout different parts of the literature. But what's also important, which we'll talk about here in a little bit, is to understand what these agents do in terms of rescue agents and what has really happened in the change in the treatment of asthma and the literature that's been produced, where now we're seeing that albuterol, for instance, has been used for 50 plus years as the number one agent to treat asthma in this urgent, acute situation. Now we're transitioning to see that we might use this not only here with albuterol, but also a corticosteroid. So as you look through those GINA guidelines, we really see this transition occurring, that we have some differences in what we have been doing for many, many years to what now some of the new evidence is suggesting. So those are some common ones that we have here. Of course, listed on there are not only our beta agonists, but also some of our long-acting, as well as our ultra-short-acting epinephrine, which we'll talk about there in a little bit. What I think is most important on this slide is what we'll talk about later in the afternoon when I talk about PFTs, is to understand where we're looking at in terms of the time and course, where that onset is. Because when we start looking at post-bronchodilator studies for PFTs, I think that comes into play very well in terms of what we're waiting for. In terms of when we give a bronchodilator, how long is it that we're waiting? And so we can't wait only a couple of minutes if we're going to be using albuterol, because the onset is about 15. So we may see 10, 15, 20, 30 minutes that we'll be waiting. So if we look at long-acting agents, these are what's considered more maintenance or controller agents, and those, again, are very common. You'll see those that are all listed there. Here's, I think, the important thing from a perspective of a practitioner, and we experience this all the time with our students at Georgia State as they're practicing, is that, especially in America, we have what I consider a history of use issue, in that we have prescribers who are prescribing these drugs because it's just what they know and what they've always done. And just because what you know and what you've always done doesn't necessarily make for a happy therapist or for a happy patient. So we have to kind of make sure that we're all on the same page. Where what's common, as we see, is that they give albuterol along with one of these long-acting beta agonists in the acute care setting. When you add both of those beta agonists, because they're in the same type, again, acting on the same pathway, the sympathetic nervous system, we can have a potential for side effects. What we need to do is make sure, are we transitioning from someone who's acute, they're getting better, but they're still in the hospital, and then we can move back onto their long-term medication so that we can better manage any type of side effects that could occur. So that's important. When we're putting these drugs that are in the same category together, we have the ability to create a side effect. Those are some of the long-acting agents, and as I mentioned before, we have the onset, which is there. As we look at some of our newer agents that we have, you'll see the onset is much quicker than our traditional and older counterparts in our short-acting agents. But they're still considered long-acting agents, and that's how we try to keep in terms of using them, although there are some pieces of literature that's showing the uses we're transitioning between asthma and adding some of these other pieces to the use of long-acting agents where those might come into play. Racemic epinephrine, I mentioned, is in our category of beta, of our beta 2 or our beta bronchodilators. Note that it has very, very poor beta 2 capabilities, so it's not a very good bronchodilator, no matter what anybody would try to convince us. The number one reason that we're really looking to utilize it is for the alpha properties, so that vasoconstriction property that it's creating, so that we can reduce blood flow to the area. That's why the biggest one on there is for you to think about stridor, upper airway issues. Again, we think about intubation, extubation, stridor, airway inflammation that's occurring. That's really probably one of the big ones that we see. Same with, again, croup, where you might have that with younger children, potentially, again, older, that could happen, but very, very rare. Epiglottitis, and then there's some use within the use of bronchiolitis, although really the literature is very minimal to none in showing that it's actually working. But ultimately, because of that, is we have the control of blood flow. That is probably the biggest one that we see. Indications for anticholinergics, so as we shift from our bronchodilators to our anticholinergic agents, these are very typical in the treatment of COPD, and that's what I really want to see that we're focusing on with these anticholinergic. Although there is now evidence, and we see that through our GINA guidelines, showing that we may be able to add some of these anticholinergics later on in our steps if we're having poor or no control from our traditional medications. Here's a list of possible agents that are on the market and that you can see there as well. I would point you to, again, how the onset occurs, which can be very important in how we're looking to utilize those. In terms of the indication of anticholinergic and beta-2 bronchodilators, that is very common. We have them together in combination for a reason, that they work very, 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 very well together, and we see that they may not work as well apart. So that's why we see them placed together, and that has now become a lot of standard of care. So we have that which is short-acting and short-acting agents, and we also have long-acting and long-acting, both from the sympathetic and the parasympathetic side, combined so that we can utilize those more effectively. Ultimately, we're using any kind of our disease that has an obstruction. We're looking to, again, utilize those agents in combination. Means of control that can be used as we transition to corticosteroids. The steroid piece, as I mentioned before, we'll have that within combination. Asthma being the number one agent, and it can be also considered to be part of that rescue inhaler piece in the GINA guidelines. COPD, not lots of evidence there to suggest the use of the steroids, so you'll see that through the COPD guidelines would come in much, much later at a much lower, or I guess higher level of instances where we're not seeing our regular drugs come together. And of course, any use of intranasal steroids for allergic and non-allergic rhinitis. As I mentioned, or really as Dr. Ari mentioned earlier about MDI, DPI, and nebulizer solutions, if we see that in terms of corticosteroids, they come in lots of different forms. The big one that we're looking for in terms of using corticosteroids through aerosol is trying to reduce candidus or thrush. So we're trying to make sure that everybody tries to rinse their mouth after the use. So that's probably one of the biggest take-homes from the use of aerosolized corticosteroids and making sure that that's done either hopefully soon after. Here's a list of, again, combination agents and inhaled steroids. Could be pretty small, but again, you can go back and take a look in your booklet to see some of those in more detail.
5 minutes left.
So we have systemic side effects for steroids. And again, the big thing there, the big take home from there for this slide is that there's evidence to suggest that bone density and growth rates can change with the use of steroids. HPA suppression is the big one that we look at, but again, is very rare for inhaled agents. So that's why we're doing the inhaled, because we're looking at giving lower doses. But the biggest thing that I want to for you to take from this slide is the change in the white blood cell count. Neutrophils go up with the use of steroids. So that's the important thing. You need to be looking for neutrophilia. So just because somebody has neutrophilia does not mean they have an infection. If they're on steroids, that could be a contributing factor. So you have to, again, differentiate. Do I have someone that has an infection because of the neutrophilia, or is it brought on from the steroid? So that's a big piece in terms of taking home from that slide there. Non-steroidal asthma agents, these are anti-leukotrienes, which for most part only work on about 50% of folks. They're not really the best, but the reason we use them is we put them in combination with all of our other asthma and pulmonary agents. Monoclonal antibodies are used as well. Those are for specific situations that we have, as you can again read there. The big take home here is look at all of these agents that are monoclonal antibodies, and they all end with MAB. So easy for you all to remember. So these are our different non-steroidal agents. I think the big take home from this slide, as you can see, we have the different agents that are split up. So these are the anti-leukotrienes. These are the monoclonal antibodies that we talked about. And again here, montelukast, probably the most utilized anti-leukotriene, anti-asthma agent on the planet because it's been studied so much. It's been approved in the US for children as young as 6 months old. So that's the big take home there, is that we're looking to, again, utilize montelukast as that agent. These are, again, a list of some different selected different agents that we might use for some of the different types of treatments that we can have. For the sake of time, I'll allow you to just read those over again. Again, you'll see that again in this slide as well. So again, it's kind of, in a sense, replicated. N-acetylcysteine, we heard about that earlier with Carl talking about NAC, and understanding that the take home here is that there's no literature to suggest that pulmonary sputum is changed by NAC. That, again, is not going to alter anything with the sputum that is produced by pulmonary patients. It might have effect on mucus that's normally generated in mostly water, but it does not have any effect and has not been shown to have any effect on pulmonary secretions. What we do know is that we have a couple of different percentages, and the hazard is bronchospasm.
2 minutes
More
left.
importantly, that what we have is N-acetylcysteine, and understanding that if it is, again, appropriate for our pulmonary patients and other patients, it's because of the antioxidant properties. And for the sake of time, Carl talked about Dornase alpha, and that is specific to CF. And we have some other inhaled agents that he spoke about, hypertonic saline and mannitol, that is commonly used. And so those are currently available inhaled agents around the world. And of course, finalizing diuretics, although these are not common. The most common one that we use are loop diuretics, and that is Lasix or furosemide. That, again, is probably the most commonly used. And you can read all of those agents there. So for the sake of time, I thank you. And what I would always tell all of my students is that if there's any comments or happy thoughts, I'll be happy to share those after the presentation.
Thank you, Dr. Douglas. Our next speaker will be a physician who came from a country which is famous of the son of midnight. I hope I have the right information. Dr. Stuart Aristad, a physician, consultant physician, and currently is a candidate of PhD in the Department of Pulmonary Medicine in Oslo University Hospital. Dr. Skeward has many publications, included sleep-related respiratory events in non-invasive ventilation. Please welcome Dr. Skeward, and you have the stage.
Thank you for the introduction, and I would like to thank the organizer for inviting me for this great meeting. And I'm especially honored to be for the first time in your country. And I was really impressed to hear that you have, I think it was right, 5,500 respiratory therapists in Saudi Arabia. And can you guess how many we are in Norway? 0. There's nobody there. The only good thing to say about that is that me as a pulmonary physician, I can do some of the fun parts. Yes. So I will, the objectives of my talk is to give a definition of COPD and also how we diagnose this common disease, how we assess the patients for severity and for treatment. And I go into details about non-pharmacological treatment and also pharmacological treatment, and some of the respiratory support that can be available for these patients, like non-invasive ventilation and oxygen therapy in stable COPD, and lastly, some words on COPD exacerbation. So how do we define COPD? It's a chronic disease with persistent respiratory system, giving a persistent airflow limitation that is caused by exposure to noxious particles or gases. That is how it's defined. And how do we diagnose this disease then? So there are 3 things from the definition we need to have with us for the diagnosis. It should be a long time exposure to noxious stimuli. It should be typical symptoms like shortness of breath or chronic cough or sputum production. And then finally, the diagnosis is confirmed by airflow limitation with a spirometry showing a persistent airflow limitation, not reversible over time or after treatment. So spirometry confirms the diagnosis. Spirometry alone is not sufficient to state the diagnosis of COPD. Very important. So, of course, noxious stimuli, cigarette smoking is the most common factor leading to COPD. However, we must not forget other risk factors. Also, smoking pipe, cigars, water pipe, and marijuana can cause COPD. And also, occupational exposures to organic or inorganic dusts, chemical agents, and fumes can lead to this disease. And also, the exposure to indoor smoke from stoves over prolonged time can lead to COPD even in non-smokers. So what about the persistent airflow limitation that confirms COPD? Of course, we do this with the spirometry, and you all know the forced vital capacity and the forced expiratory volume in 1 second. And then it's the ratio of these 2 parameters that show the airflow limitation. And it's common to use the ratio of 0.7 as a cutoff value for obstruction. However, it's important to remember that this ratio is also age dependent, so it will tend to overdiagnose in the elderly group and underdiagnose younger people. So it's increasingly being used to have to instead use the lower 5th percentile of the lower limits of normality to diagnose obstruction. So, so this is why it's important also to remember that we must have the noxious stimuli and must have symptoms, because if you only look at spirometry, and if you then also not forget that this is age dependent, especially in that are not so obstructive, you can diagnose actually a healthy person with COPD. So how do we assess the patient with COPD? Just for severity, but also for the treatment that we can offer them. symptoms has to be looked upon, and there are good questionnaires systematically studied, like the Modified British Medical Research Council, or the COPD assessment test that gives us the common CAT score, useful tools. Also, rate of exacerbation. You should talk with your patient and ask about this, because we know that one of the most important information that to predict exacerbation in the future is the rate of exacerbation they've had the previous years. And also, in some medication, the level of blood eosinophilia is important to know. So how can we classify COPD patients? The GOLD guidelines, I guess it's common to you. This is an international guideline. This is updated every year. And it states that according to the spirometry, as soon as we have detected first the airflow limitation, then we can use the FEV1 to classify COPD in mild, moderate, and severe, and very severe COPD according to the numbers. Also, in the GOLD guidelines, we have the ABCD tool, or now it's more ABE, but AB on the lower part classify the symptoms. So either you have a lot of symptoms, and then you are in B, or if you have less symptoms, in A. And also the frequency of exacerbation. You can be a frequent exacerbator or not. So that has something to do with the treatment you will offer in the chronic stable phase of COPD. Also, when we assess a patient, we should also think about the non-pharmacological treatment that are available. And then we want to know their smoking status. Are they still exposed to other noxious stimuli? How is their level of exercise and nutrition? Their oxygen status, the psychological factor like depression and anxiety, and also comorbidities like osteoporosis, heart disease, obstructive sleep apnea, kyphoscoliosis, other things that can influence on their way of living, also on their lung function test. So then we turn to management of this chronic disease. And it is important when we discuss with our patient that this is a chronic disease, and what should be the aim of the treatment. And the first and the most important maybe is how can we help the patient to better live with this chronic disease. I think it's important to focus on the symptoms, but sometimes this is not so easy to control in these patients. At least because they're limited, their lung function is sort of already harmed by the disease. But we can, by training, for example, we can increase their exercise capacity and then reduce their symptoms. Even if the pulmonary disease is the same, they're able to move better if they exercise more. We can improve their health status in general. And also it's important to do what we can to prevent the disease progression and also exacerbations. And of course, also in this patient group, to reduce the overall mortality is important, and treat exacerbations when they occur. The management, we can focus on first non-pharmacological treatment, and then on pharmacological treatment. And finally, we'll talk about treatment of the exacerbation that these patients suffer from. A non-pharmacological treatment of stable CO2 are a very important aspect of the treatment of this disease, because it has been shown that it can prolong longevity, that it can reduce exacerbation and increase their symptoms and quality of life. So these are essential interventions in the treatment of this disease. And it can be seen as a spectrum of more simple interventions, like what I can do with my patient when I have him or her in my office, to a more integrated or comprehensive program, like in a pulmonary rehabilitation situation. I just mentioned some of the factors that are important when you do this kind of intervention. So when I have the patients in my office, I can, of course, explain to the patient how they can recognize and what to do during exacerbation, how can they adjust their short-term acting bronchodilator, when should they take a short course of oral steroids, when should they use oral antibiotics, and when should they contact us to get further help. So this is what you can provide the patient with during a conversation, but I also recognize that maybe my instruction to the patients that are not sufficient, and to have people help me to do a better approach to educate the patients is often very useful. And so a more comprehensive education of the patient is in place, and where we can explain more further the COPD and its symptoms. We can help them to avoid smoking, avoid them to be exposed to passive smoking. We can treat them, help them to manage breathlessness, and we can explain them the useful of physical activity and pulmonary rehabilitation, and important also to explain in detail how they should use their medication, the inhaler techniques, and important of adherence, and also to follow the whatever national vaccine program they have, and also how they can identify and manage exacerbation. So these are important factors when we educate our patients. Also, we know that although education increase the knowledge of the patient, it doesn't necessarily lead to a change of behavior in a positive way. So sometimes we must put more effort into our intervention with the patients, and this is what we call self-management intervention, focus on many of the same topics, but in a more comprehensive way, and in order to help the patients to be motivated and to engage in a positive change of their lifestyle, and also to provide them with skills to better cope with their disease. And for many patients, this could be better done in a setting over time, in a pulmonary rehabilitation program, where we typically will have the patient for 6 to 8 weeks in a systematic program. Either they're staying at home and coming to this program every day, or admitted to a specialized rehabilitation unit, or sometimes in a hospital, where we have a structured and supervised program. So let's turn to the pharmacological treatment of stable COPD. And inhaled drugs are, of course, the main pharmacological treatment. And we have already heard about this. We have a range of medication. We have the short-acting beta-2 agonist, long-term acting beta-2 agonist, short-term muscarine antagonist, and long-acting muscarine antagonist. And also, in some cases, also anti-inflammatory drugs, where inhaled corticosteroids are the most commonly used. So we have a range of these inhalers available, and also they are, of course, as you know, in combination. We have combination of LABA and inhaled corticosteroid, LAMA and LABA, and also in triple therapy now, very commonly used. So which of these ventilators should we choose? Which one should we apply for the patient? And there are two things that are important, and their symptoms and the rate of exacerbations are the most important when we choose the therapy, more than the values of the spirometry. And there are a range of inhalers available, and I always use, annually we have this pamphlet in Norway, and I guess you have similar, that can be very helpful to discuss with the patient which kind of therapy are you actually using, and explain them. So we have the dry powder inhalers on the right-hand side, and we have the metric dose on the left side. So the GOLD guidelines, they have annually updated recommendations for pharmacological treatment, and I won't go through all of these busy slides, but just the main principle here is that if you have, they focus on symptoms and they focus on exacerbation, that alters the therapy a little bit. So these patients are primarily symptomatic, like dyspnea. The main treatment will go around long-acting beta-2 agonist and long-acting muscarine antagonists. However, if the patients also are a frequent exacerbator, earlier in the stage, you will try also inhaled steroids. And also, if the patients have a eosinophilic blood count, that will also make us earlier introduce and try oral inhaled corticosteroids. So it's important that on one side of the treatment is to prevent exacerbation, and then the patient needs to be encouraged to use this therapy. And then maybe side effects will be at some point we might discuss not to follow this treatment. On the other hand, if the patients are more symptomatic, then and these medications are not helping, then we must discuss with the patient. So there are different perspectives, and the patient need to learn why they should take their medication. So I will turn to some of the respiratory therapy or support that we can give the patient. We have oxygen therapy, and as we already heard today, long-term oxygen therapy is important for those patients in need of that. And it's important that the patient know that long-term oxygen therapy means that they should use oxygen for at least 15 hours per day if they are prescribed oxygen. And we should encourage them to use it more than that also, 24/7. On the other hand, ambulatory oxygen therapy is the use of supplementary oxygen during exercise and activities of daily living. So which patients should be offered a long-term oxygen therapy? This is based on older studies from the 80s that show that the use of long-term oxygen therapy did improve survival. So this is the main indication to give patients oxygen today, is that that will reduce mortality and also reduce development of cor pulmonale. So, and that's why long-term oxygen therapy is indicated when there is chronic hypoxemia, PO2 below 55 millimeters of mercury, or the other option is, other situation is that if PO2 is above 55 millimeters of mercury, however below 60 millimeters of mercury, if there is either secondary polycythemia or peripheral edema as a sign of right-sided heart failure, or if they have pulmonary hypertension, then long-term oxygen therapy is indicated. And what about ambulatory oxygen therapy? Patients that already are using and prescribed long-term oxygen therapy, they should also have ambulatory oxygen if they're motivated and able to use it. That will increase the hour they use oxygen. And also, they need to be motivated for this. Patients not meeting the criteria for long-term oxygen should not routinely be prescribed ambulatory oxygen therapy. That is what the guidelines said. We know in practice, practical life, this happens maybe more than the guideline says. However, the guideline says that ambulatory oxygen may be considered in patients with desaturation during exercise, and if adding oxygen, their exercise capacity increases. And of course, this should also be motivated to use oxygen. So what about long-term non-invasive ventilation? This could be considered now in the neuro guidelines. This has been studied previously, and we have not found evidence that this is helpful for the patient, but neuro data has shown that this will increase the time for the new exacerbation leading to hospital visit and also improve survival. So for a subgroup of patients with COPD, this can be an option. And this should be evaluated in patients with chronic stable hypercapnic COPD. and also in patients who are admitted with an acute hypercapnic episode, if hypercapnia persists 2 to 4 hours after the admission. So you should not provide this therapy directly after the acute episode, but re-evaluate the patients, but quite soon after the acute incidence. And if you decide to try this long-term non-invasive ventilation in this patient, you should aim for reducing CO2 in daytime. That should be normalized. So you apply the therapy during night, but the aim is to normalize CO2 in daytime. We know that some patients with COPD, they progress to a chronic respiratory failure where the symptom burden is high. And also it's important to have advanced care planning and palliative care and end-of-life care in these patients.
5 minutes.
And supportive care like opiates and oxygen may be appropriate to reduce breathlessness. In some selected patients, we have some specialized bronchoscopic interventions like in the bronchial valve, lung coils, and vapor ablation, and some surgical procedures like bulectomy, lung volume reduction surgery, and even lung transplant. However, these are, of course, options that are for selected patients in very selected centers. So I will end my talk with focusing a little bit on COPD exacerbation. We know that this is very common, a very common reason for patients to be admitted to hospital in acute setting. And this is acute worsening of breathlessness with increased cough and sputum production, and it could be classified according to the therapy that the patients are needed. How do we treat this exacerbation? So pharmacological treatment is important. We would normally use bronchodilation frequently in the beginning, maybe every hour for the first 2-3 hours, often nebulized, and then less frequently. And as soon as the patients get better, we even within the stay of the hospital, I think it's important that we shift over to their normal inhalers, just both to the reduced side effects, as we heard in the last talk, but also to have the opportunity to see the inhaler technique of the patients. It's a good opportunity. Systemic corticosteroids should be given to all patients with exacerbations leading to a hospital admission, and also in some outpatient this is appropriate. When we use oral corticosteroid, we should use a dosage of 30 to 40 milligrams of prednisolone, and it should be a little shorter than we used to do before. Now it's recommended to give it in 5 to 7 days without gradual tapering of the dose as we used to do. Antibiotics should be considered in patients with COPD exacerbation, even if there's not a clear-cut pneumonia. So we will give it if all of the following are present: increased sputum volume, and especially if the sputum is purulent, then it's more frequently given. And also for all patients that receive invasive or non-invasive ventilation, antibiotics should be added if the patient has a COPD diagnosis. Oxygen therapy is important in exacerbation, and all should be evaluated, of course, for this. SpO2 can be a supplement if blood gas is not available. However, this is the gold standard, as you know. And all hypoxemic patients should be given oxygen. However, this should be done in a controlled way with a target saturation of 88 to 92%. Often oxygen flow of 1 to 2 milliliters will be enough. And we should titrate this, as you know, with a target of 88 to 92%. Non-invasive ventilation is the first choice of ventilation if the patients need mechanical ventilation. And this should be started if the patients have sign of respiratory distress, increased respiratory rate and use of accessory respiratory muscles, and combined with the presence of a respiratory acidosis. So with that, I think I'll leave you the key points for you to read in the book, and thank you.
Thank you very much, Dr. Aristad, for this interesting presentation. Moving to our third presentation and presenter, Dr. Majdi Idris. He's the head of Pulmonary Vascular Unit, Prince Sultan Military Medical City, and he's adjunct professor of respiratory medicine at University of British Columbia, Vancouver, Canada. He's the primary author of the Saudi Guidelines for the Management of Pulmonary Hypertension and the co-author of the Saudi Guideline in both asthma and COPD. Please welcome Dr. Majdi.
Assalamu alaikum wa rahmatullah. Thank you very much for having me here. Thank you, our chairperson, for this kind introduction. So my goal today is to talk about bronchial asthma. And as you know, this is kind of a very wide topic, but we'd like to kind of focus on a few things that I think that it is really important to the management of bronchial asthma when it comes to the real life scenarios. We're going to go quickly over basically these things. So let's start by talking about how to diagnose asthma. And that's extremely important because you need to have that on majority of cases based on the clinical background. And that depends on the symptomatology of asthma, i.e. Basically the triad of basically dyspnea, cough, and wheezing. You need to have some physiological confirmation by doing lung function, showing obstruction and reversibility in most patients. You have to document that there is airway hyperresponsiveness, which is the magic word when it comes to the bronchial asthma. And you need sometimes to evaluate the degree of inflammation. Now we have a tool that is the FeNO. Of course, the presence of A2P as well help in the diagnosis, but you always need to think about different things that can mimic asthma. In the clinical practice, this triad of really asthma, of dyspnea, a cough, and wheeze is not only present in asthma, but many other diseases can really mimic asthma by having the three basically symptoms, including vocal cord dysfunction, which is not uncommon, the proximal respiratory tract disease, a disease of the bronchi and the bronchioles, cardiovascular disease, certain drugs can induce a chronic cough, and many, many others. So what are the features of asthma? So if you look at the feature of typical asthma, usually those patients, they do have these symptoms that are variable. They really comes and goes. Basically, sometimes they are very symptomatic, and some other time they are doing very, very well. So if you look at that, when you always ask asthma patient, almost always, they will tell you that these symptoms are worse at night. As a matter of fact, if the patient did not say this word, think about that might not be asthma. Asthma is a nocturnal disease, and symptoms, it can happen in the morning, but most of the time it happens more or worse when it comes to the evening. Symptomatology, as I said, varies over time, depends on the exposure, and usually it's really triggered by something. Now, the positive bronchodilator test, it supports your diagnosis. That does not mean that all asthma patients should have reversibility. I'll say the typical asthma patient should have a good bronchodilator response, but that's not always the case. And to look at the other side, some COPD patient actually reverse. So use that really with care. Now, basically, excessive variability, again, is typical for asthma when you do the peak flow, but it always or only happen if the asthma is not controlled. Controlled asthma patients should not have this basically variability. Sometimes we can do challenge test with a methacholine challenge test or histamine challenge test to detect the hyperresponsiveness that happen in those patients. And what we mean by hyperresponsiveness, we mean that the asthma, or really the asthmatic lungs, are actually angry. Whenever they are exposed to any irritant, they just like overshoot. They get this hyper-responsive response. In children, we used to do the cold air challenge or exercise challenge. Sometimes we do exercise challenge in those asthma patients that have exercise-induced bronchospasms. So they have basically symptoms at the end of the exercise. Now, again, if you would like to make differential diagnosis, which we usually should do in any disease in clinical medicine, you should look at certain diseases that can change a little bit, depends on the age of the patient. So the younger the patient, probably you should think about the chronic, basically upper way cough syndrome, basically foreign body. Younger people, you need to look at what we look at, this vocal cord dysfunction, which is a horrible disease. It's horrible to die. It's very difficult to really diagnose, and it's very difficult to treat. So that's not uncommon. Of course, hyperventilation, COPD, etc. Once you get beyond the age of 40, then chronic bronchitis, COPD, and of course, chronic diseases such as tuberculosis or so kind of present at any age. So if you look at the younger group, those who belong to the age of basically 6 to 12 and adult patients, always when you look at asthma patient that comes to you for example, education, it's always we need to assess the level of asthma control. And the level of asthma control is a kind of complex thing. It's not simply, are you feeling well? Yes, I'm well, thank you so much. It's far beyond that. It depends on the symptoms, on the exercise limitation, on the night symptoms as well, how much they are using bronchodilator, basically the short-acting bronchodilator, and what is the future risks. So you need to assess that. You need to assess the medication itself. I'm going to talk about that. If you look at the GINA guidelines, the GINA guidelines talk about the 4 symptomatology that will help us to really say that asthma is controlled from the symptoms point of view. So that's based on those 4 criteria: no daytime symptoms, no night symptoms, no exercise limitation, and basically your patient is not needing to use the short-acting beta agonist as a reliever. GINA allow 1 to 2 times per week, but to be in really ideal situation, you should have no symptoms. And now, sometimes in the busy clinic, we don't have time to go over all of that, so we use some basically validated questionnaires, such as the asthma control test or the ACQ testing. It's going to give us a pretty good idea about the asthma control symptoms in the last 4 weeks when it comes to those patients. So what are the risk factors for poor asthma control? And that's extremely important, because the first thing that you will probably give you a hint that this patient will be in trouble, that those patients who are using lots of albuterol or really Ventolin, salbutamol. And we know that if the patient is using more than 3 canisters per year, the asthma mortality starts going up. And if those patients are using more than 10 to 12 canisters per year, the asthma mortality shoot up more than 10-fold. So that's pretty much a good indicator that this patient is at risk of really poor asthma control. Of course, the presence of comorbidity, obesity, can give you small airway disease asthma, which is, again, more difficult to control. The presence of rhinosinusitis, GERD, can also be a problem. Psychological, basically, factors differently play a role. Those who have poor lung function, the lower the lung function, the more likely that this patient will get basically exacerbation. And when you look at those patients who are at risk of getting basically persistent airflow limitation that is even very difficult to treat, to really recover the lung function towards normal, those individuals who had problem at their early life, even at the fetal life, so really exposed to smoke as a fetus, as basically infant, baby, or young adult, that will prevent your lung to grow. So that will affect the growth of the lung. We know that our lung continue to grow until we reach the age of 20, 25. So at that age, if you have problem exposure to basically irritants, to great extent smoking as a kid, that will basically slow down really your lung growth. Of course, having infection, multiple infection at the younger age group. Basically certain medication, or I'll say certain lacking of medication. If the patient is not treated early enough with inhaled steroid, that would allow to a lot of airway remodeling process and more difficult to treat basically asthma. And of course, risk factor from the medication using of oral steroid, frequent courses of systemic steroid is a problem. And now with the era of biological therapy, our main goal is to prevent that, because we know that if the patient is exposed to multiple courses of oral steroid, probably 2 to 3 courses per year, that will increase the risk of having acute myocardial infarction, stroke, bone problems, diabetes, etc. So giving those short courses of steroid that people think that they are benign, they are not that benign. So yes, they treat the acute problem, but they cause a lot of chronic problem. And every time you see someone come to the emergency with acute MI, or basically go to the ophthalmologist with cataract, ask that patient how many courses of oral steroid your doctor used to give you previously, because that could be influenced or really affected by us as doctor when we have kind of very low threshold for writing a course of oral basically steroid. So when we see those patients, this is the trick. So you have to start with assess the level of control, adjust treatment to get the best control, and then review to be sure that the control is maintained. And now the guidelines talk about stepping up level of care, going from step 1 to step 5 in most guidelines. Some guidelines, for example, the Latin America go to the 6 steps, but that doesn't matter. The whole thing is that we need to keep stepping up treatment in order to be sure that asthma is well controlled when it really comes to the symptoms, but also to future risk. And this is extremely important, because you know that sometimes we don't think about future risk. And I hate to say that, because you know pulmonologists and cardiologists do not like each other, right? That's very well known. We don't like them, they don't like us. But we have to admit that we learn this from the cardiologists. Cardiologists treat hyperlipidemia to prevent the future risk of MI. They treat hypertension to prevent the future risk. So now we are treating asthma, yes, to control the symptoms, but we need to prevent the future risk of exacerbation and fixed airflow limitation. I'm not going to go about treatment. We heard very good talk about really the medication, but it suffices to say that we need to think about asthma treatment as controller medication that control the inflammation and reliever therapy to relieve basically the symptoms. Again, I'm not going to go over that because we heard very good talk about really the medication and the different combination that we are using when we step asthma treatment above. Now, but very important to talk about the inhaled steroid and the steroid in particular, which is because it is the cornerstone when it comes to the asthma treatment, and that's extremely important because it is the drug that will allow the steroid receptors to move from the cytoplasm into the nucleus to inhibit the gene. And that is inhibition of the inflammation is what asthma treatment is. Or everything else, as a bronchodilation, etc., comes after that, and you have different dosing when it comes to, when we say low dose, intermediate dose, or high dose of the ICS. Nowadays, we try to avoid high dose ICS for a long time because of the recent data of the tracheomalacia that happen if you keep your patient on high dose ICS for a long time. Thanks to the biological therapy, we don't need to do that frequently these days. So again, engagement with your patient. This is very important. Many studies have shown that there is some kind of discrepancies between the patient's goals and the doctor's goals. So it's extremely important to look at at basically what the patient wants. And of course, you need to educate your patient toward the best care. Biological therapy, you don't need to go that and that, but now we have multiple biological therapy. We have basically the old omalizumab that work on the allergic status. We have anti-IL-5, benralizumab, and mepolizumab and rislizumab, which we don't have it in Saudi Arabia. We have anti-IL-4, dupilumab, and now we have more maps are coming. So we have basically dipimicumab, which is the every 6-month treatment. So we're getting more and more antizipilumab, a lot of treatment that's coming in the biological era that we are all lucky to live in that era. So initial asthma treatment, how to start treatment based on what level of care, step 1 to step 4, and that definitely depends on the severity of the presentation. Somebody present with really early, very mild symptoms, you can start at level of care 1, which is ICS formoterol as your PRN, or you can escalate, depends on the severity of the presentation. You might start at step of care 3 or even 4 if somebody presents to your clinic with very, very severe symptoms. Now, and of course, you need to adjust that based on the different, basically, response to treatment, and then you can step up the level of care. The goal is to induce control. I remember that inducing control means inducing symptoms, preventing exacerbation, maintaining lung function, and reducing the side effect of medication. When to refer a patient to a specialist, this is very important. I think when there is problem in making the diagnosis of asthma, this is not a typical presentation, or those who have difficult to treat asthma or severe asthma to start with. Risk factor for severe asthma or really death, those who have previous admission to the hospital with the ICU, intubation, etc., should always be referred. Those who might need probably to have biological therapy, or those who have occupational asthma. Now, this is very important, adherence to treatment. And when it comes to the adherence to treatment, that's the story by itself. Patients don't like to use inhaler therapy. And we know that in real life, patients will stop using the inhaler once they feel better. And when you think about it, why this is happening, there is many reasons, but we know that there is this nice study looking at patients not using their inhaler, and the doctors need to really trick them by using inhaler with counter to show if they are talking, I mean, when they say I'm using the inhaler, if they are doing that, and about 30% only were using their inhaler. So you need to optimize this to see what is the best inhaler for each patient. There is no perfect inhaler, so you need to choose the best inhaler that fits that patient. And you guys, you are the one that you would like to teach the patient how to use that inhaler. It's the respiratory therapist. Only 60% of pulmonologists know how to use the different inhaler in the market. So pharmacists, thank you so much, no. Basically nurses, forget about it. It's respiratory therapists, and that's been shown in multiple data. Even respirologists, basic pulmonologists, they are not the best really educators. So respiratory therapists are really the one, and there is many, many reasons why patients might not stick to that. So again, remember that what you need to do is basically managing the patient goal to really develop that basically partnership and look at the best outcome. And it is really steps of care that you need to go from seeing the patient, making the diagnosis, confirm the diagnosis, reach the control, and sometimes go to the specialist. Now, common exacerbation risk. Now, this can happen in asthma patients. They've been doing well, and then suddenly they get acute asthma exacerbation. So, death of asthma is fortunately not that common, but we still see 1 or 2 cases per year. So that's really a sad story, and there is many factors, especially poor adherence, poor technique, occupational, basically using other medication, exposure. Those might lead that patient might die with asthma, and those patients might not I mean, they don't need to have severe asthma. They might have mild asthma, but poorly controlled, and they die with a severe asthma attack. So those are the ones that you need to basically look at. So again, just like going back to really summarize what we said, so basically those who have, when it comes to the exacerbation, very important, I would like to tell you one thing. Unlike chronic asthma therapy, in acute asthma, the management is a bronchodilator. Of course, steroid should be used. But those patients who end on the ventilator, those who are those patients who were initially not treated aggressively with salbutamol or albuterol. So those who were given Ventolin every 6 hours. No, that's not right, right? So initially be aggressive. Give it basically back to back, every 20 minutes, whatever. Use a lot of Ventolin to break that acute bronchospasm. Of course, use a steroid to really control the inflammation. But in acute asthma, you need to pick up those patients with kind of life-threatening or really severe asthma, treat them very, very aggressively. And when you plan for discharging those patients, they should always go out with really clear plan, management plan, clear strategy, steroid treatment, and referral to the doctor to see them later on. So just basically for the sake of the time, so this is the same things we are saying that, but think about it. When you have basically acute asthma, be aggressive with the bronchodilator and always have plan to what to happen after you discharge them home.
5 minutes left.
Thank you. So the current definition of asthma and COPD, and this is kind of hot topics among pulmonologists. Does this syndrome exist? And to me, I don't care. But I know that if asthma patients smoke, they can get COPD. And if COPD patients have atopy, they're going to get asthma. So yes, the two diseases can exist both together. Is it one disease or two diseases? Who cares? But the management is to really control both diseases. So really decrease the inflammation in the lung and treat the bronchodilator. And those are the estimated probability of asthma in children. So when you have children, you need coming to you with symptoms, you need to think how likely this is asthma. And again, that depends on how typical basically the symptoms is. So remember that all children, they do cough, they do wheeze, and they do have basically dyspnea from time to time. But think about those patients who are exposed to irritants or get frequent basically infection in their early childhood. So those are the ones at risk. And this is why we keep saying, if you are a parent, please don't, if you want to smoke and kill yourself, be my guest. I don't care. But don't smoke with your children around you. You are not only harming them now, you're harming them by preventing their lung growth, and they're probably going to grow up as a COPD, even if they don't smoke themselves. So please, 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 no smoking basically around basically children. So guidelines also important. We have the GINA guideline. We have our the Saudi initiative guidelines, which was tailored to really look at our own basic environment and conditions, and I would really recommend that all of you take a look at that. And finally, if you look at that how to implement these guidelines, it is basically teamwork between doctors, between healthcare basically provider, the government, the societies, in order to really disseminate these recommendations in order to improve asthma control. So the key points, take-home message, asthma is just like variable disease. It's quite common in Saudi Arabia. We have different basically figures from 5 up to 20%, especially in the adults. And those patients are at risk of getting asthma. Think about asthma based on the symptoms. Diagnose asthma well, use symptoms and lung function, and then treat with a step of care to reach the control, and always think about adherence, 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 and the technique. That, I'm gladly say that it is your job, not our job, when we treat asthma patients. And thank you very much for attending.
Thank you, Dr. Majdi. We are honored to have Dr. Douglas again on the stage. His next presentation will be on a topic that I personally believe some of us as a RT, especially those who work in ICU, have some weaknesses in it. His next topic will be in pulmonary function test techniques and interpretation. Floor is yours, Dr.
Thank you. Thank you very much. So I guess I have the pleasure of being the first speaker that you see twice. So I don't know if that's good or bad. Maybe again I'm up here because I'm the prettiest. I don't know. But we're going to talk about pulmonary function. As I did last time, here's the objectives that we're going to cover. I'll just give you just a little bit of time to look over those and what we hope to accomplish during our 25 minutes together for this talk. In terms of indications, there's lots of different indications for pulmonary function. Ultimately, we use those to diagnose disease. Although the diagnosis is difficult when we say that with pulmonary function, it's an interpretation that we're going to use. So remember, this is just part of all the other different evidence that we're going to have to utilize to make a diagnosis. It's not going to be the number one thing that we're going to use. So we're going to use all of those things. What's important as respiratory therapists is everything that we use, we also are going to use the most important thing. We're going to use our eyes. We're going to see what's happening with the patient. So we can use for that diagnosis, but probably a lot of times what we may see, especially in longer progressing diseases, we'll think something like CF, we're using that for disease progression. Is it staying the same or is it getting worse? And then we have eligibility requirements. So a lot of times within the US and other countries, individuals are looking for disability, and so the pulmonary function test can be used in their attempt to get that eligibility to receive benefits. If we look at our pre-test procedures, the important thing is to gather all of your information. Really the big thing there is what the computer is going to do when you enter in that information. It's going to come up with what the predicted value is of that individual. So it's all going to be based on things such as age is very important, height, and of course sex. Those are the three main pieces that we have. Weight can again vary, again depending on what that's going to do. It's not going to make our lungs bigger, but again, it may have some compression issues. And of course, there's a lot of research being done for the race in pulmonary functions. So spirometry, this is what I'd like to talk about in terms of direct spirometry. So when we're looking to get direct spirometry, we are directly getting the information from the patient where they're blowing into a device. We're directly getting that. And so the main piece that we look there is the vital capacity. For PFTs, it's not the vital capacity, but the forced, because we're asking the individual to forcefully project that air out of the lungs. We may also, again, look to get the maximum voluntary ventilation when the patient's breathing in and out very rapidly. This is one of the most important slides, the entire deck. This is key for any individual practicing respiratory therapy and understanding what we're doing in terms of disease, no matter whether you are, again, doing, pulmonary functions, whether you are on doing general floor care, or whether you're in the ICU. This is extremely important that you understand what's occurring in terms of the tidal volume that the patient is breathing, and then ultimately when they take in that big deep breath, and then they exhale back to their tidal volume, we have our IRV, our inspiratory reserve volume. As they continue to exhale, that again is the ERV, and so together we then can use these volumes to make up a capacity. So that's our vital capacity. That's important information. For those of you who are doing an incendiary spirometer, what is it that you're getting from that patient? You're not getting the vital capacity, but you're getting the tidal volume and the inspiratory reserve volume, where now you have the inspiratory capacity. So two different things in what we're asking for, depending upon what it is that we're doing for the patient in terms of that exercise and understanding. So we understand that these volumes can be put together to make these capacities. One of the most important ones that we forget about a lot of times, because it's hard for us to see unless we're doing indirect spirometry or lung volumes, is to find out what the residual volume is. And so the residual volume is a big player in what may happen to the vital capacity. So we're going to see that in a little bit and understand that, yes, the vital capacity or the forced vital capacity is what we look for in terms of making an interpretation of a possible restrictive issue. But we also can see that being lowered, not as restricted, but also as an obstruction because we have the residual volume as it gets larger, squishes or squeezes or pushes that vital capacity to be much smaller. That again is key to understanding how the lungs are working and everything that you're doing as a respiratory therapist. If we look at acceptability and repeatability for a vital capacity, there's the keys in what we're trying to do here with all of the slides that dictate acceptability and repeatability is that we're wanting to make sure that we get an acceptable test, and usually that again is based upon ATS standards. So everything is set to making sure that we're going to be able to achieve that standard in terms of the acceptability of the test, and that we're going to be able to use it for the interpretation. The repeatability is the important part, where that we can have that patient do that same thing over and over again. So it's the consistency piece that we're looking for to make sure that there's no issues, whether that could be from effort or they, again, don't understand the instructions, or whether they're trying to cheat the machine, if you will, that they're trying to get some different values. So we want to see that repeatability. In terms of the vital capacity itself, as I mentioned before, it is a forced piece, and because of that forcefulness, we're also able to capture an expiratory volume in time. And that in time is, again, allowing us to, again, focus more on what we will look at our interpretation of the ability of an obstruction. So if a patient has an obstruction, we would then see the change in that FEV1. Whereas normally with a restriction, we would most notably take a look at our FVC. But remember, because of the prior slide, understanding that the vital capacity could be pushed down because of a severe obstruction, and now we have both a vital capacity that is low and an FEV1 that is low. And on that direct spirometry that we are doing, what we're looking for there is we usually capture three main items, the vital capacity that I mentioned, the FEV1, and then this is what's considered the ratio, or the FEV1%, and all that is a simple calculation. So simple mathematical calculation. And why this is so important is that this tells us what's occurring up here. So it's almost the value that is going to signify to us, hey, yes, you're right in your interpretation of the vital capacity and the FEV1. It's a confirmer piece for us. So it tells us what it is that we're actually getting. So that's important in our interpretation. So if we look at this interpretation, you'll see there at the top, we have what again is considered a normal test as we're looking through our direct spirometry. Now, when we get into our obstructive and restrictive patterns, that's where we're looking to make our interpretation. And as I mentioned before, the big take home here is understanding in an obstructive pattern where we have this FEV1 being the best confirmer for the obstructive disease, then we're going to come down here and look at the FEV1%. If the FEV1% is lower than what the patient should be doing, then that is going to confirm to us that we have an obstruction. Now, we'll probably see that vital capacity is reduced depending upon how bad that obstruction is because of that squishing or pushing down of that residual volume on the vital capacity. Now, we flip that around and we look at a restrictive pattern, and this is the number one confirmer that we're looking for. Is the vital capacity reduced? But remember, we said reduced vital capacity could be obstruction, so now we come down to our FEV1, which potentially, again, could be reduced or normal. And then we're coming here to confirm all of those above and find out where we're at. So this is going to be either normal or potentially elevated because, remember, it's a simple mathematical calculation. That's all we're looking to do. This is our flow volume loop, which is important in terms of giving us visual pictures of what it is that we're looking for in terms of how the patient is breathing. So this is, again, if we look at the different axes that we have in the flow volume loop, As the patient, again, exhales, they're going to exhale, again, forcefully, and they're going to continue to exhale over time until they have no more air, and then they are going to have a big inspiration. So that's where we get our flow volume loop. And that's important in understanding visually what might be happening with our patient. So also with our vital capacity and with our direct spirometry, not only are we looking at a flow volume loop, but we're also looking at a volume timed curve, which tells us really a lot of the same things here, but is just, again, giving us this line of how that volume is moving over time. And that, again, is where we see the same thing as we have up here as they're moving down through that pieces. It's making that time as the patient exhales. So here's an important slide, I believe, because this is where we can start using our visuals to try to get some confirmation, at least early on in our direct spirometry, about what is occurring with the patient. So here at the very top, we see that this is a normal flow volume loop. And so it's able to see that the patient can exhale all the way and continue to exhale and be able to breathe and close the loop. That's important. Being able to close that loop, making sure that the patient completes the entire breath. That is important. As we move down to the next, because we have a flow volume curve, because we looked at the flow volume loop, here what we're looking at is that, see how it's squished right there? So it's narrow. That narrowing means that we don't have the volume. So if we don't have the volume, we now have a restrictive process. So now we have that restrictive process, and because of that restrictive process, as we saw before, as we again have that timed FEV1 will be a little bit lower as well. But again, the narrowness tells us about the restriction. Here, we have an individual who has an obstruction. We know the obstruction because the inspiratory looks really good, but when they start to blow out, it's not coming out here. It's starting to fall or slope. And so now we see that we have an obstruction. And then we have a really bad obstruction because we have this even bigger collapse or bigger scoop that, again, is occurring because it's very small because of the collapse of the airways. So the airways are collapsing, and that's where we're losing all of that expiratory volume, and that's where we may have some trapping that's occurring. That's where we know it's really, really bad for our patient. Here, this is one where we have an individual that might have some type of extrathoracic issue that's occurring. They don't have any problem in terms with the volume, but it's that inspiratory flow that they cannot complete. And so that's why the flow just, again, is they're having that inspiratory maneuver comes across here instead of the loop. So that's something that's happening outside of the airways and outside of the lungs. Here at the top, we have a fixed issue where now we have something that might be, again, fixing the inspiration and the expiration, maybe potentially within the airway, where we have the expiration is low and the inspiration is low. So now we have that more of a circle-looking piece. And that, again, is telling us that there's an issue of both coming in and going out. Here, this is an internal piece that we have. I don't know what happened. This is our internal. I don't know, I guess I have to make sure I stay away from that. So this is where we have a problem opposite of here, where we have the problem with the expiratory side, but the inspiratory seems to be much more normal. So we have something that's internally occurring within the airway that, again, only is affecting that part of the expiration. As I mentioned, acceptability and repeatability. The reason I come back to this slide is we know how important it is, but it kind of transitions us into the next slide, which is understanding what we might have in terms of errors that are occurring. So as the therapist, and we're conducting these studies, we have to be able to look and making sure that the patient is doing what we want them to do. And the way that we're able to do that is visually see what's happening in the flow volume loop. The repeatability, the same thing. We're looking for the repeat to occur. And so here is what we're looking at in terms of the errors, in terms of acceptability, reproducibility that we have. So in this sample, you can see that the patient is starting to exhale, but not exhale forcefully, probably due to some back extrapolation. So you wouldn't be able to see that person necessarily pushing that air out, but they're pushing it out and the machine is able to catch it. Then you instruct them to blast that air out, and that's where they would start to exhale, and that's where that's captured. But you would not necessarily see that unless you could see what was happening on the screen. So that's telling you there's an error. Your timing between you telling them what to do and them actually doing it is off. So that goes back to the therapist making sure that we're educating the patient, and we're doing these over and over and over again. We're looking usually for 3, but again, sometimes I've seen it done where I've done it before 10 or 12 times if we're looking to have that repeatability. So we're looking for that. And then, of course, the patient is going to inhale. Same thing on the volume time curve. You can see that exhalation start just gently before the blast actually comes. So you get to see that on both the different graphs that you will have at your disposal. Here in this one, this is a hesitation. So it goes back to how you are educating your patient, making sure they understand what it is that you're asking of them. So instead of them taking in the big deep breath and then blasting it out immediately, we can see that that would normally occur here with this darker arrow, but on the red arrow, they hesitate. And so that's why it's shifted out a few degrees. And so then that exhalation begins and then, of course, ends. Here, here again, we have an issue that has some oscillation. Again, breathe in as they're exhaling, and you see that, again, change where they may have some issues in terms of their exhalation, where there doesn't seem to be too much issue, although a little bit of vibration as they come back here for the inspiration side. Here again is where we have a big blast of air that comes out, and they continue to exhale, but all of a sudden there's a hesitation, a pause in their breath, where it's almost in the sense that they hold that, and you can see that because the line drops straight, right there at the red arrow, instead of continuing all the way down. So that's a hesitation in their exhalation later on, versus the other one we saw, that hesitation started much earlier. Here you have that issue as it comes much later in the exhalation. This is an oscillation where the patient is exhaling. It's almost a start and a stop of the entire exhalation, where as they're pushing that air out. It's not continual and consistent. So we need to redo that test, of course, with that air. And here's what I mentioned earlier. We're not able to close the loop, as the patient seems to do pretty well in terms of exhaling. And then once they make that inhalation, we do not come back here to connect. So we have this inspiratory issue or an error for not connecting that entire loop. In terms of bronchodilator responsiveness, we had that talk just a minute ago, and understanding what it is that we're doing with bronchodilators. Usually the standard is about 12% is what we're looking for in terms of a change. Now, this is important. We've talked of at least 10 minutes, but remember, depending upon the drug we're utilizing, you might need a little bit longer because of how that drug is going to have an onset. So albuterol has an onset of about 15 minutes. Does that mean that you could not get the response at 10 minutes? No, but maybe a little bit longer. So that's why it's at least 10, if not a little bit longer. So some places you might see it 15, 20, 30 minutes later that you're going to do the post test to redo the bronchodilator responsiveness. And in terms of doing so, all we're looking at here is the different changes from pre and post and with the bronchodilator in place. So we're just looking for, is there that change? And we can see that loop tell us everything we need, along with the volume time as well. So you can see that, is it changing? And of course, we'll make the calculation if it is significant. But remember, just because it may be 12% better does not necessarily mean it's the best response or that's the best drug for them. So remember, it's going to take a collection of a lot of other things that we're going to, again, go through in making that ultimate diagnosis. Spirometer types, lots of different ones that are used in terms of pneumotax. Everybody's going to be a little bit different. You can read a little bit more about how that might, again, work in your hospital and or department. Calibration, probably should, again, talk about that probably sooner versus a little bit later, but calibration is huge. We have to make sure that a machine is calibrated. Without a calibration, all the data is insufficient and unusable. So we need to make sure that the calibration occurs. It's usually done with a 3-liter syringe, and you go through all the different steps that the machine has you go through so that you can complete all of those. And make sure that it is 100% calibrated. As we kind of transition out of spirometry that's direct, we're moving into other testing that is important for the overall pulmonary function and the use of interpretation of a disease that could be used for a diagnosis. So diffusion capacity with carbon monoxide, the DLCO, commonly used all over. What's important about that is we're looking for alveolar capillary membrane changes. That's what this test tells us. Is there a problem with the alveolar capillary membrane? That's all it's going to tell us. So it's not telling us anything other than that. What, again, is compounded with that is if you have an individual that may have a change in their hemoglobin. So a hemoglobin, because of the carrying piece, that hemoglobin carries oxygen, it has to have hemoglobin to carry that carbon monoxide. So if you have a lower hemoglobin level, you may have an alteration in your DLCO outcome. Now, some of your machines, if you know that information, you can input it, and it'll do a calculation back to give you a much better, again, output number so that you can utilize that in your interpretation based upon that hemoglobin level. If you do not have that, then you have to take that into account. What if you do not have that, and could that hemoglobin play a difference?
5 minutes.
In terms of diffusion capacity, we all know that we're using carbon monoxide and how that, again, works through the test. And of course, I'll let you read about the acceptability and repeatability of that as we've continued to cover that. Lung volume testing, that is our indirect piece. So remember we saw before the residual volume, we just can't look at that and see that. This is what it is that we need. And we do that by 3 different tests: helium dilution, nitrogen washout, and plasmography. So the plasmography or the body box, very common, again, very standardized now, I think, in many places around the world. What you're doing here is breathing against a pressure, and that pressure difference is calculated what's in the box and what is in the airway. And we see that occurring here as it's being plotted. So remember, it's just a different, so instead of you being in this big room and it's unable to seal it up, and we have pressure changes here in that box, it's sealed, and now you're looking at the difference between the airway and in the box, and we can calculate what those lung volumes are. Helium dilution, just exactly what it says. The patient's going to breathe helium until you have a calibration that tells you you've met what you need, and you're going to be able to exhale to be able to measure that. Same thing with nitrogen washout. We're going to breathe in 100% oxygen until we get down to a nitrogen level that is the standard at 1.5, and we're going to be able to have a calculation of what the lung volume actually is. Bronchoprovocation test, we just heard that in the earlier talk. So if you're looking at the direct way in terms of making the airways very angry, as we heard earlier, you're going to make those airways angry by giving methacholine. The key is 20%. That's the difference that we're looking at for a positive challenge. 20% difference in the FEV1. If you look at some of the other challenges that are used, you'll see the varying 10 to 15% that you're looking for positivity. So ultimately, and again, this presentation and taking home, I think the most important thing is understanding that we're interpreting and using a lot of other material to make a diagnosis. This is not the only thing we're going to use. We have to have lots of other information. The interpretation, I think, is key in understanding how to do that. We'll talk more about the machines and the interpretation tomorrow. But the other big take-home piece, as I said, is that early onslaught and understanding the different volumes and how they add to those capacities. That is something that you should always have with you to understand what's going on in anything and everything that you're doing. Again, I thank you, and if there's any questions, comments, or happy thoughts later, be happy to take those.
Thank you, Dr. Douglas. By the end of this presentation, we came to the end of this session. Now we'll have a 20 minutes of coffee break. Next session will start sharply at 3 o'clock. Would you please be here at 3 o'clock, as there will be a very important presentation by a very expert presenters. Thank you, and see you again.
Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to our session 4. And please excuse my voice. It's musical so far. So it gives me a pleasure to welcome Rachel Sullivan. Rachel, she's a trauma and emergency general surgeon. She's a surgical intensivist from Toledo, Ohio. She will talk about airway management. So please.
Better? Oh, yeah, okay. All right, and I want to make sure I know how to advance the slides. The green button? That goes. Okay. All right. Well, thank you so much for having me as part of this. I'm very honored to be invited, and we'll go ahead and get started. So I am happy that I get to talk about more of a clinical aspect, since that's what I do as a... And how do I go back? The left? Oh, okay. So I obviously am more involved clinically as opposed to the research side, so I'm very happy to be able to bring that aspect to the course. So in terms of the goals of airway management, fairly simple: oxygenation and ventilation, which are two separate processes, as you know, helping to ensure airway patency, preventing aspiration, and performing all of this while promoting cardiovascular stability. So when I was first learning, I just had a hard time figuring out the anatomy, and maybe that's just me, but I'm going to go over the things that I think are going to be most helpful as we go through the lecture and we talk about different devices and where they go and what the anatomy kind of looks like. So here we have a patient, this cut sagittally, so just like this, right in the midline. So you can see here their nasopharynx, and then their oropharynx underneath, divided by the hard palate. All right. And then I want to draw your attention to the tongue. So we really generally underestimate the size of the tongue and what a large muscle it is, and it's heavy. So when people are unconscious, laying on their back, supine, that muscle and all the soft tissues will fall back into the oropharynx and cause airway obstruction. So tongue, the large tongue will be something that we will discuss later. Now we come down to the base of the tongue here. This is called the vallecula, in between the epiglottis, which is right here, and the base of the tongue. I'll have you come over and look at this cartoon. So here's looking down in the oropharynx, base of the tongue, and epiglottis, okay? And this is the view you want to see when you're trying to intubate. Generally, the epiglottis flaps down on top of the vocal cords to help prevent aspiration. Then just a couple more landmarks over here. We've got our epiglottis right above, this is where your vocal cords will be, your laryngeal inlet with your trachea coming down, and the esophagus just behind it. You've got your thyroid cartilage, and below it, cricoid cartilage, and in between your cricothyroid membrane. So those will be referenced as we move through the presentation. So as with any clinical situation, you want to assess your patient first. Look, listen, feel. Within the first 10 seconds of walking into a patient's room, you guys will have most of this assessed. You want to look at their level of consciousness. Are they breathing or not? Do they have injuries? Are they in a C collar? I'm a trauma surgeon, so I'm going to be talking a lot about suspected cervical spine injuries. Look at the mechanics of their chest and neck wall. Are they using those accessory muscles that we referenced earlier? Do they have a big beard? Are they very obese? Do they have a short neck? Do they have injuries to their face, neck, chest? Also listen before you use your stethoscope. Do you hear them gurgling from the doorway? Do they sound like they're underwater? Muffled breath sounds? These are all pretty bad signs. Sometimes you can hear wheezing, stridor, and then go ahead and listen, make sure they have breath sounds. Are they present? Are they absent? Diminished, etc. And then often providers forget about feeling, so you want to check the chest wall for crepitus, the neck, the airway. That can indicate other injuries. All right, so first we'll talk about some basic maneuvers and equipment, and then we'll talk about more advanced maneuvers and equipment. So basic airway maneuvers are very basic. So the first one we'll discuss is the head tilt chin lift. You can see the provider puts their hand on the forehead and lifts up the chin and extends the head backwards. Now, if you suspect a C-spine injury or a patient is old with really bad arthritis or they've had a neck fusion, you can't extend their head backwards like that. But in most patients, the jaw thrust is an excellent maneuver to do. You just grab the angle of the mandible in the back and the bony prominences you can feel and push up towards the ceiling. These will facilitate to open up that oropharynx, that heavy muscular tongue and all the soft tissues that have fallen back into the back of the oropharynx. These will help alleviate that. And then you can use some adjuncts as well. So the top right, these are nasopharyngeal tubes. They're generally the size of a patient's pinky, and they're malleable rubber tubes that you can place down into their oropharynx. And you can see the position here through the nose, nasopharynx, and then it stops before the epiglottis, which is important because you can cause the gag reflex with the ones that hit the epiglottis, which are the oropharyngeal airways that you see pictured over here. These are larger caliber, they're rigid, and they help open up that oropharynx and again, pull that heavy muscular tongue out of the way. So these are very simple maneuvers that you can do to help ensure airway patency. Next, we'll talk about bag mask ventilation, which can be used and should be used in conjunction with the previously aforementioned slides. So bag masking can be used if a patient is totally apneic or if they're not breathing very well and they have insufficient tidal volume. You can put PEEP valves on these bags of note. You can see in this diagram here, there's both one-handed and two-handed. The technique and the concepts are the same either way. You want to take the mask and use the bony prominence of the bridge of the nose, whether it's one hand or two, and place that apex at the bridge of the nose, and then pull the mandible up with the bony prominences up into the mask to create an effective seal. Sometimes your hands are too small for it. That's fine. You can have another provider do two hands. Sometimes the patient has a large beard or they're obese or even facial trauma, which also makes it difficult to form a seal. So you might need to do two hands in that situation as well and have a separate provider bag for you. The important things to remember when you're bagging, there's a number of important things, but again, you want to maintain the patency of the airway with some of the aforementioned maneuvers, maintain the seal like I've talked to, and you need to deliver appropriately sized breaths at an appropriate rate. People get really excited in like emergency situations and they just bag and really fast and really a lot of volume. So you really just want to do just till you see chest rise, and only about 10 to 12 times a minute. So just take your own pulse if you're in that situation and slow down a little bit. If you do have a lot of overventilation, physiologically you'll cause gastric overdistension, which can then lead to emesis, which can then lead to aspiration, which is also something that we would love to avoid if we can. So those were the more basic issues to talk about. Now we'll move on to advanced airway devices. The next device to talk about are supraglottic airway devices. So the epiglottis that I pointed out to you, these, right below that is the opening of the larynx. And the idea is that the aperture sits right there on the opening of the larynx. It doesn't go through the cords, it just sits right there. Most commonly used are the LMAs. These are similar to the ET tubes and anything else with a pilot balloon on the outside connected with tubing. Once you've placed it, you inflate your cuff. These are inserted blindly along the hard palate that I already referenced earlier until you feel resistance. Once you feel resistance, in theory, the apex here is blocking your esophagus to try and help prevent aspiration. Then you can bag through these, you can connect them to a ventilator. The other supraglottic airways that are commonly seen, and they do have one of the vendors outside has the eye gels. They're similarly placed. They just don't need to be inflated once you put them in. It's just a gel-like cuff, and those work in the same way. Now, neither of the two that I've just mentioned are definitive airways because they don't go through the vocal cords, but they are helpful adjuncts and can be used in various situations. So definitive airways are those that go through the vocal cords, a tube through the vocal cords. And if you're unconscious and apneic, this is for you. So you want to intubate a patient to maintain their airway patency. That's when they don't have an ability to protect their airway, whether you induce that for an elective surgical procedure or their pathology of disease. It facilitates control of their oxygenation and their ventilation. Remember, those are two separate processes. It helps bypass obstruction in the upper airway, allows for suctioning of the tracheobronchial tree, especially if folks cannot tolerate whether it's secretions, blood, vomitus, and it limits aspiration. I put an asterisk here. Whoops. Well, it's tricky to go backwards on this thing. Oh my goodness. How do I go backwards? Back center. Oh, I see. Sorry. Okay, I put an asterisk here because when you do blow the balloon of the ET cuff up, which I'll show you later, even though it is opposed to the tracheal wall, you do have little micro folds and micro aspirations can go down, and you can still have micro aspirations. So it doesn't completely limit aspiration, but it helps. So again, we're back to when you're going to intubate a patient, the assessment. You want to assess their mouth opening, the prognathism of the mandible, which is how far does it protrude forward, your head extension, the Malin-Potty score, which I have pictured here. Basically, when the doctor tells you to say ah, they're going to look at how much space or how much they can see of your oropharynx. The bigger the better, right? Because we want to be able to get in there with devices and tubes. Thyromental distance, which is between the chin and the top of the thyroid. Dentition, this is important, and I also never really understood this when I had started learning, like why does the lack of teeth cause an issue? Well, you lose your normal facial contours. Once you don't have teeth, actually your bones reabsorb a little bit, and so your normal facial contours, your cheeks get sunken in, and so you can imagine that's very difficult to maintain that seal for bag masking. Additionally, anything else that makes bag masking difficult should raise your concern for difficult intubation because bag masking is generally a precursor to intubation. So again, those big beards, facial trauma, short neck, obesity, those types of things are things you need to be looking out for as soon as you see a patient. So we'll talk about the equipment that we use for intubation. Most commonly and traditionally, we have direct laryngoscopy, which are these metal blades. We have the curved one, that's called a Macintosh blade, and the Miller, which is a straight one. The Macintosh blade, the tip of this goes into the vallecula, and I'll show you a picture of that again, but that's the area I pointed out already, and they're most commonly used. Only the proceduralist can see what's going on during direct laryngoscopy. That's why I love the video laryngoscopes, because everybody that's in the room and can see the screen can see what's going on. These blades are modeled after the Mac blades, so it's a similar motion that you do. The Mac blade, like I said, goes in the vallecula and indirectly lifts the epiglottis so you can see the vocal cords, and the Miller blade goes directly behind the epiglottis and directly lifts it up. So we talked a little bit about ET tubes. Again, we've got our pilot balloon connected all the way to the cuff with tubing. We have our adapter outside to connect to bag masking or your ventilator. And it is a secure channel through the vocal cords. So in general, this is a definitive airway because it goes through the vocal cords, and you want to make sure that you have the right size for the patient. In general, men have about an 8.0 tube, and women are about a 7.5. That's the internal diameter. You should keep in mind, if you think your patient may need a bronchoscopy during their intubation, that you should place a tube large enough for this, because the bronchoscopes, the larger the bronchoscope, the better the suction power. And generally, you're doing a bronch because you want to suction out secretions or blood. So you want as much suction power as you can. So the larger the tube, the better if you think they might need a bronch. So you never really know if somebody's going to need it. So I always kind of try to err on the side of as large as I think is appropriate for the patient. Not pictured here is the stylet that goes through the ET tube, and we'll show you guys these tomorrow, but it's a malleable metal tube that gives the tube, or a metal rod essentially, that gives the tube enough rigidity to get down through the oropharynx and through the vocal cords. Similarly not pictured are bougies, which we'll also show you tomorrow, and those are rigid plastic tubes that are thinner in diameter than an ET tube, but can be helpful if you can't get a full view of the vocal cords or you're having trouble passing the ET tube. And then you can slide the ET tube over it. Also, the bronchoscopes, we'll show you that tomorrow as well. We don't have that pictured here, but we will show you that as well tomorrow. And again, just like the glide scope, all operators in the room can see the screen and see what you're seeing. The next thing to discuss with intubation is positioning. So you can see here that when a patient is supine, and again, this would be the type of patient, the trauma patient that's in a C-collar and you can't move their head. All of these axes are at pretty acute angles, your laryngeal and pharyngeal axis, as well as your oral axis. When you place the patient in a sniffing position, their nose is up, sniffing, it aligns these axes for easier placement and view of the vocal cords. All right, the next slide is kind of boring, but arguably it could be the most important thing about intubation. You need to do all of these steps, and you need to make sure that they're correct before you start. Any of these steps that go awry could cause catastrophic airway emergencies. So you want to make sure you're preparing and checking all your equipment, and during all of this, pre-oxygenating the patient. Ideally, you want to have a separate provider to be monitoring the vitals while you, the proceduralist, are concentrating on the procedure itself. Once you have everybody in the room and all your equipment checked and ready to go, you want to give your induction and paralysis, your medications. Ideally, you want to wait for them to kick all the way in, and we'll talk about that in a little bit. And then position your head and neck appropriately, as we've already discussed. And then one important thing to talk about in the C-spine injury, we will show you this tomorrow, but the collar, the anterior portion of the collar can come off, but the patient's head still needs to be maintained in line, and that needs to be also by a separate provider while you're doing the intubation itself. So when you're doing this, I chose to show you the Mac direct laryngoscopy Macintosh blade because that is the most common. The tip goes right in the vallecula here, and then you want to pull up at a 45-degree angle. You don't want to crank your hand back because you'll break their teeth, you'll cut their lips. Not good. You want to pull straight up, like if you look where the ceiling hits the wall, that angle right there, that's where you always want to aim when you're intubating somebody, forward and up. Don't crank your hand back. And we'll show you that tomorrow too. And then, this is the beautiful picture we always see every time in real life with no blood and no secretions and no vomitus in there. Okay, I'm just kidding. So the cartoon over here is what I showed you at the beginning, base of the tongue, epiglottis, vocal cords. In real life, this is what it looks like, your epiglottis, vocal cords, and this is a beautiful picture. Generally, there is, like I said, secretions in there, blood, vomitus, and you need to have your suction ready to go so you can actually visualize the cords. All right, this slide is also arguably important, even though it also looks boring. Once you get the tube in, don't get so excited and pull your blade out, because some people do that. You want to watch that tube go all the way through the cords and have the balloon blown up while you're watching. Otherwise, it can sometimes pop out. While you blow the balloon up, sometimes it has some back pressure if they have any sort of stenosis below. So you want to watch it. That's the best way to know that you're in the right spot. And then we have adjuncts to make sure we're in the right spot, which need to be done every time, okay? You can do your colorimetric detector. Again, when I was learning, I couldn't ever remember, like, is it supposed to be purple to yellow or yellow to purple? But then I remembered it's like alphabetical, so purple to yellow. So if you're ever not sure, purple to yellow, alphabetical. There are also fancy end-tidal CO2 detectors that if you have that at your institution. And then you also want to listen for your bilateral breath sounds. And you want to listen over the stomach. If you have sounds over the stomach, you may have intubated the esophagus. So you need to make sure you check all of these things. Eventually, you should get a chest x-ray and make sure that the tube is positioned appropriately with the tip 2 to 3 centimeters above the carina. If you cannot confirm, do not proceed, do not pass go, do not collect $200. If you cannot confirm tube placement, stop until you know you are in the right place. You can have catastrophic events when you don't confirm and you continue to proceed and then the patient's having a respiratory code. Do not confirm. If anybody in the room is concerned about the lack of confirmation, stop, listen to your team, okay? Because I've seen some bad things happen. So it's a team effort here. Then you want to secure the tube, also extremely important, because what if they code right after and somebody gets all excited and throws a syringe across the room and somebody starts chest compressions and nobody secured the tube and now, oh shoot, it's dislodged. Okay, that's a problem too. So it's just as important to secure the tube after you've confirmed placement as it is to place it in the first place. I know this all sounds very silly, but I've seen every single step along the way kind of go awry, and again, it can be catastrophic.
5 minutes.
Okay. So pharmacology, we're not going to get too deep into it. Basically, it blunts the reflex sympathetic stimulation, minimizes agitation and pain, allows for sedation, and facilitates upper airway relaxation so you can see what you need to do and position them the way you need to. The important things about induction and paralysis is that you want short on and short off, okay? The most commonly used are etomidate and succinylcholine. That's kind of the main thing with this. Once you've paralyzed a patient, you are 100% responsible for keeping them alive, and you need to remember that. Some notes on intubation. Oh, sorry. You can do tracheal intubation or nasotracheal intubation, but that's generally a more elective planned procedure. You want to minimize multiple attempts. Oh, where am I? I'm sorry, I went back forwards. You want to minimize multiple attempts because that can cause severe periglottic edema. You want to minimize breaks in bag masking, less than 30 seconds. Cricoid pressure used to be used routinely to help prevent aspiration. It has been shown not to do so, and so now it's generally used to help optimize the view. And then you want to try to prevent intracranial pressure increases, especially in those trauma patients. Complications, bleeding, trauma, obstruction of the tube, esophageal intubation, main stem intubation. The tube can get dislodged, or the feared can't intubate, can't ventilate, which leads to the need for a surgical airway. So extubation, I know there is a liberation lecture, so I'm not going to go too far into it, but long story short, the reason that you were intubated in the first place needs to be resolved. You want to perform spontaneous awakening and then spontaneous breathing trials on patients. Spontaneous awakening is all sedation comes off, and then if they maintain hemodynamic and respiratory stability and they're following commands and they're not agitated, then you can turn them on to SPT, which is a low-level support, generally 5 of PEEP and a CPAP mode, and then allow them to breathe on their own for 30 minutes to an hour. If they pass, then you can go ahead and extubate. Again, I'm not going to go too much into the extubation procedure because I do believe there's a lecture on that. If they can't get off the ventilator, that's when we're talking about tracheostomies. They can be done if patient can't be liberated from the vent or in the emergent surgical airway situation, and sometimes for elective, generally ENT cases. Again, we've got our pilot balloon with our tubing and our cuff. And I like this picture here because it shows the cuff here and the blown up in the trachea, and it bypasses the vocal cords, which is very irritating to the patient. So when you're talking to families about it, it's a lot more comfortable for the patients, and it's a reversible thing. So a lot of folks think it's forever, but it's not. So when you're ready for decannulation, again, you have to have the indication for the need for an airway resolved. You need to have them having appropriate mental status. They'll need to be able to handle their own secretions. You want to assess the upper airway, deflate the cuff, make sure they can breathe around it, speak around it. You can downsize the trach, cap it, put speaking valves on it. At this point, though, I'm usually taking it out if they're speaking and breathing around it. And one last thing to talk about, so that's tracheostomy. And the landmark I pointed out earlier, the thyroid and the cricoid membrane, that membrane is where you do your emergent cricothyroidotomy and surgical emergent airways. Sorry, I showed you that at the very beginning. So the last thing to talk about is the difficult airway algorithm. The American Society of Anesthesiologists has developed it, and it's in your chapter, so I won't reiterate all of it. But the most important thing, recognize that you might have a difficult airway. Don't recognize it when your patient's coding. Recognize it ahead of time, okay? That's one of the most important things in this algorithm. And then you plan, and you plan with your team. Is this person okay for rapid sequence intubation, or do they need an awake nasotracheal intubation? Investigate any previous intubations that the patients had. Like, what were the successes? What were the difficulties that somebody encountered and documented? Those are all extremely important to know. And plan with your team. You need to talk to your team before you paralyze and induce that patient, so you all know what's going on, and it's not chaos in the room if there is an issue. I personally have plan A, B, and C, and I make everybody in the room listen to my plan before I will push the paralysis. So that's how I do it. So again, limit your attempts, because that periglottic edema can cause severe airway swelling, and even the most advanced provider may not be able to get the tube if you've completely caused bleeding and swelling. Call for help early. That might mean before you even start, okay? Nobody will ever penalize you for calling for help early. They will definitely question your judgment if you knew it was gonna be difficult and you were like, it's fine, and didn't call anyone. Call. It is not time to have an ego when we're dealing with airways. Bag mask the patient at any point if you're able. That can keep them alive until either their paralysis wears off or a more advanced provider can get there. Utilize those supraglottic airways. Sometimes those are also life-saving. And then worst case scenario, can't oxygenate, can't ventilate, can't get an airway, then you'll need somebody like maybe me to do your emergent surgical airway. All right. Thank you.
Thank you very much, Dr. Sullivan, for your insightful presentation. And now, please let me introduce our next speaker. I'm pleased to introduce Dr. Dean Hess. Dr. Dean Hess has been a respiratory therapist over 50 years and has made a significant contribution to the field as a clinician, as an educator, managing, and as well as a researcher. He is currently the editor of the Respiratory Care and has published over 280 papers. And therefore, please join me in welcoming Dr. Dean.
Thank you very much. Can you hear me? Yes? No? Hello? Now can you hear me? Okay, so in this presentation, we will be talking about non-invasive respiratory support. I chose a few highlights from the chapter to talk about during the formal presentation. So I'm not going to talk about everything that's in the chapter, nor will I talk about anything that is not in the chapter. So I'm just going to try to hit some of the high points. So when I think about non-invasive respiratory support, these are the three things that I think about and that I will talk about this afternoon. We have non-invasive ventilation, where we apply an inspiratory pressure that is greater than the expiratory pressure. Often we refer to that as IPAP and EPAP. We have CPAP, where the pressure is the same throughout the respiratory cycle. However, it is greater than ambient pressure. And then we have high-flow nasal cannula, which also generates a little bit of CPAP, but not as much as we would typically get if we set CPAP with a device or provided non-invasive ventilation. In the acute care setting, there are a number of indications for non-invasive ventilation. They are listed here. This is from some recent clinical practice guidelines that I helped to author. The two most common reasons why we will use non-invasive ventilation in the acute care setting are for COPD exacerbation, and now I'm going in the wrong direction, COPD, all right, COPD exacerbation, and acute cardiogenic pulmonary edema. So there are a number of reasons why we might use NIV in the acute care setting. These are the two most common. What distinguishes non-invasive ventilation from invasive ventilation is that we do not use an endotracheal tube or a tracheostomy tube. Rather, we use one of the interfaces, such as those that are pictured on this slide. And there are a number of those today that are clinically available to us. When selecting an interface, it is important for us to think about how well the interface fits. We do not choose one that is too large or too small. How comfortable it is for the patient, how well it controls leaks. Sometimes I press the pointer and it goes forward. How well the interface controls leaks around the interface, and then finally, the potential for skin breakdown. So skin breakdown is an important complication of non-invasive ventilation that we need to think about and address, and one of the important ways of addressing that is to choose the correct interface and have it fitted correctly to the patient. There are a number of different types of ventilators that we can use for non-invasive ventilation. Most important for non-invasive ventilation is that we use a device that compensates for leaks. Newer generation of critical care ventilators now have non-invasive ventilation modes, so we can use the same ventilator whether we are applying non-invasive or invasive ventilation. We commonly use bi-level devices for non-invasive ventilation. These are single-limb blower devices that have a leak port either in the circuit or perhaps more commonly a leak port that is in the mask. These allow setting of inspiratory and expiratory pressures to provide ventilation. With these devices, we need to apply an expiratory pressure of at least 4 centimeters of water in order to keep carbon dioxide flushed out of the circuit. Generally, for non-invasive ventilation, we will use pressure support or pressure control mode. Perhaps most commonly, we will use pressure support for our devices that apply an IPAP, an inspiratory positive expiratory pressure, and an EPAP, an expiratory positive airway pressure. The level of pressure support is the difference between the IPAP and the EPAP. So if we set an IPAP of 10 and EPAP of 5, that's a pressure support of 5. There are adaptive pressure control modes that can be used. I think these tend to be used more in the long-term setting rather than in the acute care setting. And we can use neurally adjusted ventilatory support, or NAVA, for non-invasive ventilation if we have a ventilator that allows us to use that mode. So over the next couple of slides, I will go through the steps for initiation of non-invasive ventilation, particularly in an acute care setting. These are actually the steps for initiation of non-invasive ventilation that I've taught for many years, and it really has not changed at all over the last 25 years. So first of all, we need to choose a ventilator that is capable of providing non-invasive ventilation. Usually that will be a ventilator where we can apply pressure support ventilation. We need to choose an interface and avoid a mask that is too large. If the mask is too large, there will be a greater risk of facial skin breakdown, and there will be a greater tendency for there to be leaks around the interface. Need to explain the therapy to the patient. Often this is a patient who is awake and interactive. We need to explain to them what we hope to accomplish with this therapy. I like to silence the alarms when I'm initiating non-invasive ventilation, and I start out with low settings, typically settings that are subtherapeutic. I then like to initiate non-invasive ventilation while I hold the mask in place. So I think that patients tend to accept that better than if we strap on the mask and then hook on the ventilator. I titrate the inspiratory pressure to the patient's comfort, so start low and then titrate up the pressure while asking the patient if their breathing is more comfortable. looking at the use of accessory muscles, respiratory rate, and so forth. When I secure the mask, I try to avoid a tight fit because that will lead to facial skin breakdown. It will be less comfortable for the patient. Tolerate the FiO2 to an acceptable oxygen saturation. Try to avoid a pressure greater than 20 centimeters of water because esophageal opening pressure is about 20 centimeters of water, so higher pressures will lead to gastric insufflation. And then I titrate the PEEP, or the expiratory pressure, to the patient's oxygenation. In patients who have COPD and auto PEEP and air trapping, I will titrate the PEEP to counterbalance the auto PEEP and improve the triggering of the ventilator. And then to continue to coach and reassure the patient, adjust the settings to patient's comfort, and adjust the pressure to avoid tidal volumes of greater than 8 mLs per kilogram. So why do I want to adjust so that the tidal volumes are not greater than 8, that are less than 8 mLs per kilogram? Well, a reason for that is that it has been shown in the literature that high tidal volumes lead to failure of non-invasive ventilation. So if I can avoid tidal volumes greater than 8 mLs per kilogram, I'm more likely to have a successful result with non-invasive ventilation. Also described in the literature is something called the HACR score. So here is the HACR score, and you can see the variables that are assessed. A higher HACR score has been shown to be related to failure of non-invasive ventilation. But I think most importantly, monitor the tidal volume. Keep the tidal volume less than 8 mLs per kilogram. Higher tidal volumes lead to failure of non-invasive ventilation. Humidification is important during non-invasive ventilation, particularly for patient comfort. Active humidification is preferred over passive humidification. Dana talked about that this morning in her presentation. A passive humidifier adds dead space, so that makes the non-invasive ventilation less effective. But besides that, if the leak port is in the mask, the patient will not be breathing back and forth through the passive humidifier, so the device will be virtually useless. We do not need to set the temperature at a normal body temperature. A temperature of about 30 degrees centigrade is sufficient. We can deliver aerosols during non-invasive ventilation, so that might be important in a patient with COPD exacerbation, for example. Dr. Ari talked about this morning. We can deliver aerosols with either a pressurized meter dose inhaler, a jet nebulizer, or, not shown on this slide, we could also use a mesh nebulizer. What is important is regardless of the aerosol delivery device that we use, as is shown in this slide, the device should be positioned near the interface. So the pressurized meter dose inhaler and spacer near the interface, the nebulizer near the interface, and there are now some interfaces where a mesh nebulizer can be attached directly into the mask. So that's non-invasive ventilation for acute respiratory failure. Now let's talk a little bit about non-invasive ventilation for chronic respiratory failure. Non-invasive ventilation is commonly used in patients with progressive neuromuscular disease. What we evaluate, and the details are in the box, the summary is in the box here to the right. So we evaluate the patient's symptoms like dyspnea. We evaluate the degree of respiratory muscle weakness with vital capacity and inspiratory pressures. We evaluate gas exchange, such as arterial PCO2 and overnight oximetry, to determine the correct time to initiate non-invasive ventilation. But in many patients with progressive neuromuscular disease, like ALS, for example, at some point in their course, they will require non-invasive ventilation. Non-invasive ventilation is also important in patients with chronic hypercapnic COPD. I really don't need to say anything more about that. Dr. Aristad talked about that in his presentation. There is now high-level evidence to support the use of nocturnal, non-invasive ventilation in patients with chronic hypercapnic COPD. Just a little bit about mask CPAP. So now we're not talking about non-invasive ventilation. We're talking about a constant pressure applied to the airway through a face mask. This might be indicated for acute hypoxemic respiratory failure, postoperative respiratory failure, or I think most commonly for acute cardiogenic pulmonary edema. So where I have used mask CPAP in the acute care setting, most commonly is for acute cardiogenic pulmonary edema. In the past, mask CPAP has been used as a prophylactic therapy. Postoperatively, that I think has been shown not to be effective, so I would not encourage you to use that in your practice. When we use CPAP in an acute care setting, like for acute cardiogenic pulmonary edema, a typical CPAP level is 5 to 10 centimeters of water. So in the final part of my presentation, we'll talk about the third type of non-invasive respiratory support, high-flow nasal cannula. So we talked about non-invasive ventilation, which is ventilation, inspiratory pressure greater than expiratory pressure. Talked in one slide about CPAP, continuous pressure applied to the airway with a mask. And now we will talk about high-flow nasal cannula. On this cartoon illustrates the important components of a high-flow nasal cannula system. So there is a way to titrate the inspired oxygen with a blender to control the inspiratory flow. With high-flow nasal cannula, we use flows up to 50 to 60 liters per minute in adults. There is a heated humidifier because without warming and humidifying the gas, 60 liters per minute into your nose would not be very comfortable. And then there is a heated circuit so we don't get a lot of condensate within the circuit, and a wide bore circuit to accommodate the flow. There are a number of physiologic, there are a number of important physiologic effects of high-flow nasal cannula. Those are listed on this slide. First, when I was using high-flow nasal cannula, I thought about it as a way of providing a precise inspired oxygen concentration. But there are other, perhaps even more important physiologic effects of high-flow nasal cannula. So the high flow flushes carbon dioxide from the upper airway, so that reduces dead space, increases FiO2, reduces the ventilation requirement for the patient. So even though it does not provide non-invasive ventilation, it reduces the ventilation requirement for the patient due to this effect. The high flow reduces respiratory resistance because the patient's breathing from the high flow presenting to the pharynx rather than needing to breathe through the high resistance of the upper airway. There is a small distending pressure of a few centimeters of water, so it provides a little bit of CPAP. And the high flow is comfortable when it is adequately warmed and humidified. So how warm should we set the temperature during high-flow nasal cannula? Well, the literature suggests that a temperature of around 30 or 31 degrees centigrade is sufficient. We do not need to turn the temperature up to 37. In fact, if we turn the temperature to 37, many patients will complain of discomfort, that the gas is too warm. So a temperature of 30 or 31 degrees centigrade is just fine. Interestingly, on the most recent generation of critical care ventilators, they have a high-flow nasal cannula mode. So that's very nice because on a single device, we can provide either non-invasive ventilation, high-flow nasal cannula, or invasive ventilation using a single device. So for example, if the patient fails non-invasive ventilation or high-flow nasal cannula, and we call Rachel to come and intubate the patient, we can use the same ventilator after the patient is intubated. These devices can use either a large bore or a small bore cannula. There is some controversy about which is better. Interestingly, there is a new hybrid cannula that just recently became available, which is a large prong on one side and a small prong on the other side, that tries to take advantage of either the large bore or both the large bore and the small bore cannula. Something that's been described in the literature to assess the success or failure of high-flow nasal cannula in the acute care setting is something called the ROX index, which is the SpO2-FiO2 ratio divided by the respiratory rate. If there is a high ROX index, that suggests success of non-invasive or success of high-flow nasal cannula and continuing the therapy. If the ROX index is low, that suggests failure of high-flow nasal cannula and considering perhaps intubating the patient and providing invasive ventilatory support. We can deliver aerosols with high-flow nasal cannula. I think Dr. Aries pointed that out this morning. Aerosols can be delivered effectively, and the best position now for the nebulizer is proximal to the humidifier. So high-flow nasal cannula, nebulizer before the humidifier. Non-invasive ventilation, nebulizer up near the interface. Now, something that I think is not as appreciated as perhaps it could be is something called sequential use of non-invasive ventilation and high-flow nasal cannula. And this has been shown in the literature to be worthwhile, particularly for patients who need non-invasive ventilation but are intolerant of non-invasive ventilation. So what we can do is we can alternate the two therapies. So we can administer non-invasive ventilation for 4 hours, and then we can put the patient on a high-flow nasal cannula for several hours, put them back with non-invasive ventilation. And in some patient types, it has been shown in the literature that that can actually improve the success of both non-invasive ventilation and high-flow nasal cannula. So this improves comfort and tolerance of the therapies. So in summary then, in appropriately selected patients, non-invasive ventilation decreases the need for endotracheal intubation. That's important, but even more important is that it improves survival. So for example, in patients with COPD exacerbation where we use non-invasive ventilation, that affords a survival, a mortality benefit for the patient. And in patients with progressive neuromuscular disease, it has been shown that patients live longer if they are provided non-invasive ventilation. The selection of interface is important for comfort and risk of skin breakdown. This is where you and I as respiratory therapists can make a big difference in making sure that it is the correct interface for the individual patient. Leak compensation is an important attribute of ventilators for non-invasive ventilation. Mass CPAP can be used for acute hypoxemic respiratory failure, postoperative respiratory failure, or acute cardiogenic pulmonary edema. Where I've used it most commonly in my practice is in the setting of acute cardiogenic pulmonary edema. High-flow nasal cannula delivers gas by nasal prongs that flows up to 60 liters per minute, and I showed you on a slide a number of bullet points of the physiologic benefits attributed to high-flow nasal cannula. Aerosol therapy is effective when combined with non-invasive ventilation and high-flow nasal cannula, and sequential use of non-invasive and high-flow is effective where in a patient we alternate between the two therapies. So with that, I will stop and hopefully stayed within my time. I was very concerned that I would go over time. Looks like I finished a few minutes early, so thank you.
Thank you, Dean Hiss. It gives me a great pleasure now to introduce Dr. Shog. Shog, she's a friend of mine, and She's a chairperson of respiratory care program at Imam Abdurrahman University. She has previously held the positions of Vice Dean of Academic Affairs and also postgraduate of Scientific Research and Innovation. MashaAllah, a great profile. So floor is yours.
Thank you. Thank you, Dr. Mohammed, for the introduction, and thank you all for attending and staying awake until now, actually. I wish this presentation will refresh your information about many things that you already know by now. The objective is just a quick overview about the modes of ventilation and each setting that allocated with each mode. To know our mode, we have to know two important features. What's the breath sequence and how each breath is controlled. If we know this, we will identify our mode regardless of the brand and the name that is sold under. Robert Chatburn has proposed a very systematic and easy way to classify the modes of ventilation. It depends on breath sequence, control variable, and phase variable. When we talk about the breath sequence, there are three ways of breath sequences, either continuous mandatory ventilation, or intermittent mandatory ventilation, or continuous spontaneous ventilation, and we will explore more about each one of these. Here in the top, where is the pointer, please? Excuse me? The pointer is the green? Okay. So in this one, this is the continuous mandatory ventilation. It could be triggered by the patient or not. Every breath will be delivered according to the settings that we put on the ventilator. Here we have mixture from spontaneous breathing and breathing that is controlled by the ventilator. The controlled breath could be triggered or not. So this is a mixture between the spontaneous and the controlled ventilation, like the SIMV. And we have the spontaneous ventilation where the patient controls every breath with all its features. When we talk about the control variable, we have two. It's either volume or pressure. The ventilator can control one at a time, and the other variable will be affected, and we will talk about it further in the other slides. When we talk about the phase variable, we mean how the breath is initiated, which is the trigger, and how is it terminated, which is the cycle. And we will go further about it in the slides. Here we will see a breath that is time-triggered, I mean. What does that mean? The patient does not have to do any effort for the breath to start. We set the respiratory rate, for example, here, 15 breaths per minute. Every 4 seconds, the breath will be initiated without any effort from the patient. We have the pressure trigger, where the patient have to produce pressure to trigger the ventilator. For example, we have to say -2. When the patient can go to -2, the breath will be triggered. We have in the flow trigger, there is a continuous flow, and we set a number. When the patient achieves that number, the ventilator will trigger the breath. For example, usually it should be set at 3 liters per minute. Here we see 5 liters per minute coming. The patient will take 1 liter per minute. When the breath is back as 4, it will not be triggered. It has to go back as 2, and then the ventilator will be triggered. The cycle, it means how the breath will be ended, how is it terminated. We have the time cycle, and the breath here will be ended when the inspiratory time is achieved, regardless of how do you set your inspiratory time. We have the flow cycle, like in pressure support ventilation. Here, what we have to set is the expiratory sensitivity, and from that, the ventilator will know when to end the breath. Here, the expiratory sensitivity is set to 50%, so when the flow went from 60 to 30, the exhalation valve will open. Here, it's the 30%, so it will be a longer inspiratory time. What do you want? How is your patient doing? Do you want longer inspiratory time? Do you care about the exchange of the gases? Or do you have air trapping and you want shorter inspiratory time and you want the ventilator to cycle early? Depend on the status of your patient. Here are the modes that we will run through today, so please stay awake. The first one is the volume-controlled ventilation, and this kind of ventilation The therapist will set the tidal volume. The pressure will be affected by patient effort and lung characteristics. What we have to know is is the ideal body weight for the patient. From that, and knowing the lung condition, we can set the tidal volume, and then we adjust the respiratory rate to reach the target minute ventilation. We set the flow and the flow pattern. It's either square or descending. Do you want it square for better oxygenation, or you want it descending for longer inspiratory time but less mean airway pressure? Depend how your patient is doing. When we talk about pressure control ventilation, we set the pressure and the volume will not be guaranteed. Again, it depends on patient effort and on lung characteristics. The beauty of the pressure control is the free flow that it could give to the patient. So the patient can take as much flow as they want, but we have to make sure that we put the rise time properly. I don't know where is it in the slide, but the rise time is a very important feature that we have to control. It tells you how fast the valve open, how fast the flow will reach the patient with his effort. The rise time is different from one ventilator to the other. And 0% in one ventilator is 100% in the other. So you have to know your ventilator to know how to set your rise time. And you want to give a proper time for the flow to be delivered. If it's too fast, you'll have the double trigger. If it's too slow, you will increase the work of breathing. So you have to set it according to the patient's needs. Here is comparison between volume and flow. Here we control the minute ventilation. So we will deliver fixed tidal volume, and we will control the CO2 properly, but we have a fixed flow pattern, and this is not always ideal. Because we have to know how to put the ideal flow to avoid asynchrony. And the pressure, we control the pressure, so the lung is safe, the flow is free, so the patient can take whatever they want, so we give it to patients with high demand of flow and who we want to control the pressure for, but we cannot control the alveolar ventilation. We can monitor it, but not directly control it. In the SIMV, the patient can take his own breath in addition to the mandatory breath delivered by the ventilator. And the beauty of this mode is the synchrony window, which shows me here, like the breath is not delivered exactly on the same time. Although the rate is 10, we should see every 6 seconds a breath is delivered, but it's not consistent in the time because it takes into account when the patient triggers. So it watches, there is a window when the ventilator watches for patient effort, and it will adjust the time of the mandatory mode, mandatory breath, to go ahead with the spontaneous breath to avoid breath stacking. Pressure support ventilation is a waning mode. The patient can go for that before extubation. They should be awake, they should be spontaneously breathing, but we have many things that we have to be careful when we set. We have to make sure we set the proper pressure level, the proper trigger, the proper rise time, and the cycle of criteria. All those are factors that if we do wrong in any of them, the patient will struggle with each breath. Although the numbers say 5 to 10 centimeters of water is adequate, a patient struggled to breathe at 10 centimeters of water, and she expressed that after extubation. She said, I fought for every breath, although the numbers didn't show it. So we have to communicate with our patient, see how are they doing, and adjust our settings accordingly. For the continuous CPAP, we inflate the alveoli, the patient will breathe around it. It's good for recruitment, for oxygenation, and it's very good for patients with congestive heart failure because it reduces venous return. The pressure here is set to 0, but usually it's above that, and the patient will be breathing freely around that. Adaptive support ventilation, adaptive pressure control, which is what we know as dual mode. We always refer to it as dual mode, like the PRVC, volume control plus. In this modes of ventilation, we set a target tidal volume. The ventilator will deliver the breath based on that set tidal volume. The pressure will be adjusted up and down to deliver the volume. It is a very good, and it's a very good, smart option, but we have to be safe in the alarms that we put in our ventilator. Why? Because, for example, if the patient took a very big breath during asynchrony or a trial to take more breath than what we are delivering, the ventilator will be like, oh wow, the patient's doing really well. And the next breath will have less pressure, leading to more work of breathing. So we have to be careful with the minute ventilation alarm and the pressure alarm. When the compliance decrease, the ventilator will see low tidal volume exhaled and the pressure will be high, could lead to barotrauma, but we will be safe with the limits that we put and the alarms that we put to avoid that. Airway pressure release ventilation, we will go over it again in the workshop tomorrow. It's an inverse ratio ventilation for patients with ARDS. We have high pressure, low pressure, time at the high, time at the low, and the patient will be breathing spontaneously at the time high. Here we can see how can we adjust blood gases in the APRB mode. If we have low oxygen, we increase airway pressure by increasing the pressure high and the time high or both, or decreasing the T low because we cannot set PEEP in that mode, but we will increase the intrinsic PEEP to improve oxygenation. If the VO2 is high, we will go down with the oxygen or go down with the pressure. If the CO2 is high, we will increase the pressure high for better recruitment, or decrease the time high to increase the frequency of going from time high to time low. It will be mimicking to increasing the respiratory rate, so it will wash out more CO2. We can also increase the time low, so it will give more time to wash out CO2. If the CO2 is low, we will increase the P high or decrease the T low. PAV, it's one of the very smart mode. It is a pressure support, but it can control the pressure level delivered to the patient. So we will not be responsible for choosing the pressure. The ventilator will calculate the needed pressure by monitoring volume and flow and calculating resistance and compliance. What we have to decide, what percentage of support do we want to provide based out of the total pressure that the patient needs. This is what we said. The ventilator will do the rest and will improve the synchrony. NAVA is a very, very smart mode. It's even superior to the pressure support mode in the synchrony. Why? Because it's synchronized with the diaphragm movement. There is a catheter that measures the diaphragm movement, cycles, maintain and trigger cycles and maintain the breath based on the movement of the diaphragm and based on the patient's needs. So best synchrony is in NAVA. Adaptive support ventilation, when I see this mode, I think I need to quit the job because it does everything for us, theoretically. It can measure the work of breathing, measure the delivered volume, measure the pressure that should be given and adjust it also. It can adjust the respiratory rate. All what we need to do is to give them what percent of minute volume we want to provide and what's the ideal body weight. And this mode will be moving from pressure control to SIMV to pressure support based on patient needs. So it will be going all over that and even adjust for oxygenation and ventilation. So this is a very, very smart mode, and tomorrow we will also explore it more in the workshop. And here we see that where is the target and where are we and how the ventilator changed the rate and the pressure to meet the target. Last mode, I promise, high frequency ventilation. The high frequency ventilation delivered very small tidal volume with very high rate. There are many types of high frequency ventilation, but the most common one is the high frequency oscillatory ventilation. How do we manage these? In this mode, to improve oxygenation, we increase the mean airway pressure or FiO2, or increase bias flow. So if we have an oxygenation problem, similar to conventional, increase mean airway pressure, increase FiO2. If we have problem in the ventilation, the best and most important way is to increase the amplitude because it mimics the concept of tidal volume. So amplitude is our first choice. Follow that is decreasing the frequency, not like the conventional. Why? Because we will have slower movement, more time for gas exchange, little bit more time for alveolar expansion. One of the mentioned strategies, but it's rarely used, is to increase the inspiratory time percent to 50%. So instead of ratio 1:2, it will be 1:1, giving more time for gas exchange by recruiting the alveoli. And last resource is to introduce endotracheal cuff leak to reduce the CO2 buildup. These are the key points. I tried to keep you with the rhythm and save time. The most important 2 key points from this slide: read about the SIMB, read the article about the evidence about it in weaning. Try to avoid using it if you are convinced with the evidence. That's all what I can say about it. And the high frequency is used in neonatal. The evidence does not support its use in adults. Thank you for listening.
Thank you, Dr. Shog. Dr. Shog, thank you very much. Good job. Actually, this chapter is authored by Dr. Ghazi Al-Otaibi. Many of you know him. However, he has some type of surgery recently, so he's not able to join us. So he gave me 2 names and 1 name from Jeddah. He said any of those can do a superb job. So we can't do anything, so we flipped a coin, and it came to be Dr. Shog, who did a superb job. Thank you. All the slides as his and everything. Thank you.
شكرا دكتور حسن يعطيكم العافية. Now I'm pleased to introduce our final speaker, Dr. Brady Scott, who is an associate professor and a program director at the Respiratory Care Program at the Rush University in Chicago. Dr. Scott has been a respiratory therapist over 20 years with extensive experience in adult emergency and critical care and critical respiratory care. Please join me in welcoming Dr. Scott in his presentation, Advanced Patient Monitoring and Waveform Analysis.
Thank you. You can hear me? Good? Good to see you again. It's been a while. So Hassan, I'm not sure what I did to make you mad, but to make me follow Dr. Hess and Dr. Shog, I'm not sure how I deserve that. That was 2 excellent presentations to follow. Oh yeah, I forgot Dr. Sullivan too, so she reminded me I was there too. So I'm not sure why I made you mad, but you know I got to follow those great speakers. So good to see you again. Looking forward to tomorrow where we get to do some of this stuff hands-on. So we've actually been practicing and planning for tomorrow. So we're going to go over some things, of course, rather briefly. So what we hope is to create some dialogue tomorrow if anything comes up as questions. That way we can get everything answered. So I'm not going to read this. This is out of the textbook. We're going to talk a little bit about some things you probably know a little bit about. As I was speaking with my colleagues earlier, I think in some of the ways when we talk about transcutaneous monitoring, pulse oximetry, capnography, not only do we talk about what it does do, we should talk about what it does not do. I think we need to know those equally. Oh, now I'm hitting the wrong button. I was flipping with this light here. So, all right. So first of all, let's start with the reality that we monitor patients all the time. All of our patients are being monitored. We know that the power of just walking in somebody's room can tell us a lot. I know Dr. Sullivan here is a trauma surgeon. I know that she's probably a complete expert from the time the patient hits the door to the time they park. We're moving the patient over to our bed, that we can tell so much about what's going on with the mental status and those things. And I kind of pride myself in that skill too. You know, the first few seconds that a patient enters the room, you can just tell so much. Or when you walk into a patient's room, you can tell so much. And though I asked you to raise your hand earlier this morning, there's not a whole lot of neonatal pediatric respiratory therapists in here. But in those years that I spend in the emergency room, I used to say the scariest sound I would hear when somebody would call me emergently to a pediatric patient's room was silence. Right, when I got close to a pediatric patient's room and everybody it was an emergency, I wanted to hear the cry. I wanted to hear that because that was telling me the airway was intact. So I would get more nervous. But it was part of making the assessment. And so again, the monitoring begins with observation, and we know that it tells us a lot, again, mental status and just looking at the patient. But we also have tools. If there's anything, actually earlier today, a young person was asking me about what do I like about the field of respiratory therapy. I love the physiology and I love the technology, and I like combining those because I'm a bit of a technology person myself. And we know that we have the ability to monitor things invasively, of course, with our arterial blood gases and those things, but we also have the ability to monitor them non-invasively. And so I have a particular interest in non-invasive ventilation, or not non-invasive ventilation, Dean, I just went to your talk, non-invasive monitoring, because I'm very interested in the accuracy. Because I'm afraid that if we don't really think about the accuracy and inaccuracy, then we're going to apply the wrong therapy to the patient. We'll talk about that more in just a second. And another thing we're going to do a lot tomorrow is we're going to talk about lung mechanics. We're going to talk about why observing lung mechanics and tracking them over time is going to help us watch our patient develop. Either they're getting worse or getting better, so we can relay that to the physicians and other members of the team to make the appropriate action. And again, and I will tell you that we're going to talk a little bit about scalars, so I'm following Dr. Shog's presentation here. We're going to talk about this, and if there's anybody in the room who's like me that maybe early in your career in ventilator graphics aren't your strongest suit, hopefully we can move that just a little bit farther today and tomorrow to make this a little stronger. I'll admit that I'm of the generation of respiratory therapists that many of the ventilators that I trained on did not have graphics. There were no graphics packages at all. And quite honestly, the ones that did have them, nobody who knew how to tell me what they said. So they would say, here are vent graphics, and they would turn them to the numbers, and we would write all the numbers down. We didn't know what to do with them anyway. So I actually learned ventilator graphics more through my career after I got out of school than probably I did while I was in school initially. All right, so let's talk about some of the monitoring. So we know we have things like the Glasgow Coma Scale, where we can report to our physician colleagues about the patient, whether or not they're talking to us or their eyes are open, they're responding to pain and those type of things. It gives us a lot of quantitative information or pseudo-quantitative information that we can try to make some decisions on regarding things like head injury or whatever. We know a patient's facial expressions can tell us a lot, or the lack thereof. So it could be the facial expression that's obvious. Somebody's in a tremendous amount of pain or distress, or something doesn't add up at the same time. And none of these things, or well, not to say none of these things, but facial expressions alone is not good enough to tell you that, yes, this is exactly what's happening. But it does give you some information. And we know that things like tachypnea and bradypnea, it's what that tells us. What does it tell us? Not sure. It could, tachypnea could be because there's anxiety. It could be because there's hypoxemia. It could be a metabolic derangement. But it tells you that something's off. And we know that in reality, monitoring respiratory rate, let's be honest, is probably one of the most important things we can do. It's also one of the worst things that we do. This has been well documented, as a matter of fact, that we actually don't give respiratory rate enough, for lack of better words, enough love as a vital sign. We underappreciate it in some cases. There's a lot of reasons why. One reason is because in reality, to measure a respiratory rate, we all should really sit there and measure it, count it for 1 minute. And everybody in this room, or most of you, would probably admit that's a really long 1 minute. Because you get about to second 39 and somebody tells you that you look just like their grandson. Or you're like, okay, now we're starting over, right? But we know that what we really should be looking more at the respiratory rate because it's very indicative of things to come. So we should talk about that a little bit in a bit. Bradypnea also could be an issue. Pursed lip breathing, this is a group of respiratory therapists, and there were some images earlier about with tripoding that was on the screen, or pursed lip breathing can give an indication of somebody with maybe some obstructive lung disease. Retractions, talked a little bit early this morning about accessory muscle use and what this might mean. We have accessory muscles of inspiration, accessory muscles of expiration. All those things, we know that irregular breathing patterns, the Cheyne Stokes that was mentioned earlier, could be indicative of several different things. Cyanosis, diaphoresis also gives us a ton of information. But if you think about it, if I said, what does diaphoresis mean? It's hard to say any one thing. It just all adds up together for us to relay this as part of a bigger picture and that we can report to our physician team and help make decisions. In terms of some of the things that are out of the book, there's, I think my colleague Keith Lamb mentioned today, we have certain kind of ways to follow folks in the hospital, like the sedation scale. Here, like for example, a patient with a 0 or of a RAS, which is the Richmond Agitation Sedation Scale, would be alert and calm. A -1, I think Mr. Lamb mentioned earlier, that may be ideal in some cases where the patient's not fully alert but has some sustained awakening to voice. So you say something and they wake up, or they may go back to sleep. This is a nice state to be in some cases in the ICU. Let's shift it a little bit. I'm jumping around kind of in the way that the chapter goes, and it goes in order, but it is sort of jumps a bit. It's not exactly a logical flow, so bear with me as best you can. Let's talk about pulse oximetry for a moment. Tomorrow I'm going to challenge you with this question. What does it do? We all know. It helps us monitor oxygen. It's non-invasive, gives us a lot of information. I'm also going to ask you what it doesn't do. What's its limitation? When do we question it? When does it not help us? Maybe it makes us feel too overconfident. I think those are equal things to ask, right? We got to think about, it's indicated when somebody has oxygen therapy or when we're coming in to try to understand what's going on with them. And, new pulse oximeters do give us information about other things, abnormal hemoglobins and so on and so forth. But again, while yes, there's a lot of great technology out there that gives us a lot of information, I think it's important for us for non-invasive monitors to always think about where perhaps might it be giving us information that we have to at least check, right, to verify against a more gold standard measure. For example, we know that pulse oximetry might be, vascular dyes or some kinds of dark nail polishes or these nails that are difficult for the light to get through. And it's something that we've been looking more and more at, although it's not new, that skin tone might be giving us some abnormalities that are, in some cases, in darker skin pigmented folks, could be giving us what's called occult hypoxemia, which is an abnormally high SpO2 based on what compared to what their actual SaO2 is on the blood gas. More work is being done. I will tell you there's a very large effort right now on an international scale to try to understand this better. Lots of research, including my own team, researching this. But we have to be thinking about when is it possible that when we put a pulse ox on someone, in reality it's falsely elevated, and what that might mean for us clinically. Again, I think I have a room full of mostly respiratory clinicians. We do have the one nurse that's here, so thank you. I didn't see your hand earlier, but whoever you are, thank you for being here. Different kinds of pulse oximeters. And is this good or bad, right? There's all kinds. I know that in the U.S., I can get a pulse ox at a pharmacy. I can get them online. I can get them on Amazon for very cheap. My old Samsung, so I'm an Android person, and I know my friends make fun of me. They say I should use Apple. So I hear you. You can make fun of me later at coffee. But my old cell phone used to have a pulse ox. And the question is, are they accurate? Have they been tested? What do we do with the information on a cell phone pulse ox? And I think that we got a way to go on that. Some of them, yeah, sure, it gives you some things. But what do we do with that if you had a patient with pulmonary hypertension? Would you trust it? And that's the question. We can talk about that in a bit too, or more tomorrow. We have other ways of monitoring our patients that are the transcutaneous ways, where you can measure PaO2, PaCO2 as they diffuse through the skin. I don't work in neonatal pediatrics, but I'm told by my expert friends that this is very common in neonatal pediatrics. I have used this of transcutaneous monitoring in the setting of adult acute care. Used it on while somebody's on non-invasive ventilation before. And in the old days, Dr. Shog just mentioned the oscillator. So I came from a hospital where oscillator was very big until 2013, where the oscillate and oscillate trial said no. But we used to even sometimes use transcutaneous monitor on that to at least monitor trending values in things like CO2 to reduce the amount of arterial blood gases and so on and so forth. And those monitors are available at the bedside. Again, my pediatric expert friends have suggested to me in the past, and in my own practice, we've at least have to draw blood gases occasionally to see kind of what relationship we have in those numbers as we're using these as trending values. Capnography is something I'm personally much more familiar with at the bedside as an adult practicing respiratory therapist. And we know that that's a non-invasive way to monitor exhaled CO2. And the capnogram is displayed. And we have a picture of this coming up in just a second. And you look at it, and you can find waveform. And particularly, I'll be honest, I like a waveform. I like the numeric displays together. Personally, that's my preference because I can understand how to interpret end tidal. And for those of you that have used end tidal before, sometimes the numbers do just like the textbook says. We have hypoventilation, the numbers go up. And then sometimes when somebody is really not breathing well, the numbers all over the place, and it's hard to see. And that waveform really gives you that information that you need to say, hey, Dr. Sullivan, I think we've oversedated this patient during procedural sedation. What are we going to do? Right? The number sometimes is, you got to be careful with that. I'm not saying anything negative about it. I'm saying this is what we have to do with all non-invasive monitors. We have to know what it does and what it doesn't do, right? Or how to use it. And we know that capnometry and the ability to monitor carbon dioxide has been very beneficial as ways to check for artificial airway placement that was Dr. Sullivan mentioned. Even the effectiveness of CPR when we're looking at return to spontaneous circulation. Well, we have a jump from a number that goes much higher that would suggest that we have some perfusion to the lungs, right? Gas exchange might be better. And monitor mechanical ventilation in some cases like disease severity. There's going to be a question here tomorrow. On this one, I'm just kidding. There's no questions from me. But we know that this is like the classic example of the end tidal waveform where we're looking at here and this information this tells us a lot of things, right? When the patient's breathing out and our end tidal values here. And again, how nice is it when we can use it to monitor and watch this either trail off or come back or 1 to 1 to 1, especially like I know we have an ED physician in here. I spent so many years of my career, I feel like I was only an ED RT sometimes. But during procedural sedation, this was so nice because the ED doc would sedate the patient. We could monitor the respiratory rate, monitor the patient's breathing in addition to pulse oximetry, right? You would add it to pulse oximetry to watch the patient breathe. And it was a much more, it improved our confidence during some of those procedures. Again, classic device here, at the bedside here where you have a nice SpO2 monitor, a readout, 100% oxygen, fine. But you would know I have a room full of RTs, 100% oxygen, not sure what that means, right? It's because you're on a non-rebreather, but you're still only breathing 6 times a minute. I don't really know what your pH is. I don't know what your CO2 value at this point in time is. But you can see here, again, the waveform comes up and tells you, here you go, and your end tidal is hanging around 39 millimeters of mercury here, which would be in the normal ranges. And these smaller ones here help us establish, this could be for transport or during CPR, or those type of things, or when the endotracheal tube is just placed for us to monitor, 1, the breath, and 2, the end tidal value itself. No waveform, but you do have a numerical display. Smaller, more portable, easier to use for different things. And then I think Dr. Sullivan mentioned the colorimetric device. I think most of us that have intubated before, we've seen these devices very useful. For the most part, they work over a few different breaths, but it does help us to we add it together to make sure that the tube's in the right place, right? So yes, we have CO2, we have the color change. The doctor said, or the RT, whoever's intubating, yes, I saw the tube go through. Now we sometimes have the video laryngoscopes where you're like, yes, the tube went through, we all see it, or no, you didn't see it go through because we can see it's not through. You have the breath sounds over the stomach, you have the breath sounds over the right and left lung in addition to this. So this adds to the confidence that we have that the endotracheal tube has been placed. All right, so let's now switch a little bit. Now, again, following the chapter a bit. Moving to respiratory mechanics. And we are going to spend quite a bit of time with this tomorrow. This is going to be a little bit of a focus tomorrow of our hands-on workshop, and hope you get something out of it. And these are measured or calculated values during mechanical ventilation. It helps us understand lung, chest wall stiffness, or compliance. I said stiffness automatically. You know, sometimes you're not, sometimes it's normal, right? The need for therapeutic intervention or the resolution of pulmonary injury. I got to speed up. Includes compliance, resistance, and those things. Again, we're going to spend a lot of time with this tomorrow. So tomorrow, you're going to see this. We're going to put this up on the screen, and we're going to say, here's your peak, here's your plat, here's your tidal volume. What's the compliance? Did the airway resistance go up? Did it go down? What does that mean? How do we treat this? And we're going to talk about this. And I hope tomorrow, if you really don't understand, I don't know what I'm looking at, raise your hand, whisper it to me. We'll make sure it's clear. I promise. That's what we're here for, is to make sure this is clear to everybody tomorrow, okay? All right, static lung compliance. When I say static, what does it mean? No movement. Right? Static lung compliance when we're taking a breath. We're thinking tidal volume and plateau pressure minus P. Airway resistance. This is the dynamic measure. Both of these things we can monitor, we can track over time. And then we can report to the team on rounds or team whenever it is to say these are the changes that are happening over time. Even if they're normal, we can watch the trending values as they're becoming abnormal. All right? Scalars, pressure, volume, flow versus time. Loops, not going to cover here today, and helps us even identify modes of ventilation. I'm not telling the instructors to do this in the room, but I have a friend of mine who teaches mechanical ventilation back at his school, at his university, and I don't do this, but when he has his students learn how to do a vent assessment, a vent check, he puts tape over top of the ventilator, and they have to do the whole thing on the graphics alone. So I'm not telling you to do that, but it sounds kind of fun, right? So unless you don't know what graphics are, then that's not a lot of fun. All right, so the first thing I had to do when I saw this, because I didn't write this chapter, is I had to orient myself to this slide. I'm used to seeing the pressure time scalar up top. I'm used to seeing the flow in the middle and the volume at the bottom. Well, guess what? Here's the pressure. So I will tell you, when I opened up this chapter to help make these slides, I had to stare at this for a second. And I thought, I'm not sure what I'm looking at here. And I had to talk myself into this for a minute. I'm like, oh, now I see it. But look, we have pressure, we have time here. This is the volume, and this is volume control. And I know it's volume control. I can tell you why I know it's volume control from a mile away or kilometer away. Sorry, I'm not in the States. I have a square flow waveform pattern. That only exists on one mode of mechanical ventilation. That only exists in volume control. You can only change that in volume control. And I have the corresponding, the pressure graphic that ascends over time, just like the pressure inside of a balloon goes up over time as you add volume. So you can even see just that fast, we can determine that what mode of mechanical ventilation we're in. We can see the amount of pressure that it's here. We can see the actual flow rate that's here. And then we can see the volume it's here and whether or not it came back out. So much information comes from the graphics that you can look from a mile away and have it tell, a kilometer away, and we can see what it is. Pressure controlled mechanical ventilation, again, same orientation. Pressure, flow, volume. Pressure waveforms, pressure time scalars are what shape always? Always. They're square. There's no other version of that. Pressure support, pressure control, APRV, and guess what? PRVC, those of you that say it's volume control, it's not. It's pressure control. You know how I know? The graphics tell me. The graphics tell me that it's a pressure controlled breath, right? It is, am I right, Dr. Shog? Am I correct about that? Thank you. So pressure, we got pressure over time. And so this information in this descending flow waveform pattern is always descending flow waveform pattern. You can't change it. It's physics. Physics will determine this. It's pressure gradients coming together. It's always that shape. And so tomorrow we're going to emphasize, my friend Akil, Keith and I, we're going to emphasize tomorrow knowing what normal looks like. That way when we talk about dysynchronies, that you're going to know what abnormal looks like. But you have to know what normal looks like first. Like this one, tomorrow, we're going to be able to, as soon as I turn it on there, you go, look, there's two different breaths here. I have a square flow waveform pattern. Brady said that must be volume. I have this decelerating. This is pressure support. I have SI and V and pressure support. Two different breath assignments right here. All right? 2 minutes to talk about dysynchrony. The world of asynchrony in 2 minutes. You ready? So, Sometimes you get called to the bedside because the patient doesn't look right. The patient's just looking funny. The options for us tomorrow are not going to be to sedate. We can't say turn up the sedation tomorrow. We can't say increase the pain control. What we're going to do is, what we're going to say is this: what mode are we in? We're going to say, now we've flipped back over to pressure time being here, flow time being here, volume time being here. And just this quick, I can say, well, this is a square flow pattern, so I must be in volume control. The patient looks uncomfortable. And I will say, well, are they having trouble turning the breath on? You're like, no, they didn't having trouble turning the breath on. The breath turns on here, and they get a breath. And the breath turned on here, and they get a breath. And then I'm going to say this: did they have a problem getting the breath in the middle of it? Was there a problem in the middle of the breath, or did they have a problem turning the breath off? And I think you're going to go, I think they had a problem in the middle of the breath. I'm going to say yes, and then what's your mode? You're going to say volume control and say, what happens in the middle? You're going to say, I think this is a flow problem. When it's a flow problem, guess where you don't look? You don't look where you assign the flow. You assign to the flow. You assign to the volume. The ventilator is just doing what it's doing. The variable, pressure. The scoop out, classic example of flow to synchrony. All right? This is also the classic example of air trapping, right? You know, respiratory therapy, we started as inhalation therapists. Did we not care about exhalation? We care so much now, right? So look, we're going to let the breath come out, and then it should go all the way out. If it doesn't, that's air trapping. When we're looking at auto PEEP, we think more pressure, fine. But you can also look right here on the flow. The flow should come back. It should come back to baseline. That's where air trapping would be noted. And what in my opinion is the easiest one is the leak. One, you can usually hear it, right? You walk into the room and you can hear the patient talking to you, so you know it's a leak, right? You're like, oh, they're singing with an endotracheal tube in, right? But I got about 30 seconds, and then we go to coffee break, right? So I know Hassan's going to be like, don't go over. He's my boss. We got two things. We got one thing to consider. In a ventilator circuit, what goes in should come out. If it goes in, it should come out. If it didn't, they're talking to you, we have a leak. You can see quantitatively the tidal volume here in, the inspired tidal volume, about 600. Exhale tidal volume, 428, right? That's nice, but I didn't need that. Let's be honest, when we leave here tomorrow, let's say we don't need it anymore. I can look right here, right? You can see the difference. What was going in was going out. Here, what went in, some of it came out. The rest of it was them singing a song to you, right? All right, that is my time, I do believe, Hassan. And so looking forward to seeing you all tomorrow. Again, thanks for having me.
Thank you very much.
And if you have any questions tomorrow, we'll talk about them.
Thank you very much, Scott, to keep us all engaged on your lecture. Thank you very much for keep us all engaged on your lecture. Tomorrow we'll see you from 1 kilometer away.
Brady, it's not an arbitrary that you are at this time to keep the people awake. So thank you very much. Now, I want to reiterate, very important, that we have about, actually not a break, 10 minutes. When you hear the bell, please come back. We need to come on time and finish on time. So it's really not a break per se, but just a refresher. Thank you.
Assalamu alaikum. We came to the last, but not least, session, and I thought it will be interested. We'll start by Dr. Dean Hess. We met him here in Riyadh 15 years ago, and now we met him again. I would like to welcome him again in Saudi Arabia and other guests. Dr. Dean Hess, well-known respiratory clinician and chief editor, over 50 years of good and excellent reputation, and he will speak today regarding the lung protection ventilation approach in virus disease. Please welcome Dr. Dean Hess.
Correctly this time. So you all have a pre-post test. My pre-post test is whether I can remember how to turn on the mic and whether I can use the slide advancer and pointer correctly. So in this presentation, I will talk about lung protective ventilation, and I will talk about how we can set the ventilator in a lung protective manner. This has evolved a lot just over the last 20 or 25 years. Early in my career, we thought about how we could set the ventilator to normalize the patient's blood gases. But now we think about how we can set the ventilator so that we do not induce any further injury to the lungs. And that's what I'll be talking with you about this afternoon. So let's talk about setting the ventilator from the perspective of the tidal volume, rate, and inspiratory time that we set. First and foremost, when initiating mechanical ventilation, we want to target a tidal volume of about 6 mLs per kilogram of predicted body weight. For many of our patients, that will be about 400 milliliters. So when I initiate mechanical ventilation in adults, I set the tidal volume to 400 milliliters, and then I do the math to figure out the mLs per kilogram using formulas such as these, and then I will fine-tune the tidal volume setting after that. We want to target a plateau pressure of less than 30 centimeters of water to avoid alveolar overdistension. A tidal volume of 6 mLs per kilogram with a plateau pressure less than 30 is targeted to avoid injuring the lungs due to overdistension. We want to provide an acceptable minute ventilation. That will often be around 20 to 25 breaths per minute, which we will then adjust according to the patient's arterial PCO2 and pH, and we want to use an inspiratory time of 1.5 seconds or less, and in fact, in many patients, we might want to start with an inspiratory time of about 1 second. As we think about setting FiO2 and PEEP, when we initiate mechanical ventilation, typically we will begin with 100% oxygen or an FiO2 of 1, and then we will adjust the FiO2 according to the resultant arterial oxygenation, which at the bedside we will typically monitor with pulse oximetry. A saturation of 94 to 98% is appropriate for most patients. A little bit lower saturation, like 88 to 92% in patients with COPD. In the ARDS network study, very famous study published almost 25 years ago now, they targeted an oxygen saturation of 88 to 95% in patients with ARDS, which translates into a PO2 of about 55 to 80 millimeters of mercury. I would submit to you that in all patients, when we initiate mechanical ventilation, we should apply a low level of PEEP, 5 to 8 centimeters of water. In patients with ARDS, we will need to use a higher level of PEEP in many of those patients to maintain alveolar recruitment, and we'll talk more about that later on in the presentation. PEEP might also be useful to improve triggering in patients who have auto-PEEP, such as in a patient with COPD exacerbation, where we will set PEEP to counterbalance auto-PEEP, and in that way improve the patient-ventilator interaction or improve patient-ventilator synchrony, a concept that Brady introduced right before the break. So typically when we initiate mechanical ventilation, we need to decide whether we will use a volume control or a pressure control approach to mechanical ventilation. There are advantages and disadvantages of either approach. And I would submit to you that in the hands of a skilled respiratory therapist, you could use volume control or pressure control safely based upon what is your individual preference. Another way of saying that is that I do not believe that there is sufficient evidence to suggest that one approach, volume control, versus another approach, pressure control, is clearly superior to the other. The real difference between volume control and pressure control comes when the patient generates an inspiratory effort. With volume control ventilation, if the patient generates an increased inspiratory effort, an increased respiratory muscle pressure, the tidal volume stays the same, but the airway pressure waveform changes, suggesting that the patient is not receiving sufficient flow. Brady introduced that concept right before the break. In pressure control ventilation, on the other hand, if the patient takes an increased inspiratory effort, more respiratory muscle contraction, now there will be an increase in tidal volume that is delivered, and potentially that tidal volume might be excessive, and it's possible due to the patient making strong inspiratory efforts, that excessive tidal volume could result in lung injury. Something called self-induced lung injury or patient self-induced lung injury. Hold on to that term. We will come back and talk about it more later on in the presentation. If our patient has a spontaneous respiratory rate, a spontaneous inspiratory effort, often we will use pressure support ventilation. With pressure support ventilation, the patient triggers every breath. The breath cycles from inspiration to expiration based upon patient's effort and respiratory mechanics. I won't go into a lot of detail about that except to point out that during pressure support, we can adjust the rise time, a fast rise time, as is shown here, where the pressure increases very quickly. That delivers a lot of flow to the patient, as opposed to a slow rise time where the pressure goes up more slowly and there's less flow that is made available to the patient. So if you have a patient on pressure support who is tachypnic and needs a lot of inspiratory flow, you might set a faster rise time. We can also adjust the flow at which the ventilator cycles from the inspiratory phase to the expiratory phase. So we can set that to a low fraction of the peak inspiratory flow, 10% in this case, or we can set the cycle to a high fraction of the, okay, I failed the test. Or we can set the cycle to a high fraction of the inspiratory flow, in this case 50%, and in that way we can adjust the inspiratory time. So notice that the inspiratory time here at a 10% cycle is longer than the inspiratory time here with a 50% cycle. So if we have a patient who's on pressure support, who is asynchronous, who is double triggering the ventilator, we might use a higher cycle so that we shorten the inspiratory time. So a little bit about breath trigger. So the trigger can be the ventilator or it can be patient effort. So if we set the ventilator rate to 20 breaths per minute, every 3 seconds the ventilator will deliver a breath, even if the patient's paralyzed. But if our patient is making inspiratory efforts, the ventilator can recognize that inspiratory effort either as the result of a pressure drop below baseline or a flow increase at the proximal endotracheal tube. So we can have pressure triggering or flow triggering. Years ago, early in my career, pressure triggers were not good because the pressure sensors in the ventilators were not good. And how manufacturers got around that issue 25 or 30 years ago was they introduced flow triggers. So when flow triggering first became available, it was far superior to pressure triggering. But on modern ventilators, probably doesn't make that much difference. And in fact, in modern ventilators, the triggers are so good that sometimes an asynchrony that we see at the bedside is auto-triggering, where the ventilator triggers due to some artifact, which could even be enough of a pressure or a flow change at the proximal airway from the heart beating against the lungs, triggering the ventilator, which I've seen numerous times in my career after ventilators were introduced with better triggers. Now, Brady introduced the concept of plateau pressure. So here we're looking at volume-controlled ventilation with a constant inspiratory flow. During inspiration, the pressure rises from the baseline pressure of PEEP up to the peak inspiratory pressure. Then if we apply an end inspiratory breath hold with no flow, the pressure drops from the peak pressure down to the plateau pressure. We call it the plateau pressure because that's what it looks like, a plateau in the airway pressure waveform. The difference between the peak and the plateau is determined by airways resistance and flow. I suspect that Brady will tell you how you can use that difference to calculate airways resistance in his workshop tomorrow. The difference between plateau pressure and PEEP is determined by compliance and tidal volume. So if we lower the tidal volume, that lowers the plateau pressure, we get more airway protection. The difference between the plateau pressure and the PEEP is what we also refer to as the driving pressure, delta P. And recently, within the last 10 years, it was shown that the driving pressure, the difference between plateau pressure and PEEP, is an important determinant of lung injury during mechanical ventilation. So that then if we are to apply a lung protective ventilation pattern, we want to apply not only a plateau pressure of less than 30 centimeters of water, but we want to monitor the driving pressure, the delta P, and maintain that to less than 15 centimeters of water and as low as possible. And in fact, there is evidence to suggest that a driving pressure greater than 15 centimeters of water increases the likelihood of mortality, the patient dying on the ventilator. Now, when we think about how we set the ventilator and the volumes and the pressures that are delivered, we need to think not only about the lungs, but we also need to think about the chest wall around the lungs and the pressure in the pleural space between the chest wall and the lungs. If there is a restrictive chest wall, a stiff chest wall, that will result in an increase in the intrapleural pressure. How might your patient have a restrictive chest wall, a stiff chest wall? Well, with morbid obesity, with abdominal hypertension, for example, chest wall burns. So in the case of a stiff chest wall, a restrictive chest wall, there is a high intrapleural pressure, and in this case, we need to use a higher level of PEEP to prevent alveolar collapse, because the high pleural pressure will be a collapsing effect on the lungs, inducing atelectasis. So if you have an intubated, mechanically ventilated patient who is morbidly obese, you should be using higher levels of PEEP to counterbalance the effects of the chest wall and the pleural pressure. Moreover, in that same patient, a higher plateau pressure may be safe, because what induces injury is the difference between the plateau pressure, which is the alveolar pressure, and the pleural pressure, the pressure outside the lungs. So then with a stiff chest wall restriction, we need to apply higher levels of PEEP, and higher plateau pressures may be safe. So in this example, a plateau pressure of 38 centimeters of water might be safe because of the high pleural pressure, which is pushing in against that alveolar plateau pressure. So then a question that I might ask, I'm pretty sure this is not a question on your exam, but a question I might ask is, when is it safe to break the rules and apply a plateau pressure less than 30 centimeters of water? And the correct answer would be in the setting of a restrictive chest wall that drives up the intrapleural pressure. If we wanted to be real fancy, we could actually put in an esophageal balloon catheter, and we could measure the intrapleural pressure, and we could titrate the ventilator settings accordingly. That's outside the scope of my lecture this afternoon. So then we need to think about not only how much pressure the ventilator is applying to the inside of the lungs, but we need to think about the pressure in the pleural space outside the lungs. So if there's a high pressure in the pleural space, then we might need to use higher levels of PEEP and accept higher plateau pressures. If there are very low pressures in the pleural space, then that applies a greater distending pressure to the lungs, and that might be injurious. So how can we apply a negative intrapleural pressure while we are applying mechanical ventilation? Well, how that can occur is by the patient making a strong inspiratory effort. And that's what I'm trying to illustrate with these arrows. So patient makes a strong inspiratory effort, that pulls out on the thorax, that decreases the intrapleural pressure, and now the distending pressure across the lungs, the potential for injury to the lungs, is the pressure inside the lungs minus the pressure outside the lungs. So this will induce a greater likelihood of ventilator-induced lung injury. So our patient may be on a pressure support of 15 centimeters of water, and you would think, how could that not be lung protective? A pressure support of only 15, how could that harm the lungs? Well, that could harm the lungs if the patient is making a strong inspiratory effort, causing greater alveolar distension while the ventilator is applying positive pressure. So then when we think about the potential for lung injury, we not only need to think about how much pressure and volume we add from the ventilator, we also need to think about what is the pressure in the pleural space outside the lungs. If that pressure is high, like with obesity, that could be lung protective. But if that pressure is low because your patient's making strong inspiratory effort, that could be injurious. So this is what we call then patient self-inflicted lung injury, a concept that was introduced into the literature only within the last 10 years or so. The idea that the patient's inspiratory efforts could be injurious. So maybe we should not be thinking about ventilator-induced lung injury. Maybe we should be thinking about ventilation-induced lung injury, because high distending pressures due to the patient's ventilation efforts might be injurious. So how might we assess that at the bedside? Well, there are a couple of techniques that have just been described in the literature, maybe only in the last 5 years or so. One is if we have a patient on pressure support ventilation and we do an end inspiratory pause, as we had talked about before, but we're now on pressure support ventilation, not volume control ventilation. If you do an end inspiratory breath hold during pressure control, and you see that there's an increase in airway pressure, that is suggestive that the patient is making strong inspiratory efforts. So you need to think about patient self-induced lung injury. You can also look at the airway flow graphic drawing pressure support, the dashed line, it would be what you should expect to see. If you see this downward concavity in the flow waveform, that suggests that the patient has a strong inspiratory effort, and that might be contributing to patient self-inflicted lung injury.
5 minutes, please.
So I'm going to have to, I guess I can't ask for the time back that I had from the last talk. I'll try to wrap it up in the next 5 minutes. We can also measure the alveolar pressure at the end of exhalation by doing an end expiratory pause. If we see an increase in pressure during an end expiratory pause, that is auto-PEEP. That can be due to a short expiratory time, a high minute ventilation, high rate or tidal volume, high airways resistance, such as with COPD. That will drive up the plateau pressure, and it will make triggering more difficult, which we tend to see in patients with COPD. So just a little bit about PEEP for lung protection. So we use PEEP in patients with ARDS to avoid closure of alveoli during exhalation and then popping those alveoli open during inspiration. So repetitive opening and closing injury. There is a lot of controversy about the best way to set PEEP. One of the things that was popular a few years ago, and is still popular some places, is an open lung approach that has tended to fall out of favor because it really hasn't been shown that it improves patient outcomes. A common way to titrate PEEP is to use the PEEP FiO2 tables that were described in the ARDS network studies. So if you like lower levels of PEEP or your patient is less ill, you can use the lower PEEP FiO2 combinations. If your patient is more ill, more severe ARDS, you can use the high PEEP, lower FiO2 combinations. And the idea here is that we use combinations of FiO2 and PEEP to keep the oxygenation in a target range of 88 to 95% saturation. Another term that has recently been introduced into the literature is diaphragm protective ventilation. So we need to think when we're setting the ventilator about how we can avoid injury, not just to the lungs, but also to the respiratory muscles. And it has been shown that either too little support, which can result in atrophy, or too much support, either too much support, which can lead to atrophy, or too little support, where there are excessive respiratory efforts, can lead to poorer outcomes due to either atrophy or respiratory muscle injury. So we need to get it just right. We need to get it in the sweet spot because too little or too much support can result in injury to respiratory muscles. I probably didn't explain that very well, so sorry about that if I bumbled it. I think with asynchrony, I can, in the interest of time, I can skip this in your chapter. This is discussed in some detail, and I believe that Brady and Keith are going to talk about that in the workshop tomorrow. So I'll reserve that for them in the interest of time. Oxygen toxicity is, I think, an important concept. We should target the FiO2 to an appropriate arterial oxygenation. We should avoid hyperoxemia. So there's no reason why we should be setting the FiO2 so that all of our patients in the ICU have an SpO2 of 100%, because that is potentially injurious and could lead to poorer patient outcomes. I think in the interest of time, I'll skip the hemodynamic compromise part. You can read about that in the textbook. So in summary, a reasonable starting tidal volume is 6 mLs per kilogram of predicted body weight. That's usually about 400 milliliters. We want to target a plateau pressure less than 30, a driving pressure less than 15, as low as possible. We want to target the FiO2 according to the arterial oxygen saturation. PEEP has both beneficial and deleterious effects. So PEEP is set to balance alveolar recruitment and overdistension. Strong inspiratory efforts can result in alveolar overdistension. patient's self-inflicted lung injury, and we talked about that in some detail. Auto-PEEP can be an issue that we should monitor in mechanically ventilated patients. We need to think not only about injury to the lungs, but also injury to the respiratory muscles. Asynchrony is an important thing to monitor and to correct at the bedside. I'll leave that to the workshop tomorrow. High FiO2 can produce oxygen toxicity, and positive pressure ventilation can have either negative or positive effects on hemodynamics. So with that, I will stop. Thank you again for your attention. A couple minutes over. This time, just remember, I was 5 minutes ahead of time on the last one.
Thank you so much, Dr. Dinhes, for your nice presentation.
Now let's welcome Professor Muhammad Al-Khatib. He's a professor of anesthesiology and pain medicine. He's also a director of Department of Respiratory Care at the American University of Beirut, where he's an academician. He published more than 150 peer-reviewed articles and abstracts and chapters. He's also a clinician.
Sorry, excuse me.
At the hospitals of the University of Beirut Medical Center. Professor Muhammad Al-Khatib will talk to us about the liberation from mechanical ventilation. Please welcome Professor Muhammad.
Thank you very much. It's really an honor to be part of this event, and thank you. It's my pleasure always to be here in Riyadh. Well, for the last two sessions, we have heard excellent lectures in topics related to invasive mechanical ventilation. Dr. Sullivan kicked it off with on how to prepare the patient, instrumentation of the airway and intubation. Dr. Hamoud talked about the modes of mechanical ventilation that are available to us. Dr. Brady, how do we monitor patient during mechanical ventilation? And just Dr. Hess talked about how do we apply or implement the strategies for preventing or protecting the lungs. Well, obviously, we're interested in getting the patient off the ventilator, right? So this is exactly what my topic is all about. I'm going to talk about liberation from mechanical ventilation. I hope for the coming 20 minutes to provide you or present to you or highlight the best evidence, practices, and guidelines on topics related to liberation from mechanical ventilation. Which one? It's not moving forward. Oh, here we go. Well, first I want to start by mentioning I have nothing to declare, no conflict of interest related to my talk. And there are several objectives related to this topic. They are presented at the beginning of the chapter in your book. So you just go over them, and hopefully we'll be able to cover them to give you a grasp about what's the current practices in the field of liberation from mechanical ventilation. Well, we all agree that liberation from mechanical ventilation is a crucial event in the care of a critically ill patient who are receiving invasive mechanical ventilation, as both premature and unnecessary delays in liberating patient from mechanical ventilation may have serious consequences, serious detrimental consequences. Keeping patient longer than the patient needs to stay on the ventilator will expose the patient to higher risk for ventilation-induced lung injury, higher risk for ventilation-associated pneumonia and ventilator-associated events. While if we do it prematurely, then we're exposing again patient to unnecessary risk. We all know that patients that will undergo more than one event of intubation don't have the same outcome in terms of patients who are not. With all the risk related to intubation and difficulties in intubation, and of course the psychological impact on both the patients and the family. So it's really of utmost importance to identify the best and most appropriate time to liberate patients from mechanical ventilation. Well, obviously, we need a starting point. We need to assess the patient readiness when the patient is ready to be liberated from mechanical ventilation. Obviously, that should start with an overall improvement in the patient condition. First, we need to see that the reason that necessitated to start this patient on mechanical ventilation is reversed. there is a resolution of this reason. Most of the time, we're talking about several types of respiratory failure, whether it's type 1 or type 2. And for this, we do use some simple and straightforward clinical metrics and variables that are available to us at the bedside, or some more advanced, integrative, and complex metrics. For example, we can use simply what's the minute ventilation of the patient, respiratory rate, or we can take an ABGs, and we think that maybe the patient is getting there. Patients are about ready. The more challenging integrative indices is one of them, one of the most famous one, is what we call the Rapid Shallow Breathing Index, or SBI, which is expressed as the ratio of respiratory rate over tidal volume expressed in liter, which is determined during the first minute of a spontaneous breathing trial. So when this threshold is compared to 105, then the patient has a high probability of being liberated successfully from mechanical ventilation. So what are these spontaneous breathing trials that we refer to them as SBTs? SBTs remain the most informative tools to help us liberating patients from mechanical ventilation. Usually these trials are maintained for anywhere from 30 minutes to 2 hours, a minimum of 30 minutes and up to 2 hours. As I said, I mean, they should start with a resolution of and reversal of respiratory failure. And of course, patients needs to be hemodynamically stable, as reflected by adequate blood pressure with no use or even some low dose of vasopressors. And of course, eventually, since we are liberating patients from the ventilator, we would expect the patient to be on low ventilator settings, right? We always in our round talk about the patient is on low respiratory ventilator setting. Usually these are reflected by the use of low levels of PEEP in the range of 5 to 8 centimeters of water and the fraction of inspired oxygen less than 50%. And of course, with an adequate respiratory rate less than 20 breaths a minute. Well, what are the forms of SBTs that are available to us? There are 3 major forms: TPs, CPAP, and pressure augmentation form. TPs used to be a very popular way of running an SBT, just basically disconnecting the patient from the ventilator and connecting a TPs, all right? So by doing so, all what we are providing to the patient is a fixed fraction of inspired oxygen. No pressure whatsoever, no tonic increase in the pressure, and no phasic increase in the pressure, all right? Well, now, this was an old technique, although I used to use it, but anyway, now with the use of modern ventilators that do a lot of monitoring for us, probably there are some advantages of running some SBTs on mechanical ventilation. One of them is the use of or the implementation of a CPAP, which stands for continuous positive airway pressure. So how it differs from TPs? It's exactly the same, but we're adding a tonic increase in the pressure. So the patient is still breathing spontaneously on her own. Fraction of inspired oxygen is fixed and stable, but now, rather than being on 0 centimeter of water, now he is on a 5, 6, whatever we decide in terms of level of pressure, continuous positive airway pressure, right? The third form is what we call a pressure augmentation. Again, we're escalating, so in a crescendo manner, right? So now we have an FiO2, we have a tonic increase in the pressure, now we're adding another phasic increase in the pressure. All right? And we have 3 different forms. A very popular, and we've heard about it so much already, which is the pressure support ventilation, right? And we all agree it's going to be around between 5 and 10 centimeters, right? Well, why 5, not 10, and what 10, not 5? Well, some argue that pressure support can do what we call electronic extubation. It's as if there is no ET tube present. So it just kind of take care of the ET tube, all right? And the patient then is on her own. And this is why, with the automatic tube compensation, if you use, it's another form of pressure augmentation, it's related to the ET tube, all right? And all it asks for you about the tube, the length, and the cross-sectional diameter. However, these are pressure support limitation is a fixed level. If you decide that you're going to apply 5, it's going to be 5. Whether the patient is doing stronger effort or a weaker effort, it's going to be 5 throughout the whole trial, all right? And the same for ATC, which is determined once and it will be maintained throughout the whole trial. However, with proportional assist ventilation and NAVA and neurally adjusted ventilatory assist, now here we're talking about a variable level of pressure support, all right? That's proportional to the patient effort, all right? So augmentation, there is a phasic change in the pressure. One way is fixed throughout, another way is having a variable pressure support level. A very important concept, when we do a trial, we always look for the outcome and you want to see a successful outcome. However, I want to caution you to start from the beginning to have an a priori criteria for failure of the trial, right? Because you have to be ready to terminate this trial the minute you feel that some variables have changed in a manner that will impact or add additional risk and complication for the patient. And that's very important to have it ahead of time. And usually it's a mix. There is no really one variable they would say the patient is failing the trial. It's basically a mix of hemodynamics, respiratory, and behavioral. So we look at the systolic blood pressure and heart rate, and particularly we don't look at absolute values, although you can, but it's rather a change from your absolute value. Because you know your patient is on the ventilator and his heart rate, let's say, is 100 beats a minute, right? So if you see like an increase to 110, although this is high, probably would say that's no really major change in the heart rate because the patient was already on 100. So usually we look at these variables in terms of percentage changes. And any changes that in the range of 20 to 25 are considered significant changes in these variables. The same we do for the respiratory rate. SpO2, if you see like a drop of less than 92% or maybe 4 to 5% if you want to look at an absolute ratio, absolute change. And of course, you look at the patient, see the patient diffusing accessory muscles, nasal flaring, agitation, anxiety, some change in the level of consciousness. So at least here you have a mix that you can look at and decide, no, I have to terminate it right now, okay? And you go back to your previous ventilator settings, and usually most of the literature will tell us, do not do it very frequently during the day. If your patient fails once, maybe you can do it 12 hours later. Maybe it's better to wait another day and do it. All right? So no need to just keep repeating it over and over. All right, so is it liberation from mechanical ventilation? Is it an art or a science? I mean, is it the gut feeling? The clinician will tell you, I think the patient's gonna do well, just go ahead and start with it. Or no, this should be based on sound scientific evidence. The literature is telling us, no, that there are really some scientific evidence for achieving successful liberation from mechanical ventilation. And for that purpose, there was development of liberation from mechanical ventilation protocols. So we do have protocols to liberate patients from mechanical ventilation. And these protocols, they have several advantages. They lead to more favorable outcomes, all right? They can shorten the duration of mechanical ventilation, shorten the patient's stay in the ICU by at least a day or 24 hours. And these protocols can be either clinician-driven, computer-driven, and the era of AI now, going to the era of AI, probably an AI algorithm will be able to help us running these protocols, all right? This is just an example of a liberation protocol. My liberation at my institution might not fit your institution and vice versa. It's just you have to consider several factors. The type of institution you're practicing in university hospital versus private practice, your environment of care, several factors come in deciding which protocol to use. In the chapters, there are a few examples. This is an old one by Neil McIntyre and colleagues. In 2012, you could see that in the early days of liberation protocol, they were so comprehensive, a lot of variables into it, and people oh my God, I have to look at all of these and make all these checks. So there have been a lot of improvement, and these are two more you can see. You can also see them, not go over them, getting shorter and shorter. So just focusing on the important component. However, whatever you decide, sedation must be part of the protocol, right? Because eventually, and some studies have shown us that being so sedated for longer than needed mainly contributes significantly to the prolongation of the patient on mechanical ventilation. To the point now, you see in the literature, I'm not going to talk about it, about inhalational sedation, using like kind of the gases we use in the OR, in the ICU to expedite, because so often patients, when they wake up, when we start to titrate their sedation, I mean, they just go crazy and they go a lot of asynchronies, agitation. So now we're talking about more some inhalational agent in the ICU. So nevertheless, sedation protocol are critical component in every single liberation protocol. And again, you must confirm that the patient is capable of initiating and maintaining spontaneous breathing activity. Usually we ask our nurse to take care of this, and we've heard a lot about the RAS score, and we kind of decide on a target RAS score. And usually this even protocolized, what kind of drugs you're using, how you want to do it, what time of the day you want to do it. Okay, another issue related to liberation is early mobilization. Dr. Hess talked about diaphragm protection and the ability to allow a patient to start spontaneous breathing early on. I mean, the same, this is a diaphragm, but we do have other muscles. We need to improve them. And when we improve work on these muscles, the overall outcome of the patient will be improved. So usually this should be initiated when patient is receiving mechanical ventilation and in stable condition. When the patient is in stable condition, fairly these protocols are safe. They can decrease to duration of mechanical ventilation. It reduces critical illness myopathy, reduces respiratory muscle atrophy, and improves the patient ability to mobilize secretion. There are several types of forms of early mobilization. A very common one, should be probably the first one to do, is to just sitting the patient in a chair or on the side of the bed, 1-3 times per week as tolerated. And then next step will be the patient moving from a sitting to a standing, and then when the patient is in a standing position, just marching in place. And some literature some research have looked at using some extremity activity and active resistance measurement by biking, like using a bicycle while sitting, and some exercise. As long as when it is really well designed and implemented, there should be no significant adverse events for these patients. All right? One time I read a letter in intensive care medicine. They brought a swimming pool for the patient in the ICU, inflatable swimming pool. He liked to swim so much, intubated patient. All right? And the patient had to take a swim in the ICU. All right. The last step, when we are sure or we are confident that the patient is getting ready to get off the mechanical ventilation, there is one final step that we need to do. And that's it, confirming that the patient has a leak, a good leak around the ET tube. So this is the last step prior to extubation. It's easy and safe, can be easily and safely done at the bedside. And basically, we're doing it to confirm the absence and presence or presence of significant laryngeal edema. And the positive leak test is less helpful than a negative leak test. So if the patient doesn't show significant amount of leak, do not attempt extubation. Now, if the patient is showing also a positive leak test, still you have to be on your toes, making sure nothing's going to go wrong, right? But with negative, you don't do it.
5 minutes.
And when you assess these leaks, you have to consider them in the context of the size of the tracheal tube, the duration of mechanical ventilation, and you ask your colleague probably who intubated the patient, how was the intubation? Was it an easy intubation? Was it tough intubation? So you have to take all these factors into consideration when extubating the patient. All right. Now, to confirm a positive cuff leak, what we need to do is we need first to deflate the cuff, fully deflate the cuff, all right? And maybe check the patient whether they can sing. I heard Brady, the patient singing. Yeah, right? Audible noise or phonate. However, we can do objective measurements. We can assess the volumes that we're measuring in and measuring out. And it was nicely seen by a graph. Usually, even I don't listen. When I look at the graph from 1 kilometer away, I can say that there is a leak. And the question the next question would be whether this is a significant leak or a non-significant leak that will kind of predict to me the chance that the patient gonna do well when I extubate and no upper airway obstruction and stridor. So the measurements are easier in absolute changes, but more the data tells us that probably it's better to look at the percentage change rather than the absolute change. All right? So most of the literature would recommend at least 10 to 24% leak, or anywhere, a loss of volume anywhere between 90 and 280 ml. But again, probably it's better set in the context, as I said, of the ET tube size and the patient condition. So probably a percentage will be a much better. Dr. Hess talked about the use of non-invasive respiratory support. There are so many patients that show us some borderline trial of SPT, and patients during an SPT trial, they showed a mild to moderate increase in the PaCO2, and you don't want to keep them on the vent. So probably the use of NIV in the immediate post-extubation period might be a good tool for us to allow this patient to go to this critical phase and ultimately succeed the outcome. Probably patient with a mild risk for post-extubation failure, a high flow nasal cannula might be helpful in this regard, but definitely patient was at higher risk and patient who showed us some CO2 retention during the SPT, a form of non-invasive ventilation will in the form of BiPAP will be valuable. So the last I want to talk about, lastly, I want to talk about a group of patients that are ventilator dependent. All right? So these are the patients that will stay for a long period of time on the vent, and we tried several of them to extubate them, but with no success. So these are the patients that we call, or maybe patients who are tracheostomized. So these are the patients that we call ventilator dependent. They will have a special and customized approach for liberating them from mechanical ventilation. You have to consider each patient as independently. You cannot just generalize. It's going to work for every of these patients. But a well-tailored approach has been shown to shorten mechanical ventilation by approximately 20 days. And usually, most of the time, it's a very slow-paced, gradual reduction in the ventilatory support. So often, for example, patients who are tracheostomized, a daily trial of a collar mask, and they maybe try to prolong the duration of the collar mask will do well for these patients. The tracheostomy, yes, just 2 more slides. The tracheostomy, we know tracheostomy, they decrease the airway resistance, allow better lung hygiene and secretion removal. It will increase patient comfort with the ability to eat and speak, and allows, as I said, for frequent SBTs, progressive, in the form of progressive collar mask trial. No protocol for these patients population, really. As I said, each patient has to be approached separately, but definitely a multidisciplinary team, physiotherapy, speech therapy, assessing eating capability, psychological support. However, whatever we do, sometimes we end up with patients that we cannot liberate from mechanical ventilation. All right, so, and these are the key concepts related to my talk that are, again, also presented at the end of the chapter. You can just go over them, and I want to thank you again for listening and staying that late. Thank you.
Thank you very much, Professor Khatib. I would like the speaker to sit. Mr. Hassan Al-Araini will make a statement.
Okay. We need your help. This is the last exercise of the day. I know this is too late, but I just need about 3 minutes. In our part of our tradition is to vote for the best booth that we have. We have 16 exhibitors, but only 6 fully fledged booths. So what I will do, I will be flipping the pictures just for a second to see. Next. Okay. Next. Al-Hamad. Next. القصيبي. Next. البيت العربي. Arabian Trade House. Next. And this is Al-Madar Rizmed. I will repeat again, and I need clapping for the one you think. Now, the one you think, the highest, the loudest clapping, meaning this will be the best booth, and they will have an appreciation from the organization. Now, what we measure really is not only the look. It's actually, I'm sure you met many of those people today. You talked the staffing, the giveaways, the chocolate, the dates, whatever, okay? So I will go back again, and I will name, and I will just hear the clapping, okay? JSK. Next. I think it's clear. Yes, clear. And I will tell you, they are the second company that actually commit to this conference. So for that, we appreciate them very, very much. Now, we thank you very much. We thank our speaker. We thank the international who are still awake. We thank every one of you. Tomorrow, extremely important, 15-minute or 7:30, let's say, let's meet here, or 20 minutes before 8. We will meet here, we will have a quick introduction, then we will head. It's actually in the same hallway that we are. You just go, as you come out of here, you go right, go all the way, and it's very clearly labeled. But you have to stop here. And when we are done, we will come back at the end of the day tomorrow, like this time, in the same place to do the post-test. Thank you, everyone. Thank you.